oncologist or us. We need to examine the patient at every cycle and do our clinical RECIST or WHO criteria and a mammography on an MRI. Anybody has any comment? Madam, even you, like what is your role? What is your take on doing an MRI versus just a mammo should be enough?
In general, mammography is enough. MRI, in patients who have been assessed in the beginning with MRI, you can assess them again with MRI. But a patient who's had only a mammogram and no MRI at the beginning should not have an MRI done later to try to assess the response.
Yeah, absolutely. I agree that it's mammography. There's a lot of Western literature coming up on doing MRI, but we are happy with mammography in dense, non-dense breast. Density grade A and B are quite safe to just evaluate on mammo again. But yes, in a denser breast, if you initially think there was an indication to do MRI for some reason, then you may do an MRI later on to assess response and to compare. Because it's a dense breast, the MRI may help you more. There is a lot of... Yes, sure. You can take the mic and tell us about it.
Ultrasound was done initially for the tumor size and all. So during the response, I think ultrasound was
A patient planning for a breast conservation should not be going ahead with only an ultrasound, because patients may have small tumors in other parts of the breast. So I think if the plan is to do a breast conservation, then a mammogram is mandatory.
No, what he's saying is for response assessment, maybe you can continue.
True, but you don't really need to do much in the middle. If you've done clinical and it's getting better, then you don't need anything beyond that, and a mammogram right at the end is enough.
Yeah, so I agree.
It doesn't
may do an
done
ultrasound, but it's
repeatedly.
not mandatory. A mammo done before and a good clinical examination suggesting that it is going down in need in size, then doing an ultrasound is not useless, but it may not be absolutely necessary. And of course, you have a lot more. I found this very fancy paper where they're fusing PET and MRI images. Looks very good, and but I wonder if it's really needed. But it looks good. I mean, like in this image, it's showing excellent response with chemo, and they've done it all throughout. And I guess not much has changed, but they're happy to see the images. So if you have this kind of situation, you have a mammo which is grade A and B density, not very dense. It's completely responded clinically, like this lady only I'm talking about, the 35-year-old that you are presenting. She has only this clip seen. We had fortunately put a clip before beginning the chemotherapy. So just to add a little bit of twist, on Saturday morning, she was 35, so she got referred to genetic clinic, and she was a BRCA1 mutation carrier. We did a baseline MRI for her, which was normal. That's the reason I have the MRI, because she was keen on conservation, and because she was BRCA mutated, we thought we will have a baseline MRI, so it helps in follow-up. And then we did a usual CA ovary workup baseline screening surveillance for that. It was normal. She was nulliparous, like I told you in the beginning. So that's an MRI picture, good response, just maybe some kind of architectural distortion there, no enhancement. So Dr. Neha and Dr. Pooja, what would your surgical plan be now? Everything is disappeared, node has disappeared, and the tumor is also disappeared.
So she is BRCA positive. I will tell her about her risk and the implication of what BRCA positive means. But BCS in BRCA positive is can be offered, and we can go ahead with breast conservation surgery if she wants. Since there's only clip available, I would have to get a wire insertion and a wire-guided incision.
Pooja, would you agree with that?
Agreed with Dr. Neha. So take out the specimen, send it for specimen mammograms, see if we've done a complete excision. And yes, we do axillary clearance for such patients. She was a heavy nodal disease to begin with, triple negative patient, and yes, genetic discussion. I'm talking to her. As you said, she's a nulliparous. So we would like to discuss that.
Yeah. So completely agree with you, both of you. Neha, just that BRCA1 came out of nowhere. We don't want to digress the day's topic to that. So I would say it was just because the report was really available, but she was keen on conservation, and like you said, it's not a contraindication. And hence we just did that MRI to begin with, so that we are also doubly sure that there's nothing else anywhere. And we localized the clip with a wire. We tried to localize it with an ultrasound, but the radiologist could not see it. Sometimes they are able to see on ultrasound also the clip, and they just give us a surface marking, but this place needed a wire. Wire-guided excision was done, a specimen mammography was done to confirm, and then she had a breast conservation surgery. And like all my surgeons said here, complete axillary clearance, N2 node 3 cm, no data till date to suggest that you can conserve this axilla. So unless we have more confidence in the N1 patients, and then eventually in N2 maybe, in exceptional responders. But as of today, we would do a complete axillary clearance in these patients. HPR was, as one would expect, pathological complete response. And what are the general issues I want to? This case was straightforward, so we are happy. Everything is gone smooth so far. But what are the issues in post-chemotherapy BCS planning? How do you assess PCR? Is there really a way to know? Because that may be a group where you may be able to avoid surgery if we are coming there in the middle of the presentation somewhere. So how would you? What are the issues that you face in day-to-day life? So the
first thing, chemotherapy-related side effects that are there. Apart from that, the proper evaluation of the patient and the patient understanding. One of the things is that whenever we see a complete response, patient convincing that they go for again surgery, that we face a lot of time. So that's the main thing that comes into effect. And again then, the wide placement dose adds to the financial burden also to the patient. So we plan it out, and that has to take into the discussion before planning the surgery.
True. And with respect to response assessment, are you happy each time or sometimes struggle?
Sometimes it's a struggle. It becomes struggling. Generally, there are downsides, so we can, where it is palpable, it's very easy. Only the one which becomes non-palpable, it becomes very difficult to assess and then traverse.
True. So however big the tumors are, if it's clear-cut on mammo and it's palpable and something like this, this is ideal. There is no downstaging is obvious. So this is probably a concentric response, but how and when do you expect like a patchy response or something like this mammo, which is there, this is pre and post. Pre on the other side and the right side is post.
Really?
But everything looks the same to me. So do you come across these situations where the assessment imaging wise, even clinically, becomes difficult?
Yes, ma'am. It does become difficult. Then the way out, whether to go for direct BCs or go for nipple sparing, those things come into discussion with the patient.
True, and I guess then we would even go with the initial stage. So we have what kind of issues in even operating. Sometimes as residents we used to struggle in operating post-chemo cases. As upfront one palpable, but I still find the residents calling me for the primary for post-chemo cases because they are wondering how to operate the same volume or the new volume, or if it's completely gone, then what to remove.
Plus, there's usually a lot of fibrosis around it, so even for someone who's newly doing it, to understand the exact palpable areas also sometimes difficult. So I think what helps is if you have, what I do a lot of times is I try to localize on tape with an ultrasound to see the exact area, correlate your previous mammography and newer mammographies, and your maybe if need repeat an ultrasound on table, and that helps, I guess.
True. And what do you, other than mammography, you think MRI could be used in these cases, especially the dense breast? Do you have any experience, any of you surgeons? We don't have a radiologist with us, but...
So, MRI for dense breast, we are already using that.
An MRI would be helpful in the initial evaluation. But the problem with localization, I mean, the MRI is not really going to help you very much to localize because there are no techniques at the moment. We don't have MRI guided wire placement. I mean, it is available, but it's not available in this city certainly. Yeah, so we don't actually have access to MRI guided. So MRI can sometimes be more confusing in the end with how to localize. But you have to localize, you should have put a clip in. And if it's a very diffuse tumor at the beginning, then you have to take a decision about what you're planning to do, because the decision for what you're going to do at the end should actually be taken at the beginning. So something that is a clear-cut tumor in a breast, you could plan for a breast conservation. But a diffuse type of tumor that is diffuse at the beginning, you should not plan for a breast conservation, even if the tumor has gone at the end.
Absolutely. So something which has pseudorons to begin with, or diffuse infiltrative pattern on MRI, they should be right in the beginning. And hence, MRI has been, although much talked about, it is often that residual disease may be overestimated and underestimated at MRI. And then overestimation and underestimation, both are around 20 to 30% in most of the published literature. What is overestimating is that they are seeing enhancement in necrotic tumors, fibrosis, even residual benign masses within the malignancy. So when they say there is tumor, it may not be true. And sometimes non-mass lesions, invasive lobular carcinomas, hormone receptor positive tumors, which are difficult to, really, they have diffuse infiltrative pattern, and the non-concentric shrinkage patterns, etc., will cause underestimation of residual disease. So for these reasons, MRI is not very popular. And it also depends on molecular subtypes. So the most conclusive evidence for maybe using an MRI would be a triple negative breast cancer, where you are indeed expecting concentric shrinkage pattern and you are not expecting trouble. And the other ones which are ERPR positive, the luminal tumors, they give us great difficulty in understanding the MRI. So prediction of PCR, overall PCR rate was 30%. In majority of the papers published, 25 to 30% overall, all molecular subtypes put together. And when they looked at accuracy for predicting PCR using MRI, it was at best around 75%. And it was most accurate for triple negatives, and it was much less accurate for triple positives and the HER2 positives also, surprisingly. So there was a good false negative rate of 20% for the HER2 positive tumors as well as the luminal tumors. So MRI, if at all, had maximum utility in triple negative breast cancer and not others. So other way to predict PCR, I guess, if this was a smaller tumor and not N2, do you have any experience of doing these vacuum core biopsies like the MD Anderson Center does?
I think it should be clear to the audience that something like this should only be done in a research setting. This is not standard clinical practice yet. It may reach that at some point, but right now, this is not the way any routine clinical practice should be conducted.
Absolutely. So this was just to get the straightforward case to get into more confusing and for more discussion. That vacuum-assisted core biopsies done, 12 core biopsies, 9 gauge needle, trying to take the tumor out radiologically is not something which is standard of care and should not be attempted, not definitely in this case which was T2N2, but even if it's T1N0, it is only in the research setting as Madam said, and right now there is no role, and like AI is creeping into all our field, screening or all other diagnostics or pathology, but right now it's just a fancy tool and we don't have conclusive proof that whether we can use AI to plan our surgery in any way. So Pooja, post-chemotherapy margin consensus, when you look at the histopath report, if it's PCR, okay, we are happy. Otherwise, when do you want to re-excise the margin?
I guess while I was in Tata, we used to do 2 mm margin to begin with, then we started with no ink on the resected margin. So I think we are following that in Medica as well, and we are doing fairly good enough until now. I think that's the standard everywhere.
So same as that in upfront operable. So there was a confusion earlier, but I think ASCO-CAP and many other professional bodies have given evidence which is very conclusive, although not level 1, based on retrospective prospective studies, that there is no difference between a more than 1 mm margin and a less than 1 mm margin as long as it's technically free and no ink on tumor. That holds true in upfront setting as well as post-chemotherapy setting, and they just have a different way of assessing the tumor. And if you see from the pathologist microscope, they have patchy responses and shrinkage patterns are different, and they have reported they started reporting residual cancer burden, etc. right now. But I don't think any of us are really using that in clinical practice. It's PCR versus non-PCR. Yes, we use that information to prognosticate or sometimes to change treatment, but RCB index is as such not used, and no ink on tumor is good enough. So now we are doing post-chemo BCS. Are we happy with it with respect to the IVTR, the local recurrence rate? What does the data suggest? Pooja and then Neha.
So happy means I'm happy doing post-chemo BCS. In a lot of it shrinks the tumor. There's a lesser volume of excision, oncoplasty is lesser. Margin positive rates are also lesser. That's what data suggests.
So any word of caution there, or everything is just fine?
So word of caution, like we know if it's a patchy response versus concentrated response, that's why we are worried about that issue. Because we don't take out the initial tumor area, we do just take out the final area, and if it's a patchy response, we are worried, but it is not amounted to increase local reference rates.
Okay, all the surgeons agree, Dr. Swadhi? True. So I just have one word of caution from the EBCTCG meta-analysis, which says that there was a 6.5% increased risk in local recurrence whenever there was post-chemo breast conservation versus whenever there was upfront. But we know that there are caveats of this paper, and when they actually separated those patients or those studies which did not have surgery at all after clinical complete response, which were the patients actually, who were the patients who had a very high risk of local recurrence. So whenever surgery was part of the treatment, of course, other than I'm coming to the radiation oncology bit of it, but even then there was a slight increased risk of local recurrence, even when surgery was part of the treatment. But like most of them, this is little older studies. All 10 studies are older and not new age. So I think we have more data coming from places like MSKCC, MD Anderson, and even our own, is that there is no much difference between the operating upfront versus operating after neoadjuvant chemotherapy, provided we have done a good mammographic and clinical evaluation to begin with, and if you're certain that the patient was eligible for BCS. So I found this paper quite interesting, which looked at patients where BCS-E is eligible and BCS-I was ineligible. So those who were BCS eligible to begin with got downsides, got BCS, it was all nice, 1.9% local recurrence rate. Those who were BCS ineligible and they were downsized to BCS eligible, there was a 6.3% local recurrence rate, slightly higher. And those who were BCS ineligible and hence got downstage but still had mastectomy, this was not a randomized study of course, it's just an observational study from MSKCC, but there was no difference, although there was a marginal difference in the incidence of absolute percent, and most of the absolute percentages were very low. So I think EBCTCG meta-analysis can be looked at little skeptically today, and we can say that as long as the previous assessment is fine, we are okay to do breast conservation post-chemo. So I'm so sorry that the radiation oncology colleagues we haven't included yet. The most important part of all of this is the radiation that's going to happen at the end. So Dr. Kazi and Dr. Devarshi, how do you plan radiation post-chemotherapy?
In these cases, BCS done in the PCR setting. So still now we used to go for conventional treating the whole breast with boost and nodal radiation, supraclavicular, if axilla is adequately dissected. Though the trials are going on for omitting the RNI, but still the data is not into the surface.
Correct. So PCR coming into the HPR is not really changing our radiation planning yet, because I believe it is the way the tumor presented, and if the axilla was positive, then and anyway she's got breast conservation. But one thing that my radiation oncology colleagues often tell me is that if you are not sure about the axilla, then get an FNSE done to begin with, so that if in case she ends up with a mastectomy for some reason post-radiation, I would know what the axillary status was before, so I can decide. That's what they often tell me, and that's what we've started as a practice, that if the axilla is not conclusively positive, not all palpable nodes are positive, we would want to get ultrasound-guided FNSE to ensure whether it is positive or negative, so that post-radiation and including the supraclavicular fossa, etc., the planning is better. So that is something that we've done, but as of now we are okay. Planning does not change as per response. Maybe in future it may, but as of now she was triple negative, young, T2, N2 to begin with. So it's great that she had excellent response, but we would still go ahead with the same radiation, including the supraclavicular fossa radiation therapy. So just to be a devil's advocate again, and to put a final end to this question, can we omit surgery in this case or in any case as of now?
As of now, even in PCR cases, the local recurrence rate you see is around 5 to 6%. So there is no point of going for omitting the local treatment as of now.
Right. So you're not happy doing just radiation yet. And of course, PCR is something that we know after surgery. So you wouldn't have that information, and hence there's so much going on about predicting PCR and the vacuum codes and the MRIs and the PET MRIs and fancy techniques, or maybe even AI to use. But today we are not there yet, and I'm not sure whether we will ever be there. But as of now, surgeons are not redundant. We are operating post-chemo PCR. We come to know only after surgery. So just to complete the topic, there is study going on, and of course we know there are studies going on in the West, and exceptional responders, what they are calling them, that really everything disappears, like the previous lady who probably had a large tumor, large axillary node, but everything disappears. There may be some role, but very early data, very small cases, and very little follow-up to really conclusively say anything. And studies on radiotherapy alone instead of surgery, there are many, and this is a summary of all of those that have happened till date. Like you see small numbers in hundreds, 150, 200, 250, but the local recurrence rates are much higher in the radiation, only radiation arm, not operating. That is as high as 30%, 22%, 25%, etc. So we haven't still been able to identify PCR that well without surgery. So again, when would you ever think conserving the axilla? Neha, Pooja, and just quick question to all
So,
three surgeons.
clinically node negative to start with, I'm comfortable doing a sentinel biopsy after chemo. If it continues to be node negative, if it is clinically node positive to start with, unless I have the facility of targeted as axillary dissection, not yet.
Absolutely agree with Dr. Neha. And in Medica, we don't yet have the option of targeted axillary marking. So we are going with complete axillary dissection.
Yeah, but for something which was clinically node positive to start with, post chemo and seeing this exceptional response, I do downstage in a way that I may end up doing low axillary sampling only. That is one thing which I do see case to case basis.
Absolutely agree. So a lot of data again for conserving axilla. In the current case scenario, no role because N2 tumor, N2 node. In N1, the world is trying to move to TAT, but personally, I've just had one conversation with the nuclear medicine consultant to start making radioiodine seeds in DRC. So maybe we will have the seeds at least, but we will need to really prospectively do a study and to see whether it works or how our experience with that develops. Vaccines and clips and radioiodine seeds are being tried and tested in the West and maybe even adopted, but their setting where they start NACT is really early breast cancer kind of setting, where our setting is still higher nodal burden, higher tumor size, and sometimes even LABC. So we can't extrapolate the TAT data so easily to our setting, and we need to be cautious. Like Neha said, low axillary sampling, we did validate in 750 patients, and apart from a little criticism regarding the number of nodes harvested, which the median was 6 to 7, we were happy with respect to the FNR at least. So as long as we will prospectively study the morbidity of LAS in future, this may be an option that you can try, and we are currently actually running a study where we are randomizing post-chemotherapy N0 patients, pathologically proven on frozen section to be node negative on LAS. We are randomizing them with DFS as a primary endpoint to observe versus to do a complete dissection, something on the NSAPB 32 lines. We just finished 50 studies and sample size is 2,400, so I'm open to having collaborators who will do the same with me over the next 10 years maybe. So axillary conservation post-surgery, N0 disease, like Neha said, we may go ahead with sentinel node biopsy. N1 disease, as such, there is no trial to suggest that it is safe with respect to DFS. We may explore this in future. In N2 disease, there is no evidence at all to conserve axilla. The West N2 disease incidence is 5%, so the evidence is not going to come from them. We are the one where the N2 disease incidence is 25 to 30% even today. So we need to test it probably in the long-term setting in some kind of collaborative study. So quickly coming to a couple of other cases where planning surgery is a challenge to the topic of the panel. So this is a 55-year-old lady, postmenopausal, left breast, cicatrizing kind of a lesion, 4 into 3 centimeter, 2 centimeter hard axillary node, and a grade 3 ER8, PR8, and HER2 negative tumor. And that's the kind of picture that she has on mammography, and that's the cicatrizing lesion, which is, let's say, in the lower outer quadrant of the left breast. So, what's our plan? Dr. Sandeep, from medical oncology point of view, she has a node, she's locally advanced, she has cicatrization, some skin involvement. What would you do?
The surgeon does the case is locally advanced, so we'll give systemic NSAT. How old is she?
55.
We can give in our
Which is great, yeah.
we have standard EC and taxons. Maybe a dose range we are using in our institute. But
so the ERPR status wouldn't really change your plan per se.
But I know that she may not achieve a pathological complete response, but we are getting patients where the surgeons are doing the surgery and then it's coming injury.
Yeah, agreed. So the surgeon's perspective here, strong ERPR positive, medical oncologist wants to give chemotherapy because they don't have much option otherwise. Hopefully the tumor will downsize, maybe not. How often do you think they downsize? Really downsize to have a BCS because it was already cicatrizing with the volume loss to begin with.
So ma'am, in this case we would like to go for NST upfront and then go for surgery. And
because of, I guess, lack of options,
yeah.
other much better options, you would start with NACT, which is truly locally advanced. So how do you expect the response, clinical response rate to be lower than a triple negative, of course? So this was an 800 patient study that we looked at 2017 patient who had NACT first, and 9.3% was the PCR in the HR positive disease. Luminal A's and B's we couldn't really discern in these study, but there's data available from literature which says that in luminal A it's 0.3%. The PCR rate is 0.3%, and this is coming from the West. And in luminal B1 maybe it is 8% to 9% is what we are getting, because we very rarely see luminal A. So the response is not so great. So this is really her mammography post-chemo after 4 cycles AC. We did give her post-4 AC because there aren't many options, and the tumor looks exactly the same. It's not progressed, but it's stable. So surgeons here, what do we do now? Stable disease on chemo, strong ER, we are on first-line chemo, 4 AC. Do you want to still complete taxons? Yeah, I guess Riya Rosina, my mom just wrote it here.
You will finish try to give the chemo, finish all the 8 cycles, because she may not respond with anthracycline, but she may respond with a cancer. But she may progress also.
I think the message for this sort of a patient is monitor them carefully on every cycle. If they begin to progress, go in straight away. It doesn't matter if it's 2 cycles or 5 cycles. But if there's some response, you can carry on with the chemotherapy.
Yeah, so as like everybody's saying, which is fine, that you are not going to change much there by giving chemo, but I may just go ahead and operate her at 4 cycles, because I don't see any point of continuing to give taxons. It will not downsize further. If you are going to require a radissimus dorsal flap, you are going to require it, come what may. You may give the remaining taxons after surgery, that may be okay, but in this case we did operate. So any experience with NAHT, with this advent of CDK4/6 inhibitors?
Not with the CDK4/6 inhibitors, but for failed patients we have given, even during the COVID time we have given, has not seen very drastic response this time.
True. So this is really a setting where we don't have much to do. We don't have NACT is not helping, any HT is as such not producing better response. And some data is coming up with the CDK4/6 inhibitors, but they are in comparison mainly with letrozole alone right now in frail, elderly, not willing, not fit kind of patients. But comparison with chemotherapy, I was looking up and I found that there are trials which are ongoing which are looking at chemotherapy versus AI and palbo or ribo or whichever cyclip, and they are being compared to see at least response rates. Because if we are really aiming to downsize for surgery, then what I have a feeling that the palbociclib and the AI might work better, but it's just a feeling, and we require data to say that whether it's true or not. And concurrent chemo therapy, we are currently running a study in the neoadjuvant and adjuvant setting where we are giving chemo and endocrine therapy together in these patients, and I don't have much to say from the data yet. We have 600 patients finished. Again, it's a 2,000 patients randomized control trial, and maybe over time we will know what to do. So locoregional radiation, again to our radiation oncologist, BCS, large flap, latissimus dorsi, and how do you go about planning the radiation?
It's the same, we will take the whole breast radiation along with the supraclav and the axillary apex.
Yeah, so agree, it's the same, but some little probably different planning for latissimus dorsi flap to, I don't know how that to do that, but probably a little more of a boost area that needs to be planned effectively. Maybe spare the flap if possible, produce less fibrosis.
Yeah, actually right now we are including the entire breast and not sparing.
Not sparing, I agree, same with us.
Practice actually.
Yeah, that is true real world practice. Although there is some data that maybe you may be able to do that in future, but I will leave that to you in future. So just to give one more example of a difficult scenario. It's a 51-year-old lady, 8 centimeter lesion, 3 centimeter matted node in the right axilla, non-metastatic on PET, grade 3 TNBC. Not discussing this further, what to do, we will give NACT, she's locally advanced, she's got triple negative breast cancer. We gave her 4 EC and Dr. Sandeep, to my dismay, she's progressed on 4 EC. So what do we do now?
I will send the case to my surgeon.
Thank you. I was hoping you say that, because that's what happened. That we gave her 4 EC, a triple negative ROS not responding to EC is unlikely to respond to further second line, even if you have, yeah, Neha, you want to say something?
Ma'am, I mean, we have had cases where patient has not responded to EC, but we have gone ahead and given backing carboplatin and they have responded. So
Anyway, so this one progressed really rapidly. After the first 2 cycles, there was little decrease initially, she told us, but it started progressing and it was that big, and you can see my resonance incision. So we have done a radical mastectomy even with the serratus anterior liver because the base had to be cleared. And she got the internal mammary lymph node now also. You can see on the PET there is this IMNN which was a centimeter. So to my surgeons first, now you're operating and you see this internal mammary lymph node on PET. It's 1 centimeter, they say, the nuclear medicine experts.
Internal mammary, experience with internal mammary resection is very less. So in this case, we try to take it out. Then certain for this that.
Yeah, I kind of tend to agree there, but it's debatable and we will stay away from controversies. But we did a radical mastectomy, opened the second intercostal space and removed the third costal cartilage and took out the second and third intercostal tissue. It's gone to histopath. This was last week. It was striking, so I got it here. And we do that, and I guess the radiation oncologists would then plan their fields differently.
Yeah, we have to include the IMNs also because I'm positive. And other part like chest wall and this thing will be the basic idea of like evolving global regional treatment in case of PCR cases, mostly HER2 negative, HER2 positive and triple negative. So I think in future these group of patients will be addressed separately in terms of local regional lines.
True, and we do give in IMN positive, persistent positive or pre-chemo positive. Our radiation oncologists are including it in the portal of radiation.
If it is positive, IMN clinically or radiologically we are including.
Yeah, because my second and third clearance may not be enough. We will have to irradiate the entire first to fifth chain. And just one last comment on now, if we have to plan her chemo, are you happy to? What kind of chemotherapy Dr. Sandeep will plan? She has a big tumor, still node positive TNBC. I know she has a poor
I will do a combination of Taxane and chemo.
And any role on giving them together, the chemo and radiation therapy? Because sometimes we have seen the chemo-resistant tumors to begin with. You continue to give them 3 more months of chemo, they have recurred on the scar by then.
Not with the, I'm not comfortable. With the standard dose what we are using.
So any radiation oncology comments there? Can we give concurrent CTRT in this setting?
No. We have not experienced any CTRTs.
True, I guess that's the general consensus, but we just completed a phase 2 study when Dr. Tabassum did. I will have to check what dose of paclitaxel they used, but they did concurrent chemoradiotherapy in the second and third cycle of 3 weekly Taxane that she was getting with not so bad toxicity with respect to all the lung evaluation that clubbing it together with paclitaxel there may be a concern. And this is very preliminary data and a phase 3 trial in this setting may be due in future in Tata. And there is some data that concurrent CTRT with either capecitabine or paclitaxel or cisplatin may be okay with respect to toxicity, and this was tried in the advanced inoperable or recurrent setting. But I do agree in the adjuvant setting we still don't have much role for that. You may get some more data in future. So lastly, are you comfortable with the LABC doing oncoplastic breast surgery? This is again to just my surgeons, that this was a lady who had a large tumor, 7 centimeter, multifocal. I'm not certain if you can appreciate the microcal, but that entire area has microcalcification. We have given her 12 paclitras, she was triple positive. She has a clinically complete response, but a persistent microcalcification in a 7 to 7 centimeter area. She says she wants conservation. We did a CEDM to further see if there is much disease, but everything had responded. At least there was nothing enhancing, but microcals were persistent. So,
yes, so you need to take out the entire area of the microcalcifications. If it's possible, doing an oncoplastic procedure, that could be by going for a therapeutic mammoplasty and taking a large area. It could be by putting in a big perforative flap. It is possible in a patient who's really keen to have it. I mean, of course, don't forget that even if she wants to conserve, what she wants is a breast shape. So if you're at the edge of where you really feel uncomfortable doing it, she should have a post-mastectomy immediate reconstruction.
absolutely.
What she wants is a breast. What she
Not a conservation.
What she does not understand is what is conservation. What she wants is a breast.
Absolutely. So she was keen on conservation. We did get the microcal out and did I agree that BCT in LABC is controversial, and maybe in those who are good responders like this patient was and who was very keen, we did end up with a therapeutic reduction mammoplasty as you thought we would need. And the summary report said no tumor at the ink again, so we are happy by the pathology report. And a little bit last comment from the radiation oncologist for post-chemotherapy, post-OPS, oncoplastic surgery, RT planning. Is there some difficulty, especially after reduction procedures, mammoplasties?
Yeah, but difficult in the sense, most challenging part is to treat the boost area because of tissue flap rotation and this thing. Sometimes the clips can migrate, and this is the main challenging part. And otherwise, till date, we are using, we are taking the whole flap areas in our target areas. So, but for the like dose, in terms of dose are not different, and the techniques, it can be manageable with the tangential techniques also.
True. So there is a word of caution here. She was large, she had a large area to give boost to, and the clips can migrate. When they call us in their console to tell them the boost area, I'm thoroughly confused. So go back to my papers and surgical notes and kind of look at it. But we have started putting clips on the base, we started putting clips on the wall so that we kind of delineate the whole area for them. And then when base clips and cavity wall clips are both taken together, probably they are now happy in giving radiation, and we can actually reduce the area because it's not the entire mobilized area that needs radiation, but really those cavity walls and the base. So I guess this is the last slide, and thank you to my panelists for like a wonderful interactive discussion. We are open to questions over tea or coffee if the time is up. But I think successful post-chemo local regional management, first and foremost, like Rosina madam also repeatedly told me, is a thorough clinical documentation of how the disease was before we begin the chemotherapy, imaging evaluation, if required, even MRI in that setting, mostly not required. SOS clip placement, FNing the axillary lymph node to document whether it was positive or not, response assessment at each cycle, even by the medical oncologist, localization of the tumor bed adequately post-chemo with wires or clips or whatever else you want to use, attention to margins whenever it's planned, talking to your radiation oncologist, helping them understand the boost area if some fancy oncoplastic procedure has been done, and appropriate systemic therapy, completion of 1 year of trastuzumab, etc. will probably get our local recurrence rate down to what we desire it to be. Thank you so much.
Thank you, Dr. Salaga. It has been really a good discussion, and I would have been happy if there had some audience interaction, but I'm sorry because we are 30 minutes late already. But there has been, the discussion has been very fruitful, and I think it has reached the audience quite nicely. So next is a talk. Yes. Next program is a talk by Dr. Patricia Sebastian from CMC Vellore, I think. Yeah. She will talk on evolution of patient-friendly radiotherapy. I had an idea that all radiotherapy is patient-friendly, but now it's a term, patient-friendly radiotherapy. Yes, it is interesting to hear from you. What do you really mean by patient-friendly radiotherapy?
Yeah, interesting topic. It was interesting for me to read the topic. Yeah, so I'm here to tell you how the patient-friendly radiation for breast cancer patients has evolved. So we know that 1920s we were treating with radium needles. Till 1990s maybe we were still doing two-dimensional information and tangents. But in the last 2 decades, there's real leaps and bounds in technology advancements and the way we have looked into radiation for these patients. So what I would look at is what has been evolved: de-escalation, hypofractionation, partial breast, omit boost, omit whole breast radiation post BCS in select groups. Escalation, we can give simultaneous integrated boost, and of course cardiac sparing, reducing toxicity. And what is evolving is pre-op radiation, look at the biology of disease and plan radiation, prophylactic radiation in BRCA carriers to contralateral breast so that breast need not be removed, and RT with checkpoint inhibitors, Rad-Scopel effect and all that. So coming to the indications, we know for sure the high-risk population definitely needs radiation, we cannot omit, but low-risk population, we have found now that we can omit radiation in them. Of course, the intermediate risk is the population where we need to personalize. Regional lymph node radiation, again and again, we've been told that in all the trials that lymph node irradiation is beneficial in reducing the local recurrence, but these trials, MA20, French and EORTC, all have been done in the upfront setting, and though meta-analysis is favoring regional node irradiation and IMC, we do not have evidence for patients right now, because we just were discussing about neoadjuvant treatment for most of our patients now, triple negative and HER2 positive patients. So in this setting, clinically N1 but pathologically N0 post neoadjuvant, what do we do? So low rates of locoregional recurrence. So this is being addressed by a few trials. NSABP B51 has randomized them into no regional node radiation versus regional node radiation. Results are awaited. MA39 trial and NRG also looking at this limited nodal involvement using tumor genetics and randomizing them to RT and no RT. This has also come into DCIS population where tumor genetics is used to differentiate between low risk and high risk. So what do we do post neoadjuvant? Consider the regional node irradiation based on pathology reports. We know that sentinel lymph node biopsy patients, we can avoid axillary lymph node dissection by adding on radiation for 1 or 2 nodes positive patients. So again, patients are happy not undergoing another surgery after the primary surgery. What about boost? EORTC boost versus no boost trial showed that at least the elderly population with low risk tumors, you can avoid boost. So avoiding boost helps in improving cosmesis in these patients, and they are happy. So, but not for the younger group. And can we omit radiation? Yes, at least in the elderly population, more than 65 years, hormone receptor positive, low risk disease. There are at least 2 trials which have confirmed that we can safely omit radiation because it only helps in local recurrence control, which can be salvaged when they take the hormone therapy, and no overall survival benefit. What about the radiation dose? Reduce the treatment time. We know today time is a new currency. So it's very important if we can reduce the time for our patients. And that is where the hypofractionation really helps. We are also aware that it is radiobiological advantage because breast alpha beta value is 3 to 3.5, so it's able to tolerate the dose, increased dose per fraction. There is therapeutic benefit, there is less side effects. It reduces the treatment time and cost for the patient, reduces mesh-in time, improves compliance. Definitely it's patient friendly now. And the debate is over for hypofractionation, both early breast and post-mastectomy setting. Canadian trial also have proven that. So what is going on now? It's not 3 weeks. We are going forward to 1 week schedule. The fast and fast forward has shown benefit for low risk stage 1 ER positive cancers. So where have we come? From 5 to 6 weeks to now 1 week. Ultra hypofractionation. It has shown that 26 gray in 5 days is equivalent, and both in efficacy and toxicity. So already 5-year data is available for patients 50 years and more, early stage node negative. What about our patient load who are mostly locally advanced? So we have this hypot adjuvant trial going on, multicentric study in our country, which will give us the answer whether we can use the 1 week schedule for our patients, which will make it wonderful for them to finish off in 1 week. So this is including all the locally advanced post-mastectomy also. And another point is giving the boost simultaneously reduces the treatment time again. And this has shown excellent cosmesis. So we are able to reduce time, give them better cosmesis, making it patient friendly. Partial breast irradiation, are we over treating in some population? Do they really need whole breast RT? Can we give similar control rates with partial breast? Yes, there are many trials that have come up and shown us that partial breast can be offered to some population. Import lobe has shown us as one of the arms there. So again, it's only useful in more than 50-year-old with low risk disease, which has shown partial breast with similar efficacy and better cosmesis, mainly when you use interstitial brachy or IMRT for partial breast radiation. Accelerated partial breast irradiation is just 1 week schedule, twice a day, over 5 days. And Astro has given us the low risk disease group, which is suitable for this. And there are various techniques that can be used, external beam, brachy. But a word of caution about intraop RT in this population. Intraop RT has not really shown benefit, though it is a single fraction, very convenient for the patient, but it has not shown benefit in the local recurrence rate. So we have the advantage again, patient friendly, equivalent efficacy, shorter treatment time, improved normal tissue sparing, better cosmesis. So RT options in early breast cancer, we have hypofractionated and ultra hypofractionated regimens. We have partial breast radiation, we can omit RT in an elderly population. Coming to techniques, we have moved from 2D era to now 3D gating and IMRT VMAT. We have shown better tumor control, spare the heart and lung, improve cosmesis. This is what the 2D planning was. Now we have gone into field and field, prone breast, gating, deep inspiration breath hold for moving the heart away from the radiation field. And this can be done even using SGRT now. Hybrid VMAT IMRT, always the worry with VMAT was the low dose spill. Now hybrid VMAT uses 2/3 of 3D and 1/3 of VMAT, reducing the low dose spill. We have reduced the heart dose by various methods like breath hold, prone and IMRT proton. So what are the evolving strategies which are patient friendly? Pre-op radiation. Pre-op radiation can be just 1 to 3 fractions or sometimes just 10 fractions. And in more than 55-year-old T1 N0, it can reduce the size, it can facilitate breast reconstruction, it can facilitate partial breast radiotherapy, also translational research. Neoadjuvant RT in early stage has been promising, showing long-term disease-free survival, but it's in SEER database. The next thing is molecular biology based treatment, where molecular type is taken into account to know the local recurrence rate percentage and then personalize radiation for them, either escalate or omit or add on radiosensitizers in triple negative. Prophylactic RT in BRCA carriers, it has shown, this is a phase 2 study showing comparable results to mastectomy in BRCA mutation carriers. Radscopal effect has the immune cell activation also. So PDL1 inhibitors with RT has been showing promising response. So we harness the immune response here. So to conclude, a lot of technological innovations which helps us to escalate the dose, reduce toxicity, reduce the time, adapt personalized radiation, assess every patient individually, and then offer the treatment. Hypofractionated, of course, is the standard. Boost to the tumor bed only when needed. Partial breast for low-risk patients. VMAT, DIPH for reducing cardiac dose and boost simultaneously to the tumor bed. RT has replaced axillary dissection in most of the patients following positive sentinel lymph node. Tumor genetics is coming up in a way to decide indication for RT. Thank you. I do acknowledge my colleagues for helping me present this.
Thank you, Dr. Patricia. In fact, you have given a broad overview of the patient-friendly radiotherapy procedures. Thank you very much for that. So, yes. Is there any question? I don't think so, because they have got the message. So now I would.
We want to felicitate everybody who was in the previous panel. Dr. Shalaka Joshi, ma'am is not here. Ek to dark bay? Kaushik da. Felicitate. Aage ma'am ki? Okay, ma'am. Dr. Patricia, thank you so much, ma'am. And all the panelists from the previous talk. Dr. Neha Chaudhary. Okay. Dr. Shubhadeep Chakraborty, Dr. Kazi, Dr. Debashish Lahiri, Rosina ma'am, Shundip sir. So the next talk is John. Eta to felicitate for. সবাই কি আপনি দেবেন?
স্যার একটু থাকবেন, একটু গ্রুপ ফটো থাকবেন স্যার।
So we would end this breast cancer session with a beautiful panel discussion at the end. And for this, I would now request the moderator, Dr. Sanjay Chatterjee from TMC Kolkata, to please come to the dais, and I would request him to call his panelist.
I'm still scared to call you. No, I'm still scared to call you. Please, I would request the panelists to be on stage. Dr. Shuparna Kanti Paul, Assistant Professor Radiotherapy. Dr. Shourav Guho, Consultant Radiation Oncologist, Medica Hospital, Shiliguri. Dr. Shomnath Ray, Consultant Medica Oncology, TMC Kolkata. Dr. Shashank Das, Consultant Medical Oncology, HCG Kolkata. Dr. Tanmay Mondal, Consultant Medical Oncologist, AMRI Kolkata. Dr. Indranil Ghosh, Senior Consultant Medical Oncology, Apollo Kolkata. All over to you, sir. Thank you.
Thank you for whoever is waiting for this, and I can totally understand the difficulty in waiting, because we've all had a very intense morning, and we needed a cup of tea, but we are the hardcore people waiting to learn, isn't it? So we've heard about radiotherapy, we've heard about local regional disease, and now we've come to metastatic. My panelists over here are sort of a bit apprehensive. The apprehension is not everyone has seen the slides earlier, some of them have. So please feel free to intervene and ask whilst we are going through the sessions. Another sort of apprehension was that Dada keu to nei ekhane boshe. So I said that don't worry, we will try and discuss within a small panel, and we will try and bring the best out of it. It is the loss of the other people who are not here. Okay, so we understand that it is a spectrum. ER positive disease is a spectrum as such, and we talk about ER positive metastatic breast cancer in a sort of broad term, isn't it? Anyone, can one of you tell me how do you approach a ER positive breast cancer, and when they come in with metastatic disease? Just anyone, if you can summarize, sir.
So, ER positive breast cancer, when a patient comes with a metastatic disease, they are mostly, if they come with upfront metastatic, they have more of a bone mets than of a visceral disease, so it's more of a bone metastatic disease. Generally, the biology of a strong ER positive and HER2 negative is a good biology disease, and after evaluation and staging, we start with hormone therapy plus minus CDK4/6 inhibitors. Earlier days, it was the rule that in patients with visceral disease, we would have started chemotherapy, but now I think for almost all the patients who comes with a metastatic disease, we start with hormone plus CDK4/6.
Right. I think overall, all of us do agree with you. But would any of you like to comment a bit more on when you see someone deciding on treatment options, what are the things that you consider?
Well, first we need to look at the previous history, what adjuvant therapy received and all. What is the current disease burden, the sites of the disease in visceral crisis as you mentioned, and the fitness of the patient, like the performance status, organ functions and symptomatology.
Well, Indranil, we expected you to mention the key points anyway, because these are exactly the points that I'm talking about, that when someone with estrogen receptor positive disease comes in, it's a spectrum. You have someone who's just estrogen receptor positive, a ER3 on ALRED versus a ER8 on ALRED. So not everyone is the same. Check that. Number two, what was the initial treatment that the patient had, and what is the interval of disease-free status? So, how long? Is it months, years, how many years? Because that will give you, if someone's had upfront treatment, if someone's come in upfront metastatic, you don't have that data. But if someone's had treatment and then come to you maybe in 6 months versus in 6 years, that obviously shows whether the patient has a disease biology which is different or not. With this in mind, let's try and see if we can use this in practical application. So again, this is for all of you over there to try and interact, comment. See this 68-year-old lady who had 6 nodes positive in the adjuvant setting, went ahead and had adjuvant therapy, and then came back with 3 liver lesions and 4 areas of bone metastases. She had minimal pain. She's otherwise fit and well, like Indranil was saying, you know, what is the fitness? She's very fit and well. And no, so you, just like our colleague said, how would you plan a management for this patient? Any of you? So I think, yeah, how would you start planning a management for this patient?
For this patient, what I would like to first see is how well she is. You have said well otherwise, but whether, since this she has quite a few liver lesions, I would like to assess the liver function test and see that part. The other thing is that I would like to know, since she had completed therapy, so what's the she's postmenopausal, I believe, obviously, and so what is the duration from that?
From what, sorry? From the initial
completion
treatment?
of the initial treatment. Now, if, as he said, earlier we used to, for everybody who have any kind of visceral mets, we used to start on the chemotherapy itself. But if she is otherwise very stable, then we can still think of hormonal manipulation, provided she had at least 12 months of gap between the completion of the AI and...
She was on AI when she progressed.
Okay, so if she was on AI when she is progressed, then AI is not an option. One option is to go for chemotherapy. The other option would be to go for something like a palbociclib or ribociclib with...
I think you know, let's sort of stop it here. Yeah. This is exactly where we have to decide as to what the biology of the disease is, what is driving the metastases, and how we treat this. So anyone from the audience who will comment? I mean, so we've had doctor telling over here that, you know, patient was on aromatase inhibitors, and he feels that you know, we should not consider aromatase inhibitors at the moment, or maybe should not consider endocrine therapy at the moment. Any comments on that from the audience?
I want to know the all-red score.
Perfect. So, you know, we said initially that, you know, what is the duration from the initial treatment and what is the all-red score. Not all ER positive tumors are you know, sort of likely to be endocrine sensitive. So the duration of the treatment in the adjuvant setting, I said, is, you know, for years. So this patient had metastasized 5 years down the line, and because she was node positive, was an extended adjuvant treatment with letrozole. All-red score was 7 out of 8. So what would you do now? I mean, I would go to my expert panelists, but you're also a panelist. I think the number of people sitting over here are almost similar to the number of people over there. So why don't you tell us what you feel should be done? Shalaka the surgeon, yes.
Liver biopsy, can we do a liver biopsy?
We need a repeat biopsy to see the receptor status again. Of course, all-red score is one of the important things. PR positivity or a PR negativity is also one factor which we need to see. And if it's a very short duration, means if it's...
I said it's years, it's around 5 years.
Long duration, so we need a repeat biopsy from the...
So how many of you with a, you know, high-risk breast cancer, 6 nodes positive, ER strongly positive, on adjuvant setting, has definite metastatic disease on a PET CT or on CT scans, bone scan, no other primary identified. How many of you would definitely go in for a biopsy of the liver? Show of hands. Right. We've got 3 people definitely going for biopsy of the liver. Well, look, there are 2 ways of looking into this. Are you doing a biopsy to try and see if this is a second primary? No, you're doing a biopsy to see if the ER, PR and the HER2 status has changed. Yeah? In a third of patients, they will change. In 70%, they wouldn't change. In patients who have a disease-free interval of around 5 years, the likelihood of change is very low. So one would usually, empirically, as per international guidelines and practice, and as per most sensible practice. I don't know. I mean, what would all my colleagues would do a biopsy, a repeat biopsy of this? Let's think practical. This is not just a session just to say things. Would you do a repeat biopsy for this, Shramnath?
Suppose if patient is previously HER2 positive, In that case,
this is all HER2 negative. HER2 negative, ER positive.
So it's a luminal A type of cancer. I am more skeptical to not to do a biopsy in routine practice.
Yes, would you do a biopsy routinely in this patient?
Yeah, I would do biopsy in any patient at in the time of first relapse, right, just to confirm that it's relapse and confirm the receptor profile once again.
Right, okay. I mean, one can actually, if you no one will fault you, but like I said, as per international practice, you're not bound to do a biopsy if you feel that this patient has initially, this patient was node negative, had a luminal A type tumor that is now, you don't think this patient should have recurred, has recurred. You definitely need it. If this patient was ER negative, then you know that you can find an option. If you repeat a biopsy, if this comes back as ER positive, you can find an option. Change in HER2 status in a ER positive, HER2 negative patient is very unlikely. I mean, very unlikely this will change the HER2 status per se. So this patient did not get a biopsy, but if you do a biopsy, it's absolutely fine. Let's move on now, because we've discussed the controversial areas. Would you do a biopsy? Would you check the Aldrich score? Would you see the lead time? We've discussed that. For some, there are established answers. For some, there are answers that even experts would differ. Okay, now we're talking about endocrine resistance. Now, when would you consider, like my colleague said, previously we would have given chemo, but previously and now, when would you consider chemotherapy for a patient who's got metastatic disease with a ER positive cancer?
Sir, actually, the patient is having endocrine therapy during the adjuvant time. Even if the patient progresses within a short span of time on adjuvant, still I will consider giving some kind of adjuvant, some kind of hormonal therapy. Along with it, I will consider adding CDK4/6 inhibitor. I will not consider primarily for the chemotherapy at the first stage.
Right. Any comments from Indranil or from Somnath?
So endocrine resistance, I think this case is not fit the category of endocrine resistance, because it is a 6 years intervals is there. So if patient is within on therapy of adjuvant AI or these things, that category should be put into the mind.
What is qualified as endocrine resistance? How do you define that, Indranil?
Yeah, at least.
Endocrine resistance and endocrine refractory are not the same thing. Endocrine resistance, typically, it was at least relapse while on adjuvant therapy or within 1 year after stopping. And previously, we used to say 6 months while on metastatic therapy for metastatic disease, but now it is usually 12 months because from other studies it has come up.
And endocrine refractory?
Refractory, where you have given say 2 lines or 3 lines of endocrine therapy already and the patient is no more responding to endocrine therapy.
So look, again, when you are giving this patient adjuvant treatment, try and see the biology of this patient. We've got another esteemed medical oncologist joining us now to try and help us debate this discussion. So Joydeep, welcome. So this patient, we need to check, is the patient recurring within 6 months of starting the initial endocrine therapy, 1 year of starting initial endocrine therapy? If so, in your head you can think that, look, this patient has been on an AI or some sort of endocrine therapy and is still not well, has relapsed. So the biology of the disease is likely to be more aggressive. Would you, in these patients, consider, and you then go back and check, look, let me go back and check, is the ERPR reported properly? In these patients, can we actually try and see if we need a repeat biopsy? Has the biology of the disease changed? Because if a ER positive patient recurs within a year or 6 months, you're worried whether your initial diagnosis is correct or whether they're really endocrine resistant or not. If on the other hand, they recurred like our patient did 5 years down the line, you're less worried about the endocrine resistance, but there definitely is a resistance, isn't it? Otherwise, why would the patient recur on letrozole? So now we are talking about the ER medium to strong positive and the resistant pathways. And that's when we talk about these agents. She's had an endocrine sensitive breast cancer, she's been given letrozole as adjuvant endocrine therapy, and then as first line, what would you give her if she comes 5 years down the line and now we are opening another can of worms. You know, what would you give her? Would you give her? She's been on letrozole. So what would you give her as first line? Let's have a. So any suggestions from the audience? What would you give her? 5 years done. Fulvestrant and Palbo from TMH. Any other? Anyone else from TMH? Okay. Anyone else apart from Fulvestrant and Palbo? Anything else?
I would go with fulvestrant with ribo.
Fulvestrant with ribo? Right. Let's see what our expert panels talk about. So,
fulvestrant with ribo.
Fulvestrant ribo.
Yes, sir. Fulvestrant
So
with
everyone
ribo.
will follow Dr. Joydeep Ghosh. Fulvestrant ribo. Who else? Indranil?
It was 5 years after stopping AI.
No, 5 years on treatment.
Five
extended adjuvant.
Yeah. So fulvestrant plus any CDK4/6 inhibitor, which I will discuss with the patient, because yes, ribo is okay if the patient can afford, but we have to consider financial things as well. So mostly it's palbociclib for me.
Right. Sir.
I have a question to ask. Everyone is saying about fulvestrant with CDK4/6 inhibitors. The patient was on a non-steroidal aromatase inhibitors. Can we give something which is different, like exemestane? Can it be tried in this setting?
A steroidal aromatase inhibitor. Well, look, I think the reason why our colleagues are moving on to a CDK4/6 inhibitor and another endocrine therapy, which is a SERM, is because we are worried about some sort of resistant pathway. Yeah? Now, exemestane is a steroidal version of the same type, so it's a steroidal version of an aromatase inhibitor. Now, to try and reduce the resistant pathway or try and act on the resistance, you don't know whether CDK4/6 inhibitor or something else is likely to work. And now we'll come to your questions a bit later, but let's address the question of ribociclib versus palbociclib versus abemaciclib. So we've got 3 CDK4/6 inhibitors. We've got drug reps over here. Yeah, I'm sure we've got pharma representatives over here. So 3 CDK4/6 inhibitor. We don't have shares in any. I think none of our colleagues have shares in any. Yeah. So which of these 3 CDK4/6 inhibitors would you give to someone who is really close to you, someone close to your heart?
So if patient is primarily endocrine resistance type.
This is the patient.
This
5
patient.
years down the line, this patient comes in on letrozole, and you need to change. What did you do?
So this patient, I also fine with the palbociclib fulvestrant, no issue, or ribociclib fulvestrant, whatever the affordability there is.
Affordability is obviously because of our generic drugs. Affordability for palbo is better, but yeah, I think possibly
This patient is not a de novo patient. So if you go into this is we are going to look at the second line data where all 3 have shown survival benefit.
This is not second line metastatic.
No.
First line metastatic.
First line metastatic, but you are starting with fulvestrant plus palbociclib.
No, I'm not starting with fulvestrant plus palbo.
Fulvestrant plus any CDK4/6 inhibitor, not AI plus CDK4/6 inhibitor. Where this question of Paloma 2 versus Mona Lisa.
Sure, I would disagree with you in that. If you look at this, yeah,
fulvestrant plus.
This is a cross trial comparison. Yeah, it's a cross trial comparison. It looks at the different studies. The only reason why people are actually debating, I believe it's a class effect. I don't know if ribo is definitely better than palbo. I think the Pfizer drug has been a bit unlucky in showing no overall survival advantage. Because if you look at the subgroup analysis and take the follow-ups of the patients, the last 2 follow-ups, then I think the Pfizer drug, the palbo drug also would show overall survival advantage. But the going amongst the medical oncology circles, some people is that ribo is possibly going to show the overall survival advantage and should be the gold standard. Whilst like I said, in our patients, we actually have to look at the efficacy, the practicality, like they said, there's a 2,000 rupees drug available in the market per month versus a 30,000-40,000 rupees drug. Pre-therapy conditions, obviously, if someone would tolerate whether they have cardiac issues, liver functions, etc., and how much we can generalize the data. I think abemaciclib data on generalizability in the first-line metastatic setting is going to be a bit challenging. So we are looking at this study comparing ribo versus palbo, and we will hopefully get the results soon on this. Another question to you: this patient came up with some bone pain. Would you not offer palliative radiotherapy, Shora?
I guess in the scenario it was minimal bone pain.
If it's moderate?
We need to look at the site where the
back pain.
Yeah. So if it is there are high risk features like suppose off-cord compression.
There's no compression.
Then we will not advise palliative RT at
Yes.
present.
The reason I bring this point is, colleagues, we often get patients who have symptoms who needs to be started on a new endocrine therapy. If it's de novo or if it's after progression, please wait for the new endocrine therapy to work unless the patient is in a lot of pain. Try and sort of manage the patient with appropriate analgesia first, because once you start these new endocrine therapy, within 6 weeks to 3 months, you'll find a significant change in their quality of life. So just don't rush into treating with radiotherapy, because it's like treating a chronic disease, ER-positive breast cancer. If you have symptoms at one place, you can address that later on once it's refractory to all your endocrine treatment. So don't just rush into it. And please don't forget the bisphosphonates if they have ER-positive disease, if they have bone disease. Yeah. So bisphosphonates are important. I'll share with you one sort of thing that we had in a patient recently. Patient started on CDK4/6 inhibitors and bisphosphonates, and patients started having high creatinine, so around 2.5, 3. So would you, how many of you actually have come across nephritis from CDK4/6 inhibitors? Sir, I'm not showing anything, sir, I'm asking you. Believe me. So nephritis, the reason I ask it's as rare as hen's teeth, but we actually had a patient who developed nephritis, which is drug-induced nephritis from CDK4/6 inhibitors. Keep that in mind. And because we often say, oh, because it's because of the zoledronic acid that you're having, we stop that. But the creatinine starts going high, yeah? And we discussed with the nephrologist, we stopped the drug for a month. It was a reversible nephropathy. Patients' creatinine functions improved.
So this CDK4/6 induced glomerulonephritis or acute tubular necrosis, tubular damage?
I don't know, there was no biopsy done.
Okay.
So the other thing that we wanted to discuss with you is that she progressed. 10 months is the median time. Yeah? 10 months to 11 months. She did well for 10 months, and then she progressed, and then she was restaged. So she had no other progression in the liver, but she progressed a little bit in the bone, and she starts bleeding from a rest lesion. So what would you change her, or what would you do?
Progression on CDK4/6.
We actually need some comments from the whoever is there in the house. I mean, I'm pretty sure you get these progressions. I'm pretty sure you see these patients. So how many of you would not do anything and say sit at home, just like we are keeping quiet? So we'll sit at home and say don't do anything. How many of you would do that? Yeah. So we need to do something for her. So what do we change her?
She progressed on CDK4/6.
She does.
So first thing you have to do the PIK3CA status in that cases, and BRCA also. This as per the guideline, BRCA, PIK3CA. Although EWSR1 is not in clinical significance, but these two should be kept in mind. So that are any targetable lesions.
So PIK3CA mutations in our center takes around 2.5 weeks, isn't it?
Yeah.
So she'll wait for 2.5 weeks.
If very much symptomatic, then we should change over to chemotherapy. But I think we have to see the PIK3CA status.
What about other colleagues? Sir, in your center?
If the patient has only progressed in a few bones and the patient is fairly asymptomatic, then I can.
She's got what she's got. She's not symptomatic from a bone disease.
So I will go a PIK3CA and the BRCA status, and I will maybe
anyone who would differ. I mean, so we're getting a consensus among my medical oncology colleagues here. Indranil, any comments on this?
So, local radiotherapy for the bleeding and pain in the breast.
When Indranil was here, I think Saurabh, you were also there. Would you like to comment on the experience and what can be done?
Since the patient has now started bleeding and significant pain, so our main aim will be palliative RT to alleviate her from her symptoms. So till now we would have advised a hyperfractionated schedule, typically a 30 grain 10 fractions. But now very recently, I think in this month only, the study has come out where you were the prime investigator, and now we can actually do a ultra hypofractionated radiotherapy and reduce the time limit from 2 weeks to 1 week of radiation. And within 1 week, we can complete it, and it has shown.
Yeah. So I just wanted you to be well aware that irrespective of the ER status, if someone has local symptoms, please address the local symptoms. Don't forget about the local symptoms. You know, this is our study published in the Red Journal, and you know, it does show that irrespective of your ER status, this was around 65% were ER positive. And you know, just look at the symptoms: ulceration, bleeding, arm edema, discharge, foul smell, all that. And just look at the sort of rates. You know, they're all, you know, in a cohort of patients, which is just 60, you're finding a significant reduction in these symptoms. So that means the effect is likely to be huge. And just look at the duration of response. And this is over years. This is over months. So this is the baseline. This is at 1 year. So for each of the symptoms, the red one is the duration of symptom. You can see the duration of symptoms comes down even at 1 year. If you give radiotherapy, the duration of local symptoms are actually controlled for more than a year. So please don't forget that. We actually have had a few patients in whom even after radiotherapy, after trying everything, systemic therapy, other endocrine therapy, they're still symptomatic. We have went ahead and requested our surgeons to then do toilet mastectomies, but that's for very bad local symptoms. Yeah, but in general, radiotherapy is effective for most of our patients. Don't forget that. Then we come to this. We always talked about, you know, let's start CDK4/6 inhibitors to start with. Now, what about CDK4/6 inhibitors delayed? Fulvestrant first, or you know, shall we start CDK4/6 inhibitors in second line? Colleagues, your opinion on this? We don't have, none of us have access to full text because this has not been published in full text. But this was one of the talking points of ASCO this year. You know, can we not start them on just you know, letrozole and have fulvestrant and CDK4/6 inhibitors for later on? Or what is your opinion? We've had a very healthy discussion on this in our recent consensus group meeting in our department, in our institution. But would like to know what others feel first, and then possibly ask Jaideep to comment.
Yeah, so this investigator-initiated SONIA trial, the PFS1 and PFS2 is almost similar when it's sequencing, no difference in the overall survival. So if we give CDK4/6 inhibitor in the second line subsequent progression, benefit was the same.
The progression-free interval is better when you give the CDK4/6 inhibitor, but the overall survival of
is no difference.
Not different. It's a non-sponsored, non-drug sponsored study. So it's a clean study from the Danish group. So, you know, very interesting. 74 centers, multi-center randomized phase 3 data. Comments?
I have a query here, though I'm not an expert, is that the patients who were initially started with CDK4/6 along with letrozole and later changed to fulvestrant, in the second line when fulvestrant was given, it was given alone. But rarely it will be given alone in setting. I mean,
if you progressed on CDK4/6 inhibitors, fulvestrant is given alone in the second line often.
But it can be combined with other.
It's usually given alone. We'll come to something combination later. Well, if we've got time, unless we'll finish in 2 minutes. Any other comments from colleagues?
The advantage of this approach is that you reduce the duration of CDK4/6 to very small, like 24 months to 8 months or something like that. So you are reducing on the financial toxicity and the toxicity as such. But the problem is that it was designed as a superiority trial. God knows why. I would have liked to say non-inferiority, but it was superiority.
Numbers of non-inferiority.
Yeah, so superiority was not proven. And it was not non-inferiority trial, so we cannot say it was non-inferior. And in our setting also, sometimes there is a dropout between first line to second line, which may not be there in the trial. So for practicality, I think first line is better. But for elderly and frail patient, where we want to cut down on the toxicity, then this makes sense.
Pradeep, any other comments? Exactly right. And also that you have other targets that you can look at in the second line, say the big three, the mTOR, etc. Isn't it?
Yeah.
So
I completely agree with you that the design was a bit weird, and this I would not say would be practice changing, but yes, if we are not using it in the first line, we'll be more confident. Now we have a level 1 evidence of using it in the second line, having equal overall survival. So it's I would not say it's practice changing, but yes, it's practice encouraging. I would say in the second line. Practice defining, redefining.
thank you. And we have 2 more slides before we finish. We all need a cup of tea. There was progression post AI and CDK4/6 inhibitors. We mentioned about palbociclib post progression. So basically, there's a group of people who would think that you should actually continue the CDK4/6 inhibitors even after progression. There's quite strong real world data on it from US and from Japan, which suggests if you continue, you get a better PFS. Overall survival data is lacking. So that, and then you've got the new pathways. So that that's got our medical oncologists' eyes lighting up again. So what new pathways and when would you use it? We'll do this and then we'll finish. Oh, time over. Yeah. So any comments? Any comments from who would like to summarize the future? Nobody wants to. Nobody wants to. Sir, why don't you tell me what you do? I mean, if you want to, otherwise, we'll get some.
Actually, probably in the future, the option, we are shifting from a group therapy to personalized medicine.
Absolutely.
Multiple genomic markers will come.
So what would you do if the PI3K is mutated?
So in that case, we'll have to go on to it.
So you think PI3K mutation? So
PI3K mutant add alpelisib to fulvestrant.
What is your experience in alpelisib? Using alpelisib? Is it quite a user-friendly drug?
For that, I have to reach to that drug. Mostly, many times it comes back as negative. If it's positive, patient cannot afford. So,
I mean, alpelisib is something that we've used, but honestly, it is a very difficult drug to tolerate. I've actually had a patient who had very refractory sugar levels. She went into diabetic acidosis with the sugar levels of around 600, 670, which was refractory to all medicines.
Same with me.
So alpelisib is not an easy drug. I mean, we used alpelisib even within the clinical study that was there, and in other head and neck studies. Joydeep, your experience?
Yeah, I agree with you. This is very difficult, and also mucositis. That is another problem.
Difficult hyperglycemia management, and these are the basically non-ketotic hyperosmolar state. So that is an SGLT4 inhibitor was the initial counterpart. So in that setup, and this management will be difficult in alpelisibs.
And what about the mTOR pathway? Would you like my colleague over there was saying, brother, why not exemestane and or what? Fulvestrant or everolimus? I mean, everolimus is an option, isn't it? It's an mTOR inhibitor. Brother?
Exemestane plus everolimus.
Yeah, why don't we see what our colleague feels as well? Use of everolimus.
Exemestane and everolimus is an option, but treating with everolimus is also a challenging thing because it has the same profile of alpelisib only, because
Yeah,
so hyperglycemia, dyslipidemia is also are the concern.
Apart from sort of mucositis, which again everolimus number 1 mucositis, diarrhea, these are the everolimus problems. Now we again had patients who had very atypical infections, chest infection, which is with a very atypical drug. Yeah, so
starting with everolimus at a lower dose is a fair option.
Yeah. So again, all of us know this, it's just that we wanted to bring this up. And this is the final slide. You know, these are the drugs that we are actually trying to explore. In Tata Medical Center, we are a part of multi-institutional studies using one or two of these drugs. And let's hope that, you know, we find a few targets, just like we're finding in lung cancer, that we can use, which can help personalize our patients' treatment nowadays. Any questions? Anything else that you would like to ask? You know, chemotherapy, we mentioned about chemotherapy, multiple progression. If patients' PS allows, after multiple cycles, would you not offer chemotherapy in them? If they're chemo naive? No? Sir?
Yes.
Yeah, what would you start with? Say for example, someone's chemo naive, you've offered all the endocrine over the last 3, 4, 5 years, and then what would you start with?
So we can start with any regimen, starting from the doxorubicin, cyclophosphamide, or maybe if the patient PS is poor, you can start with weekly paclitaxel.
So taxanes or anthracyclines is usually not a combination but a single agent is being there. Yeah, and you can get some time with it.
So I had one question for the panelists. Would they be comfortable using CDK4 in first line with a ER score of 4?
We've discussed that just before you came.
Okay, sorry.
So, yeah, answers please. So we've discussed that just before you came.
Yeah, I am not comfortable with the ER score of 4 starting CDK4/6 in first line.
So we discussed that, you know, the ER is a spectrum, and anyone with moderate to high, possibly CDK4/6 and endocrine is what we go with. ER low, we would treat more like ER negative cancers.
And one comments I just regarding the Sonia trial.
Yeah.
Because I thought if you close look at the subgroup, the ESR1 mutation, though those subgroup are basically triggering the full western the given in the endocrine resistance pathway. I think this also be pre-specified subgroup there was mentioned to equally OS data. That is one triggering factor. If you comparison with the complement data for the Sonia trial, the ESR mutation positive population, those receive full western in the first line, those are the more, and the response is better.
Any other questions? Any other comments? If not, let's have some nice.
Just a small question. I just wanted to know the experience of the panelists, like from ER positive to ER negative when we are rebiopsying. The frequency of patients getting.
It's rare, but you know the intensity does come down. It is rare, but after multiple lines, if you biopsy, which most of us do, if it doesn't respond to 1 or 2, we would do a repeat biopsy. You can see that the intensity may come down, but it is rare.
In the reverse.
From ER negative to positive, you know, I don't know, from in my experience, ER negative to florid ER positive is very rare unless it's a second primary, but ER negative to moderate, say maybe 3 to 4 ER positive is reported, and we see that easily. Any comments on this from my expert group? Yeah? Ready? Yeah. Okay, thank you so much. Thank you. Laura?
Thank you. Thank you very much for Thank you very much.
So we'll felicitate the panelists. So one moment everybody, just take 1 second. So, आप भी felicitate हो रहे हैं. We'd like to facilitate our last group for breast panel. So, Dr. Suparna Kantipal. Thank you so much, sir. Just give us a moment, we'll take a group photo at the end of the felicitation. Thank you. Dr. Saurabh Guho. Dr. Shobna Frey. Dr. Shashank. And Dr. Indrajit, please. Hands up করে দিচ্ছি স্যার আগে আপনাকে করবেন তারপরে আপনি স্যারকে hands up. Request Sanjay sir to precede our chairperson for the whole breast session. Dr. Little. We'll start with group photos, sir, please. Thank you so much, sir. Thank you, everybody. We'll start with hematology session. Thank you so much, sir.
जाके हॉस्पिटल जाओ यार
We request the chairperson for the hematology session, Dr. Naveen Khatri, to join us here. Sir, please. Hands up, please, sir. I don't think anybody needs to be told about Dr. Naveen Khatri. He is a professor and deputy director of ATRAC, chief of bone marrow transplant unit at Tata. We would like to call upon the moderator of the session, Dr. Lingaraj Nayak, associate professor, medical oncology, TMH Mumbai. The panelists, please join us on the stage. Dr. Akshay, Senior Consultant Medical Oncologist and Founder Member of Sunrise Oncology Center. Dr. Pradeep Mandal, Consultant Medical Oncology, Medica. Dr. M.V. Chandrakant, Senior Consultant Medical Oncology, Narayana Hospital. Dr. Avinash Bonda, Senior Consultant, Medical Oncology, AIG, Hyderabad. Over to you, sir. Thank you.
Okay, so good morning and thank you Sudeep and Dr. Datta for inviting us. And it's interesting that moderator, panelist, for all of us, the teacher is Naveen sir, who is the chairperson here. So what I will do is to discuss three cases that from all three cases are from TMH, and these are three case scenarios. So we will not discuss about how myeloma is diagnosed, and so for all cases, all the diagnosis is already made. So we'll discuss how the treatment landscape has changed. So coming to the first case, so this is this patient is a doctor, and he is 52-year gentleman from Northeast, and he is hypertensive, and he came to us with a history of 1 month duration of leg pain and chest pain. So he had an MRI before, which showed opacities in the vertebra, and there is a soft tissue lesion at the S1, which was extending to spinal column, and there was features of cord compression as well. So this was his basic labs. So his complete hemogram was normal. Creatinine was normal, calcium was normal. The Med was 3 gram per deciliter, and it was IgA kappa type. So this was the bone marrow report that we did. 76% plasma cells in the morphology, and they were all clonal. And this was his PET CT because he had an extramedullary disease, so he did a PET scan to look for the other sites of extramedullary disease, and he has extensive bone and extramedullary disease as well. And this was the FIST report, which is, you can see that it has DP53 deletion, monosomy, and 1Q. So now coming, first question to, maybe I can start with Dr. Avinash, that how do you see this myeloma in total? Like, he's a 53-year gentleman with extramedullary disease. This is the FIST report. And can you just describe us about how do you stratify myelomas in terms of the risk at baseline?
Yeah, so I think, if I am not wrong, this is a monosomy 13 and there is a P53 and 1Q gain, isn't it? So,
yes.
Yeah. So basically there is definitely one of the high-risk myelomas with respect to the cytogenetic report. One can add to it as like say a double or in fact a triple hit myeloma also. So we have to be aggressive on him. The outcomes are not going to be great. So that's, I think that's how I would risk stratify. The burden of the disease is itself evident, like he has got significant disease burden. So that's how, I would classify definitely as a high risk myeloma.
Yeah, so Pradeep, so how do you routinely classify myeloma based on factors at baseline? What are the factors that you look for when you see a myeloma at baseline?
Yeah, of course, that apart from that cytogenetic, that standard risk and high risk, that common things we see, that of course we have to see the disease burden, that patient-related factors, that age of the patient, comorbidities, and of course that organ functions. All these things we have to look into that before planning any treatment. And of course that we have to look into that cost of the therapy patient will be able to bear or not, that affordability of the patients. So,
yeah. So I think the risk of myeloma depends on multiple factors. First is age, then the burden of disease, then the disease biology where you will fit in your cytogenetic abnormalities. So when you look at cytogenetic abnormalities, maybe Dr. Chandrakant can tell, is there anything new that has come up when you say high risk in terms of cytogenetics?
I think 14, 16, the known high risk features, and 1Q again, that is one more as a high risk.
Yeah.
I think this is what I am aware of.
Dr. Asay, anything you want to add?
So basically, when you are describing high risk, except translation 1114 and 614, most of the abnormalities they will get classified as a high risk. So the thing is that the newer concept is that how many number of high risks are there? If it's a 1, if it's a 2, it's a double hit, 3 is a triple hit. So more and more is aggressiveness is there. Now, though we are not routinely doing, but at least genomic profiling, that is what is something which is which has to be done. But again, no guidelines recommends it so far. Yeah. So this is high risk. So this is something in the terms of genetics. But besides this, what we look at is a TCR LSCP. The plasma index. Basically, there is both as at baseline and a diagnosis also and a prognosis also. Because if somebody has been treated, and whether there is a decrease in TCR, if there is a plasmablastic morphology is there. So again, plasmablastic morphology indicates a poorer prognosis. Though people say that plasmablastic morphology is more associated with translocation 414 or other translocations, but again, it is not clearly evident. So all these things they matter. And last but not least is the circulating plasma cells.
Yes.
On the peripheral blood. So initially the cutoff used to be plasma cells may over 20%, around 20. But now with the newer, even if you are looking at 5%,
yes.
So that is something which is again, is poor, is plus all of us know that plasma cell leukemia, the survival is in single digit months, it's not even years.
So thank you. So thank you for highlighting those important points. That 1Q gain is something that has come up new, and as he said, plasma cell leukemia is the definition is changing, and we are looking at even 5% in the peripheral blood is a high risk disease. So roughly we see 10 to 15%. If you add 1Q and monosomy 13 also, it will be around 20 to 25% of your new myeloma that you will see as high risk patients. And that is important to stratify at the baseline because the median survival of these patients is 2.5 to 3 years if it is truly 17P versus 8 to 10 years if it is standard risk. So that is entirely different disease. Now let's move on. And so it is a high risk myeloma. This patient had extramedullary disease, high risk cytogenetics. So it's a high risk myeloma. So now let's start and discuss will you treat differently in 2023 a high risk myeloma from a standard risk. Maybe I can again start from Dr. Avinash, that how will you treat?
I think he's 53-year-old, right? If I'm not wrong. Yeah.
He is 53. He is fit.
Yeah. So
cost is not a constraint. There is no financial issue.
So I think though we do not have very, or rather I would say, good long-term data, but for the induction purpose, I would definitely consider using Dara-based induction here, especially for the fact that he has got high-risk signature, and then definitely consider auto-transplant once he achieves CR or VGPR.
Yeah, so we'll come to auto-transplant question. Yes, Pradeep. Anyone else have to differ, or you are okay with Dara-based?
Yes, patient is having P53, is having high-risk genetics. Yes, if patient is affordable, DBRT regimen will be the best for this patients. But I'm still okay with BRT, 3-drug regimens, even if that most of the patients is not affordable for Daratumumab. So I'm okay with BRT for past initial 3-4 cycle, then to assess that ACT eligibility.
Okay, so suppose Dara is not feasible because of financial constraint. Dr. Chandrakant, okay for KRT? BRT versus KRT. If you want to cook cartridge, may be generic now. So will you consider, suppose the patient is not able to pay the amount that is Daratumumab is humongously costly, but we have cartridge which is roughly 35,000 per month now with the generics available. So
I don't know the RBD versus KRT. I don't know what is the difference.
Okay. Dr. Asay, maybe can.
So I think when you're choosing, I think both the regimens really is not going to make a really difference. When you're actually using 2 or 3 drug regimens.
Yes.
So the thing is that either you're going to use RPD or so KRD is I think more of a maybe a physician's choice. I think at the end of the day, but still I feel Daratumumab. I mean myeloma basic victim, transplant eligible, ineligible, and then you go ahead. So in present world, only scientific, if I advise, Daratumumab has to be the part.
Oh, sure. Okay, you'll consider Daratumumab. So now cartridge is definitely you don't have any data, but in a standard risk group there is no difference from the endurance data. Now coming back to the question of transplant now, yes, Dr. Avinash. So transplant, will you consider a tandem is TP53, 95% TP53, extramedullary disease, single or dual transplant? The patient is fit.
So I would, I think I would actually collect definitely for 2 transplants, but I would actually see what he would respond to after the induction, and then take the call on the tandem, or if he has got a good CR and a VGPR, then definitely I would just go with a
single transplant. Anyone wants to differ on this?
Yeah, so in high risk disease, definitely the data for a tandem transplant within 6 months is there. But I am not an I'm not an transplant specialist. I am not doing
But Chandrakant or Dr. Asay, anyone has to do a tandem. So to give a context, so this was definitely addressed in 2 randomized trials, Stamina and EMN. But in 17P group, Stamina has shown a benefit in terms of PFS, non-overall survival. But EMN wasn't, EMN was with BCD and BTD backbone, but with BRD backbone, the Stamina trial has overall it was negative in terms of tandem versus single. But in 17P group, there was a benefit of doing tandem. But given this situation, right, transplant is not a costly treatment in India. If patient is otherwise fit after the first auto, will you consider? No. Okay. So, sir, final thoughts. Tandem in the TP53.
So, if you look at tandem transplant, there are 3 or 4 large randomized trials which did not classify it as standard or high risk. It was just all myeloma that it was done. If my memory does not fail me, at least one of the trials was positive, the other 2 were negative. Now, you have to look at the patient. High-risk cytogenetics, whether it's deletion P or the 1416 or 1420 and 1Q. I'm not very sure how high risk is 1Q, but the other 3 certainly are terrible. So with that, if you can collect enough cells, tandem transplant possibly may be better. You will never get a randomized trial in a selected subgroup to tell you whether that would be the right way to go. What we know for sure that if they don't achieve VGPR or CR, then a second transplant may benefit. But if you look at these high risk, there is a higher chance anyways that they will not achieve a good VGPR or CR, or they will not sustain it. So in my opinion, if I collect enough cells, at least for the deletion 17p, I would certainly consider a tandem transplant. And we've done tandem transplant. It's not a major, toxic way of doing it. Of course, there is always not many centers would store cells for one more transplant. We routinely store cells for one more transplant. So I would not hesitate doing a tandem transplant.
It is 17p.
Yes.
Thank
you
you.
don't have too many things to play with. Which drug will you play with later? That's fine.
So, Dr. Avinash, so suppose you do one single transplant, will you consider any consideration? The patient is in VGPR, so we have given 4 cycles.
So
VRT, suppose, okay?
I would definitely consider 2 more cycles of consolidation with VRT and then body plus LEN maintenance.
Dual maintenance.
Post-transplant.
So all agree with this? Okay. So what we did for this patient? So for this patient, we started on DARA VRT and 3 cycles he attended VGPR. So PBC harvest was done in another private hospital where we couldn't collect enough cells for a dual transplant. We think about doing a tandem, but there are not enough cells for a tandem. So he underwent a single auto transplant with 200 mg per meter square of melphalan. And then as we thought it is a high risk myeloma, we didn't give any consolidation. So post 3-month transplant, I started him on dual maintenance. So both bortezomib and LEN. And I think all agree on this that high risk we consider dual maintenance. Okay, for standard risk it is single lenalidomide maintenance. So what happened is, so 8 months post transplant, he came with an acute low backache. Remember he had the disease at the S1 level also when he presented, and he came 24-hour duration. He came with paraplegia and he did a PET in EMH, and there was a soft tissue mass with cord compression, D12L1 lesion. So immediately he received. It was a Friday, and we could give him radiation on the weekend, and we started him on high dose dexamethasone and single site disease. There was no other site of disease. So, but how do you treat now? So maybe I can start with reverse order. Maybe Dr. Asai.
So basically, whenever you are looking at the relapses, basically we need to see whether we are having a systemic relapse or maybe just a localized relapse.
Yeah, if it is a localized relapse.
So that's what the proteinuria for the parameters.
So SPP was negative.
So
at this time, though he had an MBAN to diagnosis, I didn't know why the SP was negative. SP there was no MBAN, but there was a disease in the PET scan, and that was a single site.
Yes, sometimes if you just have an isolated light chains also, so that also can give the SPP negativity. But we look at the free light chain assay and other things. So if it's just a localized relapse, if it's a systemic, if it's not systemic relapse per se, nothing on the biochemistry. I mean, definitely one previously MBAN and the later on. So there usually I give the localized therapy and then I continue with the same maintenance which was being given. But if there's a systemic relapse, then definitely I would like to change. So whatever the previously has been used, whatever the drugs which was there, if like.
Because he was already on maintenance.
Maintenance, yeah. So he's already on what is 1 year. So he, switched to carpil, so pomalidomide, dexamethasone, so KPD kind of regimen.
Dr. Chandrakant, anything different?
Yeah, I agree. But if there is even a localized relapse, I mean, these patients tend to have multiple relapses, so the disease biology is not looking good. Probably I will switch to maybe a DARA also is helpful.
DARA, yeah, because
this patient had good response to
Yeah,
DARA
yeah.
at baseline.
Yeah, that's a good. Yeah, Pradeep, Dr. Avinash, anything different? So you'll give KRD or KPD, right?
Yes.
So just to give the follow-up of this patient, so he was started on KPD because he was already in dual maintenance. Post 3 cycles, progressive disease, so he got CAR T cell therapy in Kolkata only, and then progressed within a month of CAR T cell therapy, and then it was a difficult journey for that patient, and he was not willing to continue further IV, so I gave something oral metonymic kind of CPD regimen, and he succumbed in 1 month. So that was the whole story of bringing this. This is a very high risk myeloma with the TP53. So we did what best for the patient, giving all possible therapy upfront, but the biology is such that these patients keep on, they have sought DFI and they relapse early. Okay. So moving on to yeah, so that was one thing that I thought in retrospect that could have done differently by giving DARA maintenance. I mean, I am not sure, sir, if you can answer, would it have helped in this patient looking at this course?
If the disease is so aggressive, it would have helped.
Yes,
you know, you need to look at it that, he's received all treatment. While you were just presenting this, I think one thing could have been that a second transplant tandem may have given him possibly a bigger progression-free survival interval for some more time, but eventually he would have relapsed. But that could have been something which could have been explored. But why didn't he collect?
So that was something which I also was, because probably whether DARA causes, and he had that S1 disease to start with, and he received radiation to start with, maybe.
That's just one area. I am not very sure that why the collection. I mean, it should have been attempted more. For the simple reason, this patient may have benefited, but eventually the disease it's a very high risk, terrible disease. Maintenance, DARA or any other apart from what is lenalidomide, I don't think would have made a major difference. And just to comment on what Asha said, I agree with Chandrakant that the systemic therapy should be given even if there is a localized area because it's too high risk. Eventually it would progress. And then we saw that eventually it progressed, irrespective of whether you give the local treatment.
Okay, so moving on, so let's discuss this case, second case. So this is a 67-year gentleman. He is diabetic, though well controlled, good PS, and he presented with fatigue. There was anemia. There were no bone lesions. The anemia workup was done. We couldn't find anything abnormal in the anemia workup. So then eventually there was a marrow and an MMAD. MMAD was 2.4 gram. It was an IgG kappa. So bone marrow was done, and there were 8% plasma cells. Cytogenetics was rhizome 11, ISS2. So lytic lesion was sacrum and L3 vertebra. So there were bone lesions in the PET scan. Okay, so maybe I can start with Dr. Avinash. How will you proceed? So it is a standard risk myeloma, unlike the previous one, and he has bone disease and anemia. So now how will you decide? Similar kind of question. So how will you proceed?
I think he's 67, so for all practical purposes, only if it is exceptional, then I would still consider him as transplant eligible and start with a triplet induction. I couldn't get his creatinine.
Is normal.
So then a triplet with VRD. If affordable, then probably DRD. So, but definitely not a quadruplet. And then try to take him through at least 8 to 12 months of treatment and then put him on line maintenance based upon the response and this thing. And the duration of maintenance, I would like to continue it as long as he maintains on it till progression.
Yeah. So anyone want to differ? He is 67 years. He's fit.
Yes.
Discussion about
Yeah.
triple triplet induction, so no quadruplet because there is nothing high risk here. So now this is about transplant. It's 67.
67 organ function is good, and in India probably that in though the Western world they have said that up to 77 we can do that eligibility, that even patient is 77 patient may be eligible for transplant. In India probably in 67 that most of our patients is become frail, so we have to assess that frailty of the patients. If patient is really looks fit and organ functions are good, then we can consider transplant for transplant. And if patient is transplant eligible, then of course that in initial 3-4 cycles of BRT best, and then to collect the cells and prepare for early transplant. So we have to decide about early versus late transplant. Probably I will that if patient is already is approaching 67, so for him it will be better
Delayed will be late.
Delayed will be late, so early transplant. And if he is not eligible for transplant, then 8 to 12 months of treatment,
and then
followed by lane maintenance for 2 years at least in standard.
So I think everybody is familiar with the determination study that got recently published. It's a randomized comparison of VRD versus VRD plus transplant and unlimited, indefinite maintenance lenalidomide. And most of you are aware of the result that there was a progression-free survival benefit, but there was an overall survival benefit. And exactly, if you see the numbers, if you give VRD 1 year, it is 35 months of first PFS. But if you add transplant to that, it is 67 months, right? And if you just give VRD and R till progression, so you can see if you do a transplant on top of VRD plus 1 year maintenance, almost 20 to 25 months of PFS or 2 years of PFS difference in terms of benefit of that. But if you see patients who received transplant in the control arm of that study, there are only 28% patients who received transplant at progression. So there was a similar study by IFM group, same design, VRD followed by VRD versus VRD plus transplant, and where almost 76% patients received transplant in the control arm, that is delayed transplant, but here only 25%. So definitely there is a stark difference in the number of transplant done delayed, but still there is no difference in overall survival. So this study lately has kind of questioned that, if you have a patient who is relatively in a borderline situation, standard risk, will you consider transplant in everyone? And again, coming back to an Indian context where first PFS may matter most to us, though there is no always benefit. Maybe Chandrakant or Asay can take.
So, whenever I counsel a patient for transplant, I always see whether this patient is eligible or does he have access to DERA or other expensive, even carfilzomib is expensive for a patient. So if a patient cannot afford those expensive progression, then I think transplant must be stressed for these patients. But if a patient can afford, maybe in that subset, if it is frail, I will differ. But otherwise, I would
even if somebody is 68, borderline, you will still push
so
for transplant.
age should not be the only criteria. And we do a strict pre-BMT workup. If the patient is qualifying, maybe 200 or 140, whatever dose of melphalan we can give, and we should do a transplant. Because if we cannot get access to effective post-progression treatment, his survival would be inferior.
So in Indian context, you say that in Indian context, it will be definitely there will be the OS curve may not look similar as in the determination. Maybe sir, what's your thought?
Even if you know, not just myeloma, but even if you look at other, even in the cross solid tumors, how many patients actually can take the second line therapy and the third line therapy? That is something which is there, and most of the times if you really look into that, it is poor performance status or progression. So if I keep a transplant as the last result, maybe salvage. I think many of them will not be able to actually undergo transplant.
So this debate of transplant upfront and delayed actually revisited after this study where determination came when there are only less number of transplant and control arms, still you have the same OS benefit. So that was the question, that in a standard risk, in a borderline age, will you really push for it, or you will just say that okay, let's continue and in terms of VRD, and what's your thought?
See, the first trial, the IFM,
yes,
the overall survival was similar because 75% of them underwent transplant.
Yes.
So, obviously, when you look at overall survival, in many diseases you will not not see a difference
Yeah.
because the salvage therapy
Is good.
may include whatever was not given earlier.
Earlier, yeah.
So, that is why in that. Now, in the second trial, there is a difference of some 5 or 6 years between the two trials.
Yes.
In the second one, obviously there are many novel agents which have come. Don't forget, even in these trials, when the novel agent comes, it is left to the physician's discretion to, use them, because the trial is only designed to answer the question of transplant and 8 cycles of RVD, right? So, with that, the proclivity or the affinity of the physicians to push them for transplant anyways comes down.
Yes.
For the simple reason that there are more novel agents which have come. You have to look at in the context of a particular setting, and of course we have to look at every data which comes in the context of our country.
Yes.
In our country, I have no question in mind that transplant must be done at the first remission. The reason for that is it certainly gives you a very good progression-free survival for a particular patient, except for the very high risk where I am not sure whether even 2 transplants may benefit or not. But if you've not been able to do transplant in the first remission, possibly it should be done in the second remission if the patient is in a VGPR or CR. To say that because the overall survival is same, transplant does not matter in myeloma, I'm not sure I would conclude that way. I would only say that the time to the next treatment will certainly be prolonged by doing transplant, and that is very important. We will never have access to all the novel drugs, and all the novel drugs also have lots of toxicities. It is not easy to just give them. Transplant has been done for 35 years. You know what the toxicity is, and it's just for the first 1 month. After that, there is hardly any toxicity, apart from a second malignancy which may happen after 10 years. So, putting all that into context, I would just look at the 2 trials and just put it in the context that transplant still is required if this is the way you will treat with induction. Because both of them have shown progression-free survival in favor of transplant. The OS did not change in one trial because 75% underwent transplant, so obviously it didn't change. In the second one, only 25 underwent transplant. Of course, there are novel therapies which come, so possibly they would have gone that, and maybe they were not then fit enough or for connection for stem cells.
That was also one of the reasons probably.
Exactly.
So we are looking at
there's too much that one has to read in between the lines to say that transplant should not be standard of care as yet.
Yeah, so if you can see, this is the post-protocol therapy in this study, and quite a few patients received daratumumab, carfilzomib, ixazomib, which probably may not be accessible to our patients, and the first PFS may matter the most in those patients. So coming back to the case, what we did for this patient is, so what happened with this patient, we treated with 4 cycles of VRD, he underwent a PBSC harvest, and he underwent a stem cell transplant with melphalan of 140 kg per meter square because of his poor lung function. He tolerated well. So then he started him LEN maintenance because he had a standard risk myeloma. He had very poor tolerance to LEN maintenance because he was 67 years, 140 melphalan, so that was also issue with him. So now he has cytopenias, and he stopped LEN maintenance after 6 months of that. And then post 3 months of stopping LEN, he came up for follow-up, and he was asymptomatic. And M-MED was 2.5 gram per deciliter, so counts are normal. We didn't do any imaging yet. And the last LEN dose he received was 5 mg, and that also didn't tolerate, and we stopped it. So yes, Dr. Avinas, how will you proceed now?
I think if he's asymptomatic, then I would keep him on close follow-up.
Yes, anyone wants to take over?
Yes, I will like to treat him, because this is a bad disease, biology, he has come so early. So there it makes a sense, post-transplant especially, if the patient is there, I think even if there is a biochemical relapse, I would like to start a treatment, because a point might come, because if they don't have a proper surveillance or they don't come on time.
Yes.
So we might have a poor performance status and other things. Just one more point to add to Dr. Naveen said, about overall survival. So maybe I think most of concept. When you have too many therapies which are, they're almost equivalent.
Yeah.
So there, I think, rather than OS, I think many of the trials now use PFS2.
PFS2, right?
So that is something we should look at, whether you were able to give the second line therapies and what was the PFS. I think that is something, but all these trials are, before that, so I think we should have. But in this case, I would like to start a treatment. I will not wait.
Anyone, any difference, Dr. Chandrakant? Pradeep?
I would observe and call after 2 months.
After 2 months. Okay. Pradeep, so 2 versus 1. You want to treat? So 2 people don't want to treat, you want to treat. What is your thought?
Probably, so within 3 months time, I have started
Yes.
increasing.
Yeah.
So probably I will like to treat this.
2 versus 2. Sir, what do you want to do? So he is asymptomatic and he has biochemical relapse. No,
So
but
you know my answer.
Yes.
Usually if they are asymptomatic,
You
I
don't
would just
treat.
watch.
You'll watch.
And the reason is you're not curing this patient.
Okay.
It's a symptom, but my intuition tells me that
He'll
he
come
will
back.
progress.
It was just very short,
Agreed, because the duration
is
of
very short.
serological progression is short. But I would just watch and call him back.
Okay.
But I know for sure that he will require treatment after some time.
Okay.
Now, will treatment now be different from when he comes back after 2 months and he becomes symptomatic? That's $1 million question.
Okay.
Most may remain okay, but if they have symptomatic, they will get treatment.
Get treatment.
If it was a free light chain disease, then I would not wait. They become very aggressive.
Okay.
If it's an F-man disease, we have patients who
can wait.
But what I want to just comment on is that lenalidomide maintenance.
Yeah.
So, the problem, what happens in science is that we forget what are the old good drugs which also give benefit.
Thalidomide.
And the sad story is that no one talks about thalidomide. There is no good randomized data to say that it is inferior to lenalidomide. I don't think there is any randomized trial of VTT with VRT. There is with VTT with VCT. It's not with VRT. So on what basis do you say that thalidomide will not work is always a question. Right? If they cannot handle lenalidomide, I would put them on thalidomide. And people may come back again after 10 years to say that this was a great drug. Apart from a bit of neurotoxicity, which is neuropathy, which even bortezomib has, and maybe a bit of constipation, that's a wonderful drug. If I were treating this patient, if the lenalidomide was not being tolerated, I would have certainly put that patient on thalidomide.
Excellent point, sir. So now suppose Dr. Rasa, you told you will treat. So how will you treat now? So this patient has stopped lenalidomide 3 months back, and that was 5 mg. So how will you restart with len-based pomalidomide? How will it qualify for len resistance?
So see, the thing is that definitely it is less than 6 months.
Yeah.
If you are supposed to look at the previous therapy, it is less than 6 months. We can look at maybe it's a resistance or not. So definitely we will have to use maybe his tolerance. So I will not be using triplet, as Dr. Nvinsa said, we are not going. So maybe KD kind of treatment, just give carfilzomib, take some kind of treatment. And as rightly said, because sometimes these older drugs can do wonders. Yesterday we had a patient who is 5 years maintenance of TAL. I told him I don't know when to stop it, but I think it's better you can. And melphalan again is very good drug. So if you are MPD kind of regimen, if you are using, that is something we can really look at, especially in the elderly population. But here I would like to use something like carfilzomib, dexamethasone.
Okay. So this was one data I could find about the len dose and whether there's some data that if you have low dose of len you can go to higher dose, but it doesn't help actually really, because even if you have on 5 milligram you are resistant anyway. So practically speaking, these patients do not benefit from len based regimen, and you can just switch to carfilzomib. So I will not cover all this. I think we have 5 minutes left. We'll discuss the last case quickly. So this patient is a 56-year gentleman. He came with a pathological fracture, expansile lytic lesion over the diaphysis. The create was high too, and there was 35% plasma cells, high light chain, standard risk myeloma. Yes. Standard questions, Dr. Vinasam, how you do it? myeloma, light chain myeloma, high light chain burden, AKI, young patient, standard risk.
So the same thing, because we'll have to right now conserve his kidney renal function as fast as possible.
Yes.
So I would consider starting him on definitely a pulse dexamethasone rather than the low dose dexamethasone.
Yes.
This is one situation where I'll consider a quadruplet because we have to bring down the disease bulk very faster.
Okay.
So probably we see D with pulse dexa and should I introduce few cycles of daratumab?
Yes.
Yes.
You said yes. And what about dialysis?
I would wait. I would wait because I have had an experience. Bad experience with dialysis.
Okay.
But the other side, conservatively managing them and starting them on treatment, people made out of it. So I would reserve the dialysis as a last.
Yeah, so that's what I was reviewing. There is a latest IMWG recommendation how to manage myeloma with renal impairment at baseline. This is published 1 month back. So what they have written is that mechanical approaches like plasmapheresis, high current dialysis has grade C, might improve, but it's a grade C recommendation. And if you see overall, if you combine with anti-myeloma therapy, it may help, but they are not clearly said that you should not do or you should do. No, they are just written that's a grade C. Somebody can choose. Yes, sir, please, sir. Yes.
Why do you want to do dialysis?
Yes.
You want to do if there is an oliguric renal failure and you have to save the patient.
Yes.
If the patient has a creatinine of 3 and the patient is non-oliguric, nothing is going to go wrong.
Yes.
Just like any chronic renal patient. They go on with a creatinine of 3 for years.
Yes.
So here, until unless there is an oliguric renal failure which is becoming life-threatening, I would agree with Avinash, just give the treatment and hopefully it will improve. Now, if the patient has a bit of a chronic renal dysfunction already, either because of a past history of chronic renal dysfunction, quite a few have, or because of the myeloma itself, anyways it will stabilize to a lower creatinine of 2 to 1.5 to 2. Then you will know that would be the baseline. Doing dialysis, just because the creatinine is high, it goes against the principles of dialysis. Where you do dialysis, if there is encephalopathy, hyperkalemia, and another 2 or 3, in fluid overload, in an oliguric failure. So, whether there's a grade C or grade B recommendation, it doesn't make sense. You have to look at what medicine has taught you for so many years, that, these patients will do well, unless there is life-threatening hyperkalemia, fluid overload, encephalopathy, on a patient who has been recently diagnosed with myeloma.
So the purpose was to reduce the light chain rather than other indication. The light chain faster rather than the other indications.
Faster light chain does not mean that it will not come down even when you get the DEXA, which is the best drug for myeloma. It is dexamethasone. Even now, it is dexamethasone followed by melphalan.
Yes.
No matter what drugs you give, So you are anyways giving dexamethasone, and you are giving daratumumab, which of course is good in this condition, and then you have the other drugs which will take some time to improve. So that is, we should not be restless, that just because the light chain disease is there, that life-threatening situation, dialysis. That is what I would do.
Okay, so I think we have this is an interesting, very nice paper from IMWG, given recommendations from all drugs in AKI. So for this patient, we did the same thing. We did a couple of sessions of hemodialysis, and this patient attained his complete renal response, and now this patient is in VGPR and then subsequent patient underwent transplant. So I think we can stop here because we have already exceeded our time. So I think we have discussed what it is. So I think we can close the session. Yeah. Okay. Are you continue? We have time. Okay, fine. Okay.
Dr. Linga, just
yes, please.
So the transplant in renal dysfunction. So what is your cutoff or what do you feel?
So, first of all, you have to see whether it improves overall survival, right? We all keep on talking that it only improves progression-free survival, not the overall survival. So, if the patient has a creatinine of 2 or less, I would, take this patient for transplant if everything else is for transplant. If the creatinine is, 2, because everywhere 2 is a cutoff for many other diseases also. If it is more than 2, I would, think what would be the complication of transplant. Now, melphalan certainly, no matter who tells what about 200 milligram per meter square which can be given, I certainly feel that a lower dose of melphalan is what you need to give for renal dysfunction, because the mucositis can be horrendous. And that is, something which is still not explained, even when they say that, melphalan does not affect the renal dysfunction. So there is something more than what we know in the world. The question of whether to do it at a creatinine of 4 or 5, I would not do it. I would continue with whatever medicines are there and use them, because anyways, the argument is that the overall survival does not improve, only the progression-free survival improves. But if it is less than 2, I would go ahead and do it, but I will always give 140 milligram per meter square. I will not touch them at 200 milligram.
So coming back to this patient received 12 cycles of ERD, best response was VGPR. He was not willing for transplant, so what next? So will you put them on maintenance, and what drug, how long want to give? Maybe Dr. Asai can
renal, I think bortezomib will be the best choice in this to put as a maintenance.
Renal, okay.
Yeah, okay. So bortezomib maintenance can be.
His renal function has improved, so yeah.
So okay.
Yeah.
Sorry. So either bortezomib or len, either of these can be used, or antidote also.
Yeah. Anyway, anything different?
This is a standard risk.
Okay. It's a standard risk, not high risk. Will you stop treatment and observe? Is there an option? No maintenance, just follow these patients.
Yeah, that's fine. That's fine even to observe.
What will you do? Will you do follow up or you will give maintenance?
I would give maintenance.
You will give maintenance. Okay. Any Dr. Avinash? Any option of thought, standard risk myeloma, so maintenance versus no maintenance, no transplant because it is not feasible. He is eligible for transplant, but not feasible because of patient choice.
So, like what sir said, I feel that we have deprived, rather not deprived, but you could not be taken up for transplant for whatever reason.
Yeah.
Then I would err on giving maintenance.
So what will you choose? Len
maintenance.
So how long you want to give? So if this patient has taken 2 years, 3 years, so there has to be some
duration. Again, as I said, we have deprived him of the benefit of transplant. I will continue till progression.
Till progression. Yeah. Sir, any thoughts?
The question remains the same. If the randomized trial with transplant gives it till progression,
yes,
they find that there is benefit. Yeah. So why those who don't go transplant should not give till progression? The question, there's a simple answer to it. And especially when the intensive treatment has not been given. Yes. So all the more reason that you must give it.
You must give it.
Till the progression. That's quite simple, Nigaraj.
Thank you. So thank you my panelists, and thank you sir. And yes, Avinash wants to make a comment.
I just wanted sir to talk about the famous teaching of twist concept of transplant and myeloma. So sir always teaches us about the concept of
time
without investigations, treatment, and then
yes.
We are running out of time, but I'll just say that the twist phenomenon came when the novel therapies were not there.
Yes.
And we knew that transplant may not improve the overall survival, but improves the progression-free survival. So twist was time without intervention and symptoms, yes, and treatment. So if you did transplant, the patient remained without symptoms and intervention for a longer time. If you did not do transplant, then the patient had symptoms early, you treated the patient again, and then you go on. So, the overall survival may not be different, but the twist period is longer in transplant without any treatment. And that is very important for quality of life of a patient. Yeah. Coming to the hospital every week is obviously, no one would want to do it. If you can keep the patient away for many months or a year, that is almost. So, that was the logic of that twist.
So the PFS benefit is without any treatment. So this, unlike other treatment where you keep on giving and you get the PFS.
So that's the. I mean, now of course you have maintenance. That time there was no maintenance.
Yes,
also.
yes.
So here you are still giving some maintenance.
Yeah.
Which possibly may still be okay, but to give the whole triplet and quadruplet again, then the question arises: why will you then do transplant?
True.
Don't do transplant.
So that's also important because this is the last slide of mine where you see each line of therapy, almost 30% patient drop out from the treatment. They remain eligible to treatment. So if you keep them on some time of treatment, maybe they will be in a better performance status to receive the next line of therapy. That's important to consider in myeloma, that especially in the first PFS where you think that first PFS may drive the overall survival. So with that, thank you and thank you all and thank you and thank you sir. Thank you.
Thank you so much, sir. We'll just felicitate everybody and then we can go on about a final expert from Dr. Naveen. Oh, already given? Sir, we are surgeons, we don't understand head and tail out of all this. So, already done, sir?
So, I can only say transplant is still the standard of care.
Works for us.
Yes, and the CAR-T is something evolving and it's years right now to see whether that will replace transplant. That's all the surgeons need to do. And refer the patient to the medical oncologist.
Always. So, sir, could you please felicitate everyone? So Dr. Aksh, okay. Go on.
Just one comment, the final. The point is it's always a pleasure to have all your students in a panel. And then it's not a great moment because then you start feeling very old now. But it's a bliss to have all your, good and bright students as panelists and, moderators, and then they teach you so much in one.
But do they dare to differ from your opinion?
Sorry?
Do they dare to differ from your opinion?
Well, they are just being respectful by not differing. In private they differ with everything.
I was learning my.
Good afternoon, everybody. We'll start with the soft tissue session. So, chairperson for the session would be Dr. Mukul Bhattacharya, Professor and HOD of Department of Orthopedics, SSKM Hospital. So please join us on the stage. Dr. Kanchan Bhattacharya, Consultant Orthopedic Surgeon, AMRI Hospital, Salt Lake. The moderator would be Dr. Ashish Guria, Professor and Director, Homi Bhabha Cancer Hospital Research Center, Chandigarh. So I'll just call everybody. Yeah. The panelists would be Dr. Kaushik Nandi, Consultant Orthopedic Surgeon, Medica Hospital. Dr. Deepak Roy Chaudhary, Senior Consultant Orthopedic Surgeon, Saroj Gupta Cancer Hospital. Dr. Dipanjan Majumdar, Consultant Radiation Oncologist, Narayana Super Speciality Hospital. Dr. Swarnendu Banerjee, Professor Medical Oncology, Calcutta Medical College. Dr. Ashutosh Daga, Consultant Medical Oncology, Narayana Hospital. I guess they are on the way. Okay, so shall we start? And Dr. Vikas Kapoor will be joining us in 5 minutes, I guess. So, sir, over to you, please. Thank you. Okay.
I'll introduce myself. Hi, I'm Ashish, and I'm an orthopedic surgeon who got trained in musculoskeletal oncology. I served about 16 years in Tata Memorial, and now I've moved to Tata Punjab. We've started a new hospital in Punjab, and I try to manage that hospital in the best possible way I can. So, as usual, thanks to the chairperson, sirs, and the panelists for being here. And sarcoma is a rare specialty, and we can actually see with the number of the people present in the August audience. But yes, it's a very interesting subspecialty, given the sense that if these tumors are treated properly, then we have very good outcomes. The palliation is definitely less as compared to other tumors like lung, esophagus, and other morbid tumors. But the management has to be quite precise. It's a new branch, and because it's a rare tumor, so we don't have many specialists who deal with this. The organizing team, Dr. Dhar and Dr. Kaushik, has asked me to do this moderation where I need to discuss the management of recurrent and relapsed sarcomas, but I have also included a few things which includes their initial management as well. So we'll go ahead with the discussion. Okay, so we'll move ahead, and I thought it would be nice if, so we have medical oncology colleagues, sorry, not. So if you can just speak for 2 minutes about your specialty and where you work, everybody will know each other and it will be nice.
So I'm Dr. Ashutosh. I'm working as a consultant in Narayana Hospital, Kolkata.
Thank you.
And for the last almost 2 years.
You deal with medical oncology and sarcoma specifically.
Yeah.
I am Dr. Deepanjan Majumdar, right now as a consultant radiation oncology in Narayana Specialty Hospital. So I have just joined Narayana Specialty 1 year back. Before that I was in Mumbai Cancer Center in Kolkata, and prior to that I was in Conclave Hospital, and prior to that I was in TMH. So I had the privilege to work with you actually when I was a senior resident at the time in TMH.
Thank you.
Good morning, I'm Dr. Kaushik Nandi, consultant musculoskeletal oncologist at Medica Hospital and HSK Mighty General Hospital, Kolkata.
Thank you, Kaushik.
Me, Dr. Deepak Raichururi, a surgical oncologist working at Sarojit Cancer Center.
Thank you, sir.
No, Dr. Kanchan Bhattacharya, the window dressing here. Nothing to do with oncology. I know who you're referring to.
Sure, sure.
So I'm Professor Mukul Bhattacharya, head of the department of orthopedics, IPG.
Thank you.
Thank you. Sir.
Okay, so we move ahead. First case, 12-year-old girl, and she was having pain in her knee and just below the knee, the upper leg, and there was swelling which was growing rapidly. So I think I'll start with Kaushik. Kaushik, this kind of picture which you get in a girl which is 12 years old, rapidly growing swelling, and this is the X-ray. What are your thoughts?
This clinically immature patient with this kind of X-ray. The X-ray is showing a mixed kind of lytic sclerotic kind of lesions. On the X-ray it looks aggressive. There is a periosteal reaction on the lateral surface. Matrix is ossified matrix, and zone of transition we cannot make out because it is not a purely lytic lesion, so zone of transition I'm not able to comment on.
Sure.
So skeletal immature patient with the aggressive variety of periosteal reaction, ossified matrix, and so my differential will be we are dealing with a primary aggressive bone neoplasm for this patient.
Okay. So exactly what you said, that on radiology it looked like quite an aggressive lesion which is osteosclerotic with aggressive periosteal reaction. There is an ossification of the extensor, soft tissue and osteoid matrix. So probably we are dealing with an aggressive lesion. So this is the MRI. Does that make you more wise, Kaushik? Or?
Yes, sir, definitely. So as you can see, the T1 and T2 images showing a hypointense kind of altered single density. Almost the entire marrow is replaced by the disease process. The entire marrow is replaced. There is no entrapped fat, which is very classical sign of infection. So from radiology, we can exclude the infection. So most probably we are dealing with a primary aggressive bony neoplasm. And considering the soft tissue, paucity of the soft tissue and the matrix on the radiology, most probably our radiological differential will be an osteosarcoma.
Okay. So let's have a small opinion, and maybe we'll just have a raise of hands. Many people talk about doing needle biopsies and doing open biopsies. So how many of us wants to do needle biopsy? Okay. Anybody for open biopsy? Okay. So it's quite clear. So we have a very clear mandate. So it's quite clear that now we don't do open biopsies at all, especially in these areas where we can get unnecessary contaminations happening. So needle biopsies are good enough. Kaushik, I have marked the arrows, which is marking towards the anterolateral side, which is targeting the soft tissues. Do you think this is the right area, or do you want to change any direction? And what are the thought process when you plan a biopsy for these patients?
Sir, the tolerance under the dictum as per the textbook, biopsy should be done by the same surgical team who are conversant with the definitive surgical plan. For proximal tibia, aggressive bony neoplasm, whatever is the reconstruction process, the resection will be a osteoarticular resection in this case. So the surgical incision is in the anteromedial side. So if we put the biopsy needle from the anterolateral, seeing the soft tissue in the anterolateral surface, so it will be very difficult to resect the biopsy scar in mass. So it may require some plastic surgical reconstruction. So my trajectory of the biopsy will be from the anteromedial surface to the subcutaneous moving.
Okay. So basically the principle is saying that you need to plan your biopsy scar greater being incision will be, some people are comfortable, most of the people will be comfortable through anteromedial sort of biopsy scar because that's the most common, but you can do through anterolateral also. Another point which is to be highlighted here is that if you look at your imaging carefully and if you can target the soft tissues, the yield is quite equivalent to targeting the bone as well. I saw Dr. Prakash Nayak. I thought we'll take his inputs as well. Okay, we'll call him a bit later. So do we have any pathologist here in the team? No? So okay, I thought we will have some pathologists and we'll have some opinions, but basically I'll just read it for you. So we have these bizarre cells which are hyperchromatic and there are mitotic activities which you can see here, and there's ossification which is intermingled between it, which is not a normal ossification, and it's an aggressive ossification. So this appears to be an osteosarcoma. We'll move ahead, and I'm going to start from this side, and let's have this question: ideal metastatic workup for an osteosarcoma high grade. What do you feel it should be?
HRCT thorax and bone scan.
Okay. Any
same.
Yes, okay. So,
okay. Any difference of opinion?
So HRCT thorax and bone scan is the classical staging protocol, but any institute or infrastructure equipped with the page CT scan can go ahead with the page CT scan also, though it is not classically just with the osteosarcoma.
So I agree. So basically, actually everybody is right. When you are talking about the staging for osteosarcoma, classical teaching is that we do an non-contrast and CT scan of the chest, and we do a bone scan which is good enough to pick up any kind of metastasis. But nowadays, so the problem with this modality is that you need to have, Dr. Nayak is it. Dr. Nayak, if you could be on the first row, and we can rope you in between for some expert comments. The only problem is that you need to have two separate appointments, one for CT scan and one for bone scan. So now people have started preferring PET CT scan in osteosarcomas as well, but obviously we need to be very careful when we are ordering this because the cost of PET scan is much higher as compared to doing a CT scan of the chest and bone scan. So there are some institutions where there is hardly any difference between if we do a CT thorax and a bone scan versus a PET. So either modality is okay, but it's only the difference of the cost which needs to be remembered. Okay, so no metastasis to start with, and the treatment was planned that as standard we'll start these patients on neoadjuvant chemotherapy, we'll reassess, we'll do local control and adjuvant. And so there are multiple drugs available, and let me speak to our medical oncology colleagues and ask them, what are your favorite drugs when you are trying to treat a high-grade osteosarcoma? Is there any preferential regime which you opt for, and any reasons for that?
So I think, sir, in my clinical practice, I usually rely on at least doxorubicin and cisplatin-based chemotherapy. 2-drug, 3-drug regimen is always debatable. But I usually use IAP protocol, OGS protocol as a neoadjuvant chemotherapy in my clinical practice. Preferably because I think there will be toxicities, but it's like manageable toxicities with this combination of chemotherapy.
You use IAP regime?
IAP.
Okay.
2 cycles of cis-doxo followed by 2 cycles of doxo and ifosfamide, followed by reassessment for definitive.
Essentially the same IAP regime you will use. Okay. So these are the main queries which we have, whether you want to use a methotrexate-based regime or an ifosfamide-based regime. But any specific reason why you do not want to use methotrexate-based regime?
So upfront methotrexate-based regime, the evidence is not enough to use upfront methotrexate-based regime.
Evidence is in terms of any additional benefit over IAP or
evidence in terms of an additional benefit over IAP in the upfront setting.
So if they are equal, then why don't you use MAP than IAP? This is what I'm trying to understand.
Because in MAP also high dose methotrexate, if given properly, is not at all a myelotoxic. Because in the trial where 8 to 12 gram per meter square is given over 3 to 4 hours followed by leucovorin rescue, there the cutoff is HB equal to 8 and platelet 50,000 and ANC 500. So it is a very manageable toxicity. But the thing is that we require the rigorous methotrexate in all institutions, more so in the government institutions, measuring methotrexate level at 42 hours, 48 hours, 54 hours, 60 hours. It is not there, and it is very costly to do outside.
Okay.
Mainly logistics. Yeah. Mainly logistics.
Yeah. So let's, for example, you are working in Medica. Medica is a beautiful hospital we visited yesterday, 200 beds, almost everything is available. You've got enough beds to admit, you got fantastic labs to do your blood drug level monitoring. Still you would prefer IIT?
So I'll not say that any particular regimen in osteosarcoma is a superior regimen than the other. Both can be used, and I preferably use it because there are two. One thing is, as Dr. Shanabindu said, the logistics part. Second is, I think to give methotrexate, you need to have a very well trained team to give proper hydration, monitor it. Post methotrexate also, you need to give hydration, leucovorin rescue, everything. So that becomes a very difficult part if you don't have a proper oncological setup. So in that context, I think IAP is a very straightforward chemotherapy to give, and we don't need any post chemotherapy monitoring for such kind of patients.
Sure. So I think third question we already addressed that 3 drug regimes you always use. Any thought on adding a 4th drug? Any advantage or?
No, I think we have data for that. Adding something beyond this has not helped. It has only increased the toxicity. So no, nothing beyond this.
Sure. I'll just tell you what happened with this patient. We have this OGS 2012 protocol which we have been practicing, which is basically a slight modification of IAP regime. We give 4 cycles of neoadjuvant chemotherapy and we sandwich surgery between neoadjuvant and adjuvant. So we did that, and this is the protocol what we follow, and which all of you have already discussed as well. So we did the assessment and we planned the surgery. We ensured that soft tissue margins are well taken care of, and
Sorry?
we thought
Okay, I'm Dr. Kapoor, Dr. Vikas Kapoor from Medica Oncology. I'm an orthopedic surgeon and working there. It's the Department of Orthopedics which I represent here.
Thank you. Welcome, Dr. Kapoor. So this was osteosarcoma, non-metastatic, and we planned this and we ensured that we have adequate margins all around the soft tissues in the bone, and we did resection and we reconstructed with the megaprosthesis. So the next question which arises is that we assessed, and you saw that even in the post neoadjuvant assessment MRI, you had soft tissue component. So necrosis was about 80%. So the next question is, and let me start with Kaushik now. Kaushik, this case comes to MDT, you have operated these patients. Margins are free, but necrosis is 80%, which is not a great thing to have. So what will be your discussion in MDT? Do you want to continue with the same chemotherapy? Do you want to change the chemotherapy? What will be your thought?
So margin status is tumor free when tumor necrosis 80%, definitely poor prognostic factor. Will discuss with the relatives, and in the discussing the MDT, we have medical oncology colleagues. As far the evidence goes, there is no gross survival benefit in changing the drug protocol. I think Shona will be more able to discuss that. So generally we don't follow to change the protocol based on the necrosis.
So you won't change the protocol?
Yes.
Since Euramos trial, till now the data available has failed to show any benefit over high-dose methotrexate, over the standard of high-dose methotrexate, over the standard adjuvant therapy. I will stick to the old adjuvant therapy, that is 4 cycles of cisplatin plus ifosfamide.
So you will continue with the same? Okay. You also agree with
Yeah, I think it's more of a prognostic rather than predictive.
So let me move ahead and ask, you are also sitting in the MDT and we are having this plan, and then one thought comes, oh, necrosis is not great, it's 80%. Will there be any advantage of adding adjuvant radiotherapy to such cases?
So frankly speaking, in this particular cases of osteosarcoma, we generally used to give the systemic therapy more commonly. Rather, the level of radiation is a little bit of not that significant. So I don't feel that offering radiation will be of great help, and rather stick to the adjuvant systemic therapy.
Sure. So we move ahead, and now we are following this patient at 12 months. Patient had an X-ray which was having some suspicious lesions, and then we went ahead by doing a CT scan of the chest, which shows 3 mets on the right side, 1 met on the left side. Deepak sir, what are your thoughts?
With this,
it's 12 months, and on CT scan of the chest there are 3 mets on the right side and a met on the left.
then we should search for the other parts of the body, whether it has metastasis or not.
We did a bone scan, sir, and there was no other metastasis. So these were the
Then I shall continue the chemotherapy as because there is metastasis, and if possible, as because the small mets are on the outer side, not inside, is it possible that can be excised?
Sir, chemotherapy was already over, and actually this is 12 months after completion of the adjuvant chemotherapy.
Then local excision is okay, but when there is metastasis, we have to think for a chemotherapy.
Okay. So, as sir rightly said that, in osteosarcoma, we need to ensure that you achieve R0 surgically, only then there is any benefit of doing any kind of treatment, and similarly, we need to assess these scans very carefully and see whether all these lesions can be removed or not, and then again discuss regarding the chemotherapy. So options in front of us were like doing only surgical excision, chemotherapy first, like a second-line chemotherapy and then surgical excision, or excision followed by chemotherapy and radiation to the lungs, or just best supportive care. So I think after sir, I'm going to ask Kaushik, what's your thought? Or maybe we can just go in the same sequence.
Sir, after 12 months of completion of chemotherapy, so the disease-free interval is 12 months.
Yes.
Patient presenting with 2 to 3 lung mets on either side. 2 lung mets on either side.
3 lung mets on one side and 1 on the other.
Okay, sir. So we'll discuss.
These are peripheral lesions, not very big lesions.
So we'll discuss in the MDT with the thoracic colleague regarding whether metastatic with R0 resection is possible or not. If it is resectable, R0 resection is possible, we'll definitely go ahead with the R0 resection. And we'll also discuss with the Medica Oncology and Medica Oncology colleagues whether they will be interested in considering the short P5, whether they will be interested in adding the systemic therapy post-metastatic.
Sure. So yes, we all agree that excision has to be done and R0 resection must be achieved.
Since it is peripheral, metastectomy followed by metastatectomy followed by observation and follow-up every 3 months. Not to administer chemotherapy.
What's your opinion?
So I will definitely try some systemic therapy post-surgery. I know the nature of disease, it's come back within 12 months. I know the nature of disease that's come back within 12 months, so there will be some other micrometastasis which is not being picked up on the scan. So So I'll try to give some chemotherapy post-surgical resection.
So now we have two different opinions. So what do we do? Let us understand the rationale of these so that we know that why. So the query is basically to give chemotherapy, second-line chemotherapy or not. That is the main question. So R0 we need to do. That's all right.
The importance, here the question is that whether as an adjuvant we will use the second line or keep it in reserve. One with a DFI of 1 year or a TFI of 1 year, by 75, it has a more than 90% chance even with urgent chemotherapy, that is the second line as adjuvant, it will relapse. So better we keep it for the later.
Okay. Now let me rope in Dr. Nayak here. Prakash, 12 months DFI, somebody can give a mic to Dr. Nayak. 12 months DFI, osteosarcoma, 4 lesions, bilaterally, peripherally placed, looks like R0 is possible.
So I think the evidence is very clear on this. As far as we can get an R0 and a complete resection with all the metastatic disease, that should be our first goal. When it comes to giving adjuvant chemotherapy, until 18 months, most centers in the world will not choose to give any further adjuvant chemotherapy with a TFI of 12 months. Between 18 to 24 months and later, there's some data to suggest that salvage chemotherapy may add some value, but what is clear is the first and the only important thing is an R0 resection. The value of that additional chemotherapy is minimal at best.
Thank you, Prakash. So yeah, we've got multiple trials which looked at the toxicity of the chemotherapy and their benefit. So in osteosarcoma specifically, it behaves very differently from Ewing sarcoma. You have labs and which are within sort of 18 months to 2 years, as Prakash said. There is no added benefit of giving a second-line chemotherapy. You are just adding toxicities. The same thing happens if you have relapsed very late. Like for example, if you relapse after 3 years, 4 years, then again there's hardly any advantage of giving a second line of chemotherapy. It is the duration of relapse which is somewhere between 18 months to about 36 months, or let's say about 48 months. That is the period where people have tried with some luck, but again, the evidence is pretty bleak on the expected advantage. So now my question is to my medical oncology colleagues again. You have given IAB protocol earlier. Let's, for example, this DF5 was about 24 months and you are planning to give a second line chemotherapy. What will be your choice?
Gemdosi.
Gemdosi? Yeah. You're not happy with MAP again?
No, Gemdosi. Because MAP is P, and P has a nephrotoxic potential. And A is cardiotoxic. They have used 25 into 3, 75 into 4. So already 75 into 4, 300, so I have a therapeutic window of 100. And I take it that there was no residual nephrotoxicity from the initial regime, but even they are adolescent, young adults. So I think how the longer the time they live, the quality of life should be better. There should not be any end organ damage. So I will go to Gemdosi. At least they don't have any effect of the end organ other than the myelotoxicity. The residual end organ damage other than myelotoxicity.
So we are talking about palliative intent, right?
No, this is curative.
Curative.
This is curative intent.
Okay.
So palliative, I don't think in osteosarcoma we do much of chemotherapy in palliative. This is curative. You are giving the best chance to the patient. I'm not looking at what will happen later on, because this is the only chance you have.
I'll try to switch to high-dose methotrexate-based chemotherapy. Maybe I'll not add adriamycin because of the cumulative cardiotoxicity, but yes, definitely high-dose methotrexate-based chemotherapy.
Yeah, so this is what we also follow internationally as well, that you give methotrexate-based regime where you decrease the load of adriamycin and you basically use a modified MAP where methotrexate is the main regime which helps you to get the action, because otherwise there are no other agents which have been proved to give a better outcome. So any role of immunomodulators? So we had this magic drug which looked like a magic drug, MTP, minimal peptidase, which came into vogue for some time, and so any thoughts on this?
I think so. Only the data is there academically, yes, but never used it. Don't know the outcomes of that in real life.
Yeah. So there was only one trial which could show some result, but there were quantitative interactions between ifosfamide and MTP, and hence it's not very popular. But yes, it has shown us a small window where we can plan this. Quick questions. I know we have spent a lot of time on this case. Any thoughts on perioperative or maintenance therapy, like metronomic therapy? Yes, no.
Maintenance therapy, see, the question in fact is a very individualized question. This oral metronomic therapy, first of all, it has to be told to the patient.
No. What's your thought? You practice, you don't practice?
Yeah, I practice maintenance therapy with oral metronomic chemotherapy.
For how long? For how long?
Till progression or toxicity.
And that may be pretty long, isn't it?
See, the patient, what you have mentioned, maybe I won't get so much time to allow my oral metronomic go on indefinitely. Well, otherwise, if the patient gives me a chance, then I want to give the therapeutic benefit of 1 year.
So isolated pulmonary metastases, which are 4 or less, the survival, 5-year survival after relapse is about 30%. So 30% of the patients are going to live lifelong. So are you going to do metronomic therapy lifelong?
No.
This is what exactly I'm trying to ask.
In that case, no, certainly not lifelong. It will be a maximum for 1 year.
So we also looked at our metronomic results, but they're not very great, to be honest. And whatever little benefit is there, it's there in EVs and angios, but we don't do it much in osteos. Quickly moving ahead, and I'll start with Sir. This is case number 2. We don't have screen here. Can you please ask somebody to help us with the projection of my slides on the TV? Or what we can do is, maybe we all can sit there and we have the slides here, we can discuss from there. Oh, that's okay, that's okay. Or we can shift there and whatever. Who's late? Yeah, I think that would be better. So I'm sorry for inconvenience, but because we are running short of time, if we can sit here in the first row and so this is 54-year-old male without any comorbidities, and he has this big lesion which is there in the proximal thigh, which measures 15 into 10 centimeters since 3 months, rapidly growing. It was initially on the examination when we did MRI, the size was actually much larger, about 20 centimeters in size, is abutting the neurovascular bundle. So how do we go ahead with the diagnosis and investigation of this lesion? What are your thoughts on this?
First of all, to have diagnosis, we have to go for a histopathological test. And then when we land after histopathology, what the possibility or what is the true disease is, then we can think of the further management.
Sure, sir. So we did a biopsy. As in soft tissues, we do core renal biopsies or the true cut biopsies. We ensure that we have at least 5 to 6 scores so that the diagnosis is done appropriately. We look at the imaging carefully to avoid the necrotic areas. This was the slides. Sorry, we do not have a pathology colleague. We can skip that, and we know that it's a synovial sarcoma. We also did the translocation studies, which shows that it was negative, but it was diagnosed as synovial sarcoma. Sir, so we went ahead with the investigations. In the investigations, we did non-contrast enhanced CT scan, which shows bilateral multiple lung nodules. So, what will be your thought and guidance to this patient?
Synovial sarcoma is very virulent type of the disease, and we have to think of excision of the tumor and tumor containing bone. And we shall consult, I shall consult the medical oncologist whether there is scope of medicine for the management of this case.
Okay, so let's move on next. As sir has asked that we need to look at the medical management in this case. Huge lesion which measures maximum about 20 centimeters in size. It's got bilateral multiple lung nodules. So how you will deal with it?
So I think, sir, looks like a palliative case to me. But again, there are two sets of data that if there is upfront metastasis versus the synchronous versus metagonous metastasis, people who have a metagonous metastasis might have some benefit from metastectomy as compared to synchronous. So for me, it looks like a palliative case. So if it's a palliative case, I'll try to give IA chemotherapy in this because it's synovial sarcoma.
Yes.
Synovial sarcomas are very much ifosfamide sensitive tumors. Even though it's a palliative case, maximum of the data for the STCs for the significant doxorubicin, but I'll try to squeeze in ifosfamide in this particular case.
Okay, okay. Very right. So basically first we need to decide whether the intent is palliative or curative, and that will basically depend upon the disease burden in the lungs. I'm sure, Kaushik, you saw the imaging surgically accessible?
RGB resection is, as far as the local series concerned, RGB resection is definitely possible, but we will be very close in the vicinity of the neurovascular pericardium.
Sure. So, would you like to take help from your colleague for any kind of adjuvant therapy locally? Preoperative radiotherapy?
Preoperative radiotherapy we definitely think of in this case to make the margins sterile.
Okay. So, what's your thought on preoperative versus post-operative radiotherapy? You prefer giving it preoperatively or post-operatively, or you take a combined decision with the surgeons? How you assess?
So first of all, in case of the bone and soft tissue management, I always have to take the input from the surgeon, because it is not possible to take a decision on radiation solely, because everything is intertwined. The thing is, definitely pre-op radiation has a great role, but most of the time we end up in treating in the adjuvant setting. The pre-op radiation has the benefit in terms of, because it has the less radiation portal. The radiation portal is shorter, and it will help to downstage the tumor, and so the surgical colleague will have some benefit on taking this mass out. But the thing is, the problem is in the trials where it has been studied, that it has been seen that in case of the pre-op radiotherapy, the acute complications in the range of 30 to 32% compared to the adjuvant, where it is around 15 to 17%. So, and these are the control setup. So that is why probably we are not very much keen. But if the surgical resection is not possible, or surgical colleague is insisting that probably the NART will be helpful, we are happy to help. The thing is, whenever we are going to give NART, probably the dose will be 50, probably not, we will give 50 gray. The thing is, after the surgical margin positivity, there is again there is a debate whether we have to give the boost or no boost, because there are the conflicting data in that. But in case of the adjuvant post-op setting, the most important thing, if you are going to do the ISRT, then probably that is the best option, because we can actually totally spare the patient for coming to the hospital, the remote, in the distant location. Most of the time, the radiation specialty will be distant from the whole hometown. We will actually spare the patient from a 6 weeks radiation protocol. In that case, if it is possible, we like to prefer ISRT, rather the brachytherapy in an adjuvant setting. But yes, there is definitely a role of NART. In this particular case, I will be happy to do NART because I think the surgical colleague will like to have NART. Yes.
Avoiding the vessels.
Yes.
Let me go to Dr. Nayak. Prakash, you have great experience working in two big institutions, one in Toronto, one in India. Both have very different school of thoughts when we talk about adjuvant radiotherapy. Can you just highlight salient points for each? And today, with a lot of experience working in both institutes, what's your take on this?
Very clearly, as Dr. mentioned, the dose is lesser. It's more defined around the tumor. When it comes to side effects, you have to choose between early and late. And we clearly know, as you said, that with preoperative radiotherapy, the early side effects which are reversible may be more, but the late side effects which are permanent, which include fibrosis, edema, the risk of radiation-induced fracture to the bone, dose to the bone is much less. So whenever possible, it's best to prefer preoperative radiotherapy, accept a slightly higher risk of wound complications because it's reversible. However, in India, we have to consider, we have to be pragmatic, because oftentimes we may not be able to accommodate a lot of patients for preoperative radiotherapy because it has to be done. The major advantages are only when you use IGRT. So which will mean about 5 to 6 weeks pre-op, a 6 weeks gap and then surgery. A lot of our patients travel long distances and have to lose out on work. Many may be daily wage laborers. Plus, if they have a wound complication, they may have to live longer in the city. And so considering all these pragmatic considerations, social considerations, even today in India, excision, R0, allowing the wound to heal, and then letting them have radiotherapy closer to home is the norm because of social considerations. But when it comes to science, particularly in this case, preoperative radiotherapy will be of great help.
Any survival advantage with each?
So the survival advantage when it comes to the randomized trial is equal. The local control is equal. There is some recent data with big centers with a lot of preoperative irradiation showing that they may have some survival advantage. But I will take that with a pinch of salt because it's not prospective, it's based on retrospective. So when it comes to local control and overall survival, it is safe to say that it's likely to be equal in both.
Okay. So let me come back to my medical oncology colleagues. Shwedu, what's your best chemotherapy regime for this case for palliation?
I+.
Okay. He is quite well preserved, 54. You want to go ahead with single drug or you are definitely
I+.
Okay. And if he's like, let's say, 74 years old, so change his age by 20 years.
Then single agent, liposomal doxorubicin.
Okay. Yeah. Thank you so much. This was so clear. And we already discussed about the role of radiotherapy in detail as well. Quickly, I have 5 minutes left, and I'm going to my third case. 15 years.
One question for the last case. So considering the soft tissue extension in the MR, it's almost covering the anterolateral, anterior, and the anterior, 3/4 of the circumference, and it's a huge long disease craniocaudal. Would you recommend or discuss any kind of option of prophylactic fixation, considering the future possibilities of pants fracture post-radiotherapy?
Yeah. So, Thai females, elderly, overweight, where you are stripping a lot of periosteum, all these are risk factors which leads to high incidence of fractures post-radiation. So yes, if you are stripping a lot of periosteum, which is in quite a big area. Earlier we used to be quite subjective about it and used to assess it, but now we have various nomograms available. So all these are parameters basically which are there: recurrent disease, earlier radiation therapy. So all the factors which you need to consider. In this case, to be honest, the disease was not very close to the bone. It was an anterior disease which was close to the vessels more. So in this case particularly, I don't think so I'm going to do any kind of laning. But yes, if you have a disease where you need to strip a lot of periosteum, yes, you will do prophylactic nailing to prevent fractures as well. And as Prakash also said, that when you are doing a post-op, your dose is high, and again you have the risk of fracture, which is more than doing a pre-op. Quickly moving on to next case, 15-year-old girl. I'm just coming to diagnosis straight to save time. It's an Ewing sarcoma, which involves diaphysis of her femur. This is a large volume disease, as you can see here. Histopathology, putting it as Ewing's. On PET scan, 2 nodules in the right upper lobe. One is 1 centimeter, another is 1.5 centimeter, which are suspicious of meds. What will be your options for the treatment? And we'll start with Kaushik and then we'll move to the right. 2 lung nodules, Ewing sarcoma of the thigh, large volume.
Considering the histopathology, the Ewing sarcoma is very sensitive to chemotherapy and radiation, and 2 lung nodules, metastatic lung nodules at presentation. In Ewing sarcoma, until and unless the patient is having a visceral plus bone mets and multiple non-resectable permanent mets, we very seldom declare Ewing sarcoma cases.
So let's go step by step. Will you declare her best supportive care?
No, sir.
No. She's got a very limited disease in the lungs, though it's metastatic, but still you will treat with curative intent.
Yes.
You will resect or you will give chemotherapy first?
Definitely we will plan for the neoadjuvant chemotherapy in the AHS.
Okay. So basically we need to treat her with a curative intent and with a multimodality management. We'll start with the induction chemotherapy and then plan for surgical resection of all the disease, whichever we assess. Fine. Just because time is less, I'm just hurrying it up. So this is the MRI post induction chemotherapy. There is almost complete resolution of the disease at the site, and even lung lesions have also resolved. You can't see them. Let's move next. And particularly to ask you, what will be your thought on the treatment of the lung disease?
Lung bath will be helpful in this case.
Sorry?
Lung bath will be helpful in this case.
Will you give lung bath?
Yes.
There's no visible disease available?
Yes.
Okay. Kaushik, what about local? You want to treat with definitive radiotherapy? You want to treat with surgical excision?
So as for the pre and post chemo MRI, this is a definitely surgically resectable disease with arterial resection. So wherever it is resectable in case of Ewing sarcoma, if there is a lot of debate, we will definitely go for the surgical resection, the arterial resection.
Okay. Let's go to Sir. Sir, we just changed the scenario a bit. 2 nodules are still persistent. There's a good response at the site, but there is a reduction in the size of the nodules, but they are still there. Then what do we do?
An excision of the nodule first.
Okay, and then we will
then go for the local treatment.
Sure. Okay. So as told by Sir, absolutely right, that if you have the residual disease in the lung, then you will excise them, and then we'll again go ahead and do the lung part. So we did the same thing. We did the intracranial resection. Just give me 1 more minute if it's possible. Okay. We sterilize the bone with liquid nitrogen and put it back. It's not moving now. That's stuck. Okay. Yeah. Okay, I'm going to skip that. 6 months follow-up, union happened nicely, all looks good. Post completion of maintenance chemotherapy, this patient came with a history of pain in the neck. MRI showed a metastatic lesion, which is there in C4, and now I'm getting to MDT. And I would like to ask my medical oncology colleagues, we did the PET scan as well. So this was the only site for metastasis. So skeletal metastasis. What will be the treatment options?
This is the only site, so I will still give a curative treatment. Local treatment, whatever is feasible, either RT or either a surgery. And then again I will go for some form of systemic therapy.
Okay. So this is how it's Your opinion is same or any different or?
No, my opinion is same, but I will discuss in the MDT about the role of high-dose therapy with autologous stem cell rescue. Maybe a tandem autologous transplantation may help in this type of settings. That I will discuss in the MDT.
Okay, great thought. So definitely, so with a solitary skeletal metastasis, this patient is still to be treated with curative intent. And unlike osteosarcoma, we always consider this as a systemic relapse, and we always add systemic therapy along with the local therapy. And this is what was done. We started with salvage protocol and radiotherapy to the neck. There are multiple protocols. I'm just not going into the details. So the patient received radiotherapy, and we give a hybrid regime with BTC and TI. Topotecan and irinotecan are the agents which are easily administered and have decent sort of tolerability, and these are the various regimes available. And yes, then we have the data which now from Euroimmun's trial, the subsection analysis, which shows that in select group of patients which have longer DFI, which have relapsed at a very small amount of disease, they can get benefited with autologous transplant. Thank you so much for listening to me, and thank you so much for the chairpersons for chairing the session, and the panelists for giving your inputs and making it interesting. Thank you so much.
While Sir is setting up his presentation, the next topic would be margin assessment in soft tissue sarcoma, current state of evidence. Over to Dr. Prakash Nayak, Consultant Musculoskeletal Oncology Services, Department of Surgical Oncology, TMH Mumbai.
So first, I really want to congratulate Team Medica for their exceptional hospitality, their great team, the fantastic hospital. We wish them the best, and I'm sure they're going to have great success and contribute to cancer care very meaningfully in the coming years. Very, very positive vibe from the entire team and great hospitality, and thank you again. So, over the next 10-15 minutes or so, the goal would be to discuss what the current state of evidence is for margins in soft tissue sarcoma. And this has been very controversial because there are a few concepts that we need to be clear of. First, why do we need to have wide margins? What do we even mean by a wide margin? Oftentimes in the clinic, we always tell our patients that, when you remove the tumor, you remove like the orange with its rind. You should never see the fruit. The fruit is the tumor and the rind is the margin. And you always remove it with the rind intact. But no one knows how thick should the rind be. Is it okay if the fruit has a very thin skin, or how thick should the skin be? So we don't know what is a wide margin. It is one thing to look at the MRI and plan, but how do we achieve that acceptably wide margin in surgery itself? What does one do when one cannot get a wide negative margin around a critical structure? And in sarcoma, when we say a critical structure, we are very clear, it's three things. Neurovascular bundle, bone, vessel, nerve. These are the three critical structures that we look at. How do we assess what these margins are on MRI? How do we translate this assessment in TROP when we operate? And how should a pathologist really report it? Now it's very clear. The first question is to why have a wide margin? Because poor margin increases your risk of getting a local recurrence. And every local recurrence, when it's so big, will contribute to huge morbidity locally and may also affect survival. So the first chance we get to get a good wide negative margin is the best chance, and which is why it's the only unequivocal thing in the biology and treatment of a soft tissue sarcoma that we as surgeons can control. And hence getting the best wide negative margin is crucial in the first instance. And as I said, it not only can be morbid, but also may affect survival in future. The other reason why we must get very good negative margins is in the first instance when there is a positive margin, and with the positive margin you have replaced the vessels. This is one of those patients who had a positive margin. Vessels were replaced, who had radiation and came with a big blowout in the presence of disease. And that white thing that you see there is the extruded stent that was put in the vessels. So these are big morbid situations which can be life-threatening and which we must endeavor and do our best to avoid. There are many papers that will discuss overall, if you consider the last 30 to 35 years, which have debated what should be the exact amount of the wide margin and what should be the quality of that wide margin, right? Today, I will focus on 2 or 3 of these key papers which discuss all the evidence in its best given scenario, and we'll conclude with what should we do actually in practice. And this is one paper that I recommend because it clearly compares the 3 major systems that we use. And now we'll come to what are the systems that we use to even understand what the margin should be in soft tissue sarcoma. First is the very well-known AJCC-R system, which all of us know and report in our practice, right? And that says that R0 is grossly and microscopically negative, which means when the pathologist looks at the margin, he doesn't see a tumor, and when he looks at it under the microscope, it's negative. R1 is microscopically positive, which means when you ink that area, and if the tumor reaches the ink, it's positive. R2 is when you don't even need the ink or the microscope, it's very grossly and obviously positive. And what's the old traditional MSTS system or the Enneking system? It's translating this into terms. And radical means we remove the entire compartment, and I'll show you on the MRI what that means. Wide against means, colloquially, histologically non-reactive normal tissue at the margin. Now remember, when you operate, this is easy to understand. You want tissue that's not edematous, that doesn't look involved, that looks mobile, that looks healthy, and that suggests it's a non-reactive normal tissue at margin. But again, when it comes to body tissue, that normal tissue can be many things. It can be skin, it can be fat, it can be areolar tissue, it can be fascia or periosteum, it could be adventitia along the vessels, it could be epinurium along the nerve. So what do we mean by non-reactive normal tissue? And this we'll see on the MR. Marginal and interlesion are pretty obvious, where you're at the margins, where you remove it with the pseudocapsule. And the common thing which is easy to imagine is when we shell out a lipoma, right? When you shell out a lipoma, you do it around the pseudocapsule or the margins. That's a marginal excision. Intralesional is when you cut through tumor before you have excised it. Okay, so that's pretty fair and obvious. And lastly, the third system that most of us use is the distance system, which is routinely used across centers, where you actually physically measure the distance. Is it 1 mm, 2 mm, 3 mm, 5 mm? You sample multiple areas around the periphery of the tumor and you report that in pathology. Now, which of these is good and which of these is important and which of these predicts the risk of local recurrence the best? So, to repeat what I just said,
If the thing in the center is the tumor, it's very clear that intralesional is when you go through it, marginal is when you are in the reactive zone of the pseudocapsule, wide is when you are at least one layer of healthy tissue around it, and radical is when you've removed the entire compartment. Similarly, on the pathology, what you see on the bottom is clearly tumor. If you're a few millimeters away, the pathologist will report it marginal. When you're wide enough away, they will report it as wide. Now it's important here to understand that all the tissue that you see on top in that wide section can be different kinds of tissue as we delineated a couple of moments ago. It could be fat, it could be fascia, and we need to understand how each impacts our eventual outcomes. If you look at the world from west to east, from US all the way to Japan, every country will have their own systems. The most rigid when it comes to margins are the Japanese. For them, a curative margin is 5 centimeters. When they say something is adequately wide, it's more than 2 centimeters. Wide but inadequate is less than or equal to 1 centimeter. Marginal for them is reactive zone, and tumor at the margin is intralesional. Now imagine an MRI like this. If you were to draw a circle that is 5 centimeters around this, you will remove bone, you will remove quadriceps, you will end up doing an amputation. So that does not seem very practical. Now let us say you draw 2 centimeters around this, you will again end up removing bone. You draw 1 centimeter around this, you will again end up removing vessel and bone. So very clearly, when they say centimeters, it's not something measured by the scale in surgery or on the MRI. Because if that were the case, if you compare the local recurrence rates of Japan versus India versus Europe versus US, the local recurrence rate should have been different, because the Japanese use a different system than what we do, but that's not the case. If you look at the last 30 years of data across the world, when you look at the local recurrences, it's almost the same when done at sarcoma centers. What that means is we are likely doing something similar, but the language in which we convey that is not the same. And hence, we need to arrive at a system where if I report in my pathology and tomorrow it's read by someone in Birmingham or Italy or Japan or in Toronto, they would all understand it in the same way, which would allow us to compare our results. And that is where a systematic synoptic strategy of reporting for even the pathologist is extremely crucial, right? If you look at ESMO recommendation, they again say rim of normal tissue, and you don't know what that means. So what does this mean? If you look at the Japanese system, if it's in the skin, you will take a liberal amount of skin, up to 4 or 5 centimeters, because it doesn't matter whether you take 1 centimeter skin or 3. For a high-grade tumor, you're not going to add significant morbidity. Similarly, over a longitudinal muscle, if I'm resecting a muscle, say vastus lateralis, whether I resect it with a 2 centimeter margin or 4, the deficit that you have in function is the same. So the dictum is, if you're removing a muscle, go longer, right? Because there are certain tissues in body where it's very easy for tumor to infiltrate and be positive. And those key types of tissues are which? Skin, subcutaneous tissue like fat and superficial fascia, longitudinal muscle. If you look at all papers, the maximum sites where your margin comes positive are these sites. And hence we have to be liberal if our margin is fat, superficial fascia or longitudinal muscle, because we are not harming the patient by giving them much worse function. So what that means is, where are we then harming them? The only harm is when we are going to resect a vessel, a nerve or a bone, because that significantly adds surgical morbidity to what we are doing. And that is where the concept of the kind of positive margin comes into the picture, and I'll deal with that soon. Now, this was not just theory. Even if you look at papers where they actually saw what is the local recurrence-free survival, which you see in the middle. Do I have a pointer? I didn't get one. That's all right. So if you look at the middle 2.5 year local recurrence-free survival, very clearly, if you have pseudocapsule, even if you have given RT, it's only 56%. When it's soft tissue, and soft tissue, remember what it means: adipose tissue, fibroadipose tissue, and skeletal muscle, it's 95. And when you have fascia or periosteum, it's 100%. So the quality of your negative margin is also very important, and it's not just theory, it impacts your local recurrence even in practice. Another important system that we need to look at, particularly as surgeons, because it matters. Not all positive margins are the same. Okay? There are different kinds and they mean different things. So one standard system used across the world is called the TMCC, which was published back in 2013, close to 11 years ago. It's called the Toronto Margin Context Classification, where there are 4 kinds of margins. One is negative, which we all know. Second is where we are close to a vessel, nerve or bone in drop, where we plan it to be close. Eventually, on the final pathology, some of them may turn positive. We think intra grossly we are negative, but microscopically we may turn positive. These are called planned close margins. And remember, we have called them planned close because when you are operating, you don't know eventually if it's going to turn positive or negative. Right? Third is positive when you excise tumor bed of a Woops excision. What does that mean? Let's say someone in the community has depulped a soft tissue sarcoma, done some piecemeal excision, sent it to a sarcoma center where you see some residual tumor and you've done a tumor bed excision. And that excision specimen gets a positive margin. That's called a positive after excision of a Woops or a tumor bed. Last and the most difficult is an inadvertent positive margin. And I'll show you examples of each. What this means is an untreated tumor that has come to a sarcoma center, planned by a surgical oncologist, a good plan, and you excise it with what you think are negative margins. Looking at the MRI, eventually the pathologist tells you one margin is positive. And you have not seen that on the MRI. This inadvertent positive margin means there are satellite cells present in the excision specimen which you can't see physically on the MRI, which suggests bad biology. And when you look at the local recurrence rates and the metastasis rates, these inadvertent positive margins behave the worst. Because even with the best surgical planning, you've had a positive margin and that correlates to bad biology. Okay? So we have different kinds of margins in different contexts and not every positive margin is the same. This planned close, which you have planned and you come close, is acceptable and better. But the inadvertent ones do the worst. I'll give you an example. On the top left is a margin with periosteum that you've taken on the bone. Okay, and you think grossly your periosteum was negative. The pathologist may report that's a planned close margin which has come positive, which you're planning to cover with radiation. Okay, and there we'll see your local control is not compromised. Okay. Similarly, imagine a big tumor on the back of the thigh where you have dissected off the epidural all along the sciatic nerve. The sciatic nerve was closely abutted but free on the MRI. We have successfully dissected the perineurium, the epidural, taken off. Here again, this contextually you will call it a planned close margin along the nerve. The first example was a planned close margin along the bone. And third, imagine this is a Woops excision done prior with residual tumor in the popliteal fossa. When you've excised that area where the skin is involved, you've gone beyond that. The inner circle is the one where the tissue was touching the skin on the MRI. The outer circle is where you measure 2 centimeters on the skin. And when you excise, you've had a planned close margin along that popliteal neurovascular bundle that you see with the skin defect. This is again a tumor bed excision where you have a planned close margin along the neurovascular bundle. Okay, so these are different clinical contexts to look at. And lastly, I don't know if you can see this well. If you see this thing here, that's called a tail. This is a myxofibrosarcoma where there is tail that is going along the sides. And this is the commonest instance where you get that fourth type of margin that I said, which is an inadvertent positive margin. What this means is you excise all this edema, which takes contrast. Despite that, in up to 25% of cases in most series in the world, you may end up getting a focal microscopically positive margin on pathology. These behave the worst because this signifies bad biology, because it's a positive margin despite your test planning. So these were 4 different contexts explained on the MRI which matches the TMCC. This is again the tail sign that I just mentioned for the MFS. And if you look at that image on the right, sometimes that tail can go really proximal and really high. Just give me a warning when there's about 4 or 5 minutes left. So this is important because if you see the local recurrence-free survival, if you look at this chart, the blue one is negative margin. The left, the y-axis tells you the cumulative probability of local recurrence, which means if you're lower on the curve, it is better. So this blue curve is the best because the lowest risk of LR, that's in a negative margin. The grey line is planned close but ultimately positive, which is along the bone or a critical neurovascular bundle. And remember, when you're given radiation, the local recurrence rates in those is not very high. It's higher than a negative margin but still acceptable. Look at that red line, that's positive after a Whoops excision. There your risk of local recurrence is higher, and the worst is with IPM, the inadvertent positive margins. That's another message why random unbiopsied excisions of soft tissue tumors is not a good idea, because even when you excise it well at a sarcoma center, you may get a positive margin, and even after that good re-excision and radiation, your risk of local recurrence is still a little high. So that's the importance of putting your margins into context. So the message so far is you aim for a wide margin. Ask, is removing more going to affect function? If your answer is no, remove it. Is it a critical structure? If your answer is yes, go marginal along the adventitia or the perineurium and add RD. And as a basic rule, have one normal mobile layer of tissue, which you have seen on the MRI and mapped intraop. Again, this is a graph that shows you from the first paper that I showed, the Gates paper, which clearly says the top, so on the left is cumulative incidence of local recurrence, okay? So again, the lower green ones are the best, the top red and blue are the worst. So the top red is intralesional and no RT, worst. The blue line is marginal and no RT, worst. If you look at the green lines, the solid line is wide or radical margin without RT. Look at how low and good the local control is. Similarly, if you're wide radical but suboptimal, and given RT, the local control is not much worse. So you have to aim to be on that green curve, not be on that red or solid blue curve on the top. So when it comes to the margin system reported, most of our pathologists will give you varied margins. And your margin is less than 1 mm but negative. It's 1 to 3 mm, more than 3 mm, more than 5 mm, and more than 10 mm. Now if you see the top 4 are marked in green, those are the ones where you're close, and more often than not, you will always add adjuvant radiation. It's only when all your margins are more than a centimeter, you may consider not adding radiation. Most of our cases, you will not get a microscopic margin more than 1 centimeter. Most of our patients will be in those top 4 groups, where it is 0.5, less than an mm but it is negative, or 1 mm but it is negative. So you'll be very close. And all of them, you get excellent local control only with the addition of adjuvant radiation. Okay? And that's been the norm for treatment of sarcomas, resectable high-grade sarcomas. Okay? Now important, this is an excellent paper, again from the Toronto group back in 2018, which tried to see, is there a difference if you get a margin that is more than 1 millimeter but negative? And sometimes the pathologist will say it is less than 1 millimeter but I don't see tumor at the ink. So technically it is negative. Okay? But you may be very close. So again, when you use adjuvant radiation, whether you're R0 or in the well-planned case, focally very close but less than 1 mm, you may not be doing very bad. Now remember, this should not be our goal. Our goal when we operate is you always grossly measure 2-3 centimeters. Despite that, on microscopy, you may come down to a millimeter, right? This is not us measuring a millimeter in surgery. This is we thinking we are 2 centimeters away, but pathologists telling us, no, you are not 2 centimeters away. On microscopy, you are just 2 millimeters away. So when intra-op you measure 2 centimeters, hopefully on pathology you will get 2 millimeters. And that's the bridge that you need to, that's the gap that you need to bridge based on your reading of the pathology and your reading of, based on your reading of the MRI and translating that MRI into your intraoperative findings. Okay? The last but the most important thing, see most pathologists, if there is one slide with a positive margin, you will clearly call it positive. But globally, how many samples must one take to be sure that you are negative all across? That has not been studied well. Okay? Multiple centers are trying to now figure out. So the way it happens is you've excised, you've given it to the pathologist, the prosector or the first person who grosses the specimen will look at all the margins and feel. Oftentimes that may not be the senior most pathologist out there. Okay? The person doing the grossing, most centers across the world will not be the senior most pathologist, and you may need some experience to know, is this tissue looking abnormal or not? So they will in general mark out some areas which are suspicious to them. They will ink those areas. In the suspicious areas, you will take more sections, right? So what that means is you have sampled, let's say, 5 slides for the margins. You are negative. It may be very possible that the remaining arc, there was some area where you were close and positive, which you don't know of. And this is a big global problem, which is a false negative rate. Okay, you don't know for sure. So there have been many studies, and one study that shows, now again, on the other hand, you can't keep making 5 slides for every millimeter, because then you will have 4,000 slides just to report the margin, which is labor intensive, not cost efficacious, and you will never be able to get a report. You'll have to wait a month to get the report. So there has to be some balance on reporting adequate number of slides and being confident that it is negative. So the current evidence shows that when you suspect an area to be positive, up to 6 slides overall submitted for margin evaluation will give you the best chance. Compare that to how we say when you do a biopsy, when you have taken at least 5 to 6 scores, you know you're going to get a good yield. Similarly, for the pathologist, when they're going to report a margin, up to 6 slides perpendicular overall will give you the best chance to be sure that you are likely going to get a true negative margin rate. That's important to know. So, to conclude, after all this, you must read the MR closely, map the margins pre-op, corroborate it well intra-op. You have one layer of mobile, non-edematous tissue. You have thick tissue over critical structures, which is fascia, periosteum, adventitia. These are thick tissues. You have to be liberal when there is thin tissue, which is areolar tissue or fat or superficial fascia. Never ever to see or have pseudocapsule as a margin, and for the pathologist who's reporting 6 or more perpendicular sections. Giving examples for each, on the left, it's absolutely fine along the radial nerve and along the bone, the humerus, to have a planned close margin. If your tumor is engulfing the vessels, be liberal, resect them and reconstruct them like you're seeing on the right. In a re-excision, this is an individual who had a recurrence, prior irradiated, you got to be liberal. You have to excise the entire thing. The only planned close margin is for the bone, and the white thing that you see there is the exposed talar ankle cartilage, the plafond, okay? So you have to be liberal but not excise that. The way you compensate that is by doing a flap. You get fascia allografts, you reconstruct those tendons, you cover the joint, put a flap on top. So your planned close margins are only going to be along the bone. You will not try and save any tendon, you will not try and save any of that prior irradiated skin. Similarly, when you have a big recurrence around the clavicle or the shoulder, when it comes to the pectoralis major, the neck muscles, the deltoid, you've got to be absolutely liberal. If there is erosion of the clavicle, you will resect the clavicle. And in all redo cases, we always combine the MRI with a focal CT to be very sure that there are no focal erosions on the bone. If there are focal erosions on the bone, you have to excise it hemicortical or on a flat bone like clavicle, the entire bone. Now there was no erosion, so we could have the bare clavicle across the neck, and that will give you a planned close margin, which you hope is going to be negative along the clavicle. Similarly, in a myxofibrosarcoma, when you see that tail, your palpable tumor will be just 4 centimeters in the mid of the thigh. But your edema, which is taking a contrast look, how it's going very high up and very high down. And all of that you must take margin, because all of this is in the vastus lateralis. Whether you remove 5 centimeters or whether you remove 10, that muscle is gone, it's denervated, it's not functional. And you have to take the better margin. So you may feel a small tumor which is 3-4 centimeters in the middle, but you have to look at the contrast uptake on the tail, and you have to remove that entire extent which you mark pre-op. And remember, in all soft tissue sarcomas, we measure from a fixed structure which is a bone. You can't measure mobile soft tissue. So that line that you see on the top right is a line on the tip of the trochanter. And all your measurements have to be from a fixed point. You measure from that there because you can see that on the MRI and you can corroborate that precisely even on the patient. So that line is the trochanter. You've measured the top white line with a 3 centimeter margin on top and the distal one is a margin on the bottom. And that's the extent of your excision that's going to be. So in the end, if you're more than 1 centimeter in every dimension, everywhere, it may be okay to avoid radiation. More than 5 mm in an elderly individual who has a lot of morbidity, you may avoid. This is not based on level 1 evidence. This is an MDJC discussion for each individual case. There are some very elderly, say 75, 78-year-old individuals who cannot maybe come to the hospital 6 weeks, who have other comorbidities, right? And there if you've had more than 5 mm, you may be okay. Less than 1 mm, higher risk of LR even if you add RT. Ideal is at least 1 mm with RT. Best is at least 3 mm everywhere with RT. Intra-op, you must aim to be 2, 3 or 4 centimeters of gross distance away, which will translate to a millimeter margin on the pathology. And for the pathologist, 6 to 8 perpendicular sections in total from all margins that grossly you think are less than 2 centimeters. Thank you.
So thank you so much, Dr. Prakash Nayak, for such a wonderful point in lightning at the margin, which is considered to be one of the basic of the oncology. So before going to the felicitation of our speaker and the panels, I would like to call upon Dr. Kanjana Bhattacharya sir to put the vote of thanks.
We had a wonderful session with Dr. Gulia moderating our panel discussion, which was very invigorating. And then we had Dr. Prakash Nayak. He was an overview of sarcoma section. I think it was small but a very captive and a very active crowd who really took everything in. So it's not always the number of people in the hall, it's the quality of the people in the hall. And it's not the amount of minute we spend, but the quality of the minute we spend. It was wonderful. Thank you very much for this opportunity.
Sir, word of comment from our group director, Dr. Vikas Kapoor sir.
I echo Dr. Kanchanda's words absolutely verbatim, and it is an honor to be here amongst such wonderful speakers, and Kaushik and Jyoti, all of you have done wonderfully well to organize this meeting, and a lot of work is being done by Kaushik and his team in Medica, and I'm really proud of them. Well done.
Mr. Mukul Bhattacharya sir, please.
Thank you everyone. It's a very interesting discussion, and we came to know so many things from our delegates, and I thank you everyone. Okay.
Thank you sir, thank you. So now I would like to call upon our speakers. Sir Gulia sir, is he there? No. Okay, then Dr. Prakash Nayak sir, please come to the dais and have a photograph with our chairperson sir. Manoj. Next, I would like to call upon Dr. Deepak Chaudhary sir, please. Dr. Dipanjan Majumdar. Thank you. Dr. Kaushik Nande, please. Next we have Dr. Sonavindu Banerjee. So Gulia sir has come in between. Dr. Sonavindu Banerjee. Professor Gulia sir, please come. Thank you sir for your valuable time and big applaud. Then last we have Dr. Astok Daga. Dr. Daga, I think he is not there. Okay, thank you, Chairperson sir. Thank you everyone. So we are concluding the session. Thank you. So I will hand over the mic to the doctor. Okay. So now I would like to call upon Ashish Gulia sir to present our chairperson. Okay, sir. So we'll start with Kanchan Bhattacharya sir. Next we have Professor Mukul Bhattacharya sir. And lastly, after our group director, MIOS, Dr. Vikas Kapoor sir. Thank you everyone. So we'll have a group photograph. Do you have a time? Gulia sir and Nayak sir, please come for the group photograph, sir.
without any further delays, we'll start for the pediatric oncology session, and the first will be a panel discussion on childhood acute promyelocytic leukemia. So may I request Dr. Shrikant Banavali to kindly chair the session, and may I request Dr. Shyam Srinivasan, sir, to kindly moderate the session.
Yes. So, it's always like this. Oh, well, yes. Dr. Rajat, could you please, Dr. Deepshika, Dr. Sumanpal, Dr. Abhishek, and Dr. Sneha, if all of you could please come and sit. Yes. So we have Preetham also, and Sir as well. So I think, as you say, it would be more of a discussion here. That's fine. I mean, that is how almost always it is. So, without ado, what am I saying? Yes. Okay. So, quickly, a couple of case scenarios, a couple of queries from my end. That is what I'm going to do for the evening, for the next half an hour or so. So we have a 10-year-old girl, she is from Nanded district in Maharashtra, who had history of fever and bleeding from the gums for a week. She had gone to a local hospital where a complete blood count was done, HB was low, platelets were also low, around 18,000, and the total leukocyte counts were 2,400. A peripheral smear was done by the physician there, which showed an abnormal promyelocytes. They were able to do a staining, which was MPO strongly positive. So, Dr. Sneha, a question to you. What are the basic investigations would you say is required to provisionally diagnose APL?
So as we know that APL is a medical emergency, before going to the definitive diagnosis, first of all we have to have a high index of clinical suspicion, and for that the basic investigation, first we can do a CBC with peripheral smear. If the peripheral smear is already showing the promyelocytes, along with that the basic investigations are the coagulation profile like PT, ABTT, INR and fibrinogens we should do, and along with that the basic organ function test and D-dimer are also having that role in the coagulation profile. And as we have the suspicion, along with that provisional diagnosis of APL, we can go forward with the starting of the treatment and then the definitive diagnosis side by side.
Okay, thank you. So, after this initial suspicion, the patient was referred to us at TMH Mumbai. Unfortunately, the patient reached to our hospital after a week from the time of referral. On examination in our emergency department, the child was comatose, bradycardic, pupils were unequal, and the CT brain was done at that point of time, which was suggestive of an intracranial hemorrhage, and unfortunately within few hours of reaching our center, the child had expired. I think somewhere during all our practice in this, in oncology, we would have come across one such case. I don't think we can deny that. So, what, Dr. Deepshika, a question to you, what are the immediate clinical concerns do we have, and what could we do more to prevent these from happening? I mean, the major concerns are early mortality in APL. And
so, thank you, Dr. Srinivasan, for the question. So in this particular case, and it's really unfortunate, we lost a child, especially because APL is currently a very highly treatable disease with overall survival more than 90% in most studies. So what we have to be aware of, APL has its own peculiarities and dangers, especially during the early phase, right before initiation of treatment or during the first 2 to 3 weeks of starting of treatment, especially differentiation therapy. And as already highlighted there, it's the most dreaded complication here is the bleeding. APL is known to be associated often with profound coagulopathy, often a DIC-like picture with low platelets, prolonged PTA-PTT, INRs, and often the child might land up with a life-threatening intracranial bleed or pulmonary hemorrhage like our particular girl. So when a physician is coming across such a case, of course, as Dr. Sneha pointed out, the index of suspicion for APL has to be very high. In this particular case, already there were telltale signs of sort of acute leukemia with bleeding manifestations, and also the peripheral smear was already showing acute promyelocytes. So when you are coming across such a child, the first thing that you do, the child needs to be admitted immediately. If you cannot immediately refer to a nearby oncologic center, admit the child, test for the bleeding parameters, and correct accordingly. A reasonable target would be to maintain a platelet of more than 50,000 and INR of less than 1.5, fibrinogens of around 100 to 150 milligram per DL. So transfuse with platelets. If cryoprecipitate is not available to you, you can use FFP. The hemoglobin was also low in this particular case, so you have to transfuse PRBC to target at
I may
least.
quickly ask you a question. Most of this are probably easier said than done. I mean, let us be frank. So is there a simpler, or I know there is no easy answer, please, all of you are most welcome to give your suggestions to this. What can we do better? What do we tell the world, and what should we do as an oncologist? Because most of this is not in our hands, but we really need to put that message out. What can we do better?
So, like if it is a
no, you can continue.
Yeah. So it is a complicated case, so better treated in a proper oncology center. So emphasize the safe and quick referral of this particular patient to the nearest pediatric oncology center, where the definitive management can be started early.
So, I'm a hematologist, so this is a situation where even in the middle of the night, if the lab calls me, I'll go and review the blood film. And if I have concern, then this kid needs to be admitted. And you say it happens in India. UK, I've seen 2 cases, adults. One was surfing and then had became unconscious, came to the hospital and had APML diagnosed post-mortem. And the other one was just sent home, brought back 2 days later, dead. So this is a situation, if you're not sure, just treat as an APML. I think that's the message, and somebody morphology should have a look and start on that and cutting the coagulation. I think that's the message we should all have. That this is a medical emergency, do not dilly-dally on this one. If you're not sure, just treat as APML, ATRA, cutting the coagulation.
So do we say to the physician out there, wherever, say this child was in peripheral Maharashtra, do we tell them start ATRA? Would we do that? Do you think
I think if they're not sure, they can go to the hospital. They should be in the hospital actually, and then start ATRA.
Okay, thank you. So yes, we did discuss this. I think you had quite clearly said about this. So just quickly another question from my end. In your practice day to day, do you go by the platelets and fibrinogen to give platelets and FFP and cryo, or do you empirically give cryo during the initial phase of therapy or FFP during the initial phase of therapy? Does these cutoff matter to you, or during the 7 to 10 days initially, do you just continue to give either BD or TDS or twice or thrice a day? In general, any of you could take it.
I can take, we usually monitor the coagulation twice a day and try to keep those, try not to give extra if not necessary. But it's difficult to, but at least monitor in the initial few days twice a day. I think that's
so
very
if
important.
the INR was normal and fibrinogen was more than 150, you would probably not give FFP and cryo. Am I correct? And that would be an uniform answer?
Actually, I'm from a government hospital, so in our hospital we don't have the levels right now. So we had to treat, we don't have the facility of the levels right now.
Got it.
So
Yes.
we, so in last 1 year we have treated one such patient, and we have to go empirically. At least one as a baseline, and then we have to go empirically for 7-10 days, and then again we need to do.
So if you don't have it, probably it makes sense to, yes, agree. Okay, thank you. was just the first case. Next, this is a 9-year-old boy from Mumbai with history of fever and peticave for over 2 weeks. The hemoglobin was 8, the total counts were 34,000, platelets were 23,000. Again, the peripheral smear showed abnormal promyelocytes which were strongly MPO positive. Dr. Abhishek, a question for you. What would be the confirmatory test for API?
So before I answer this question, I'll go back to the history. The TLC was on the higher side. And already the point has been emphasized by my co-panelists that morphology is extremely important. However, classical APML presents with pancytopenia, but if we can get that abnormal promyelocytes which look like kidney-shaped or angel wing nucleus cells with hypergranular, and there is a hypogranular variant as well. And more importantly, MPO. So if the MPO is a strong positive in a correct clinical scenario, so that will indicate. Now coming to the confirmatory test for diagnosing APML. So the classical teaching that we teach our resident is that APML entity doesn't exist. It is acute promyelocytic leukemia with PML, RARA or translocation 15-17. So these are molecularly defined entities. So we need to confirm it by the help of molecular genetics like Carrier can help. More sensitive tests like RT-PCR, that is the first line of test that should be done. And in some centers, although fish is taken up upfront because of the shorter TAT, and we have specifically designed probes with short hybridization program where the report can be signed out in 4 hours or even less.
What added information would a PCR give me compared to a fish?
PCR. See, it all depends on...
Suppose my fish says it's PML translocation 15-17. Do I need to do a PCR, or is this enough for my diagnosis and I move on with my treatment?
You're talking about the fish?
Yes.
Yeah. If fish is positive, then RT-PCR is not really required.
Okay.
But some centers have their own protocol. We at our center do RT-PCR upfront. If the RT-PCR is negative, then we take up fish. Okay. But few centers in Calcutta, I know they take fish upfront because they have specially designed probes to take up different breakup points. And if it is positive, they start the treatment. And if it is negative, then they take RT-PCR.
Okay, thank you. So that was that. Could you also tell us regarding flow cytometry? Is it required, or if morphology is enough?
So as far as flow cytometry, I will not say that it is mandatory, but yes, as a diagnostic workup, it should be done. And we being hematopathologists, there are certain clues to APML diagnosis with the help of flow cytometry. As we are aware that the classical plot in a flow cytometry we see is a side scatter CD45 plot. And that plot itself can indicate that it's a case of APML. We get high side scatter due to the more granulation of the abnormal promyelocytes. The characteristics Christmas tree pattern is obviously seen, and there are other clues. Since it's a myeloid leukemia, there will be 1333 positive, which 33 will be bright homogeneous positive, 13 is heterogeneous, 117 is usually weak, 64 is a very good marker, which is mostly positive in all classical cases of APML. Apart from this, in some microgranular variant, there are CD2 positivity, even CD56, which doesn't really help in diagnosis, but it plays an important role in the prognostication of a patient.
How often do you see a microgranular variant?
We see, not very frequently, but if I see out of 10 APML cases, we see 20% cases are hypogranular.
So, Dr. Suman, a question to you. So, how would we re-stratify an APL?
This child, his TLC was quite high and platelet count is less than 40,000, so we can, according to science classification, we can classify him as a high-risk APML. But regarding this classification, I just want to add something. This is a bit interesting because APML was once considered the most dreaded malignancy, but during the last phase of 90s and the first few years of 2000, there was a drastic change in the management while this differentiation, the medicine, the drugs came in the market. And after the two groups, one is the Spaniards and the Italians, they studied both the medicines with chemotherapy, the ATRA and the ATO, and they and the outcome were varied throughout this cohort. So it was necessary to stratify the disease, and they did a multivariate study, and they have found that only these two things, one is the WBC count and another is the platelet count, has the bearing on that, the outcome based on the relapse, the risk of relapse. And depending on that, Professor Sands come out with this classification, the low risk, intermediate risk and high risk. But with all practical purposes, we categorize the high risk and low risk and intermediate risk. We club the both together in most of the protocols.
Okay. So no more we take platelets into consideration for risk stratifying, rather there is a low risk and a high risk. Correct? Thank you. So Dr. Rajat, a question to you. So just to summarize, 34,000 was the TLC. We have diagnosed an APL based on the morphology and PCR. What would be your next step at this point of time? I mean, we have already discussed the emergency and all that.
Yeah, so the supportive care, and now you have to do, obviously you're giving differentiation agent ATRA, and then you have to start cytoreduction. It's a high risk. So if you don't do cytoreduction, this kid is fast, then
So you wouldn't do the first one, you would rather do the second one, am I correct?
I would do the second one, definitely, with a high count. And you said high count, so the children especially get the hypogranular variant, much more commoner. And this is not an uncommon situation for us to see APML, but the hypogranular variety. So you have to actually start. We used, in my hospital in Singapore, we used to start dexamethasone as well, plus cytoreduction, but of course ATRA on the night the child comes. So second one here.
Okay. So just a follow-through question, which agent for cytoreduction?
We looked at all the evidences, and then we came up with our own protocol, which uses donorubicin and cytarabine and ATRA on the first induction, and use the second, similar for the second one also. That was entirely our own protocol, but I agree.
Donorubicin, cytarabine and ATRA?
ATRA, yeah.
Okay. So you do not use ATO to start with?
Arsenic trioxide, no, we didn't have that many patients, so not in the beginning, but we'll use it at the consolidation.
Any other difference in opinion? Would you like to opine? For cytoreduction, what do you use? I mean, I'm quite sure there is no one right answer to this. It's just that.
Yeah, the other options are already mentioned, the anthracyclines, and
what do you use?
We usually, the two options that I'm telling you, usually we start with anthracyclines, usually donorubicin or mitoxantrone, 2 to 3 doses, or we also use hydroxyurea.
Not together, I presume. It's predominantly anthracyclines.
Yes.
So yes, we do have multiple options. Hydroxyurea, anthracyclines can either be dono, idurulfin, even mitoxantrone. Cytarabine have been used, but most of the contemporary protocols have moved away from using cytarabine, but it is an effective cytoreductive agent. And GEO, the West, is pretty much moving towards an anthracycline-free regimens where gemtuzumab has been a good cytoreductive agent, but currently we do not have access to it. So, Dr. Deepshika, a question to you. What would your preferred induction regimen be at this time? I mean, say we have cytoreduced this patient with 1 or 2 doses of anthracycline, as per what you said.
So you were just mentioning that we are trying to move away from the chemotherapy to a chemotherapy-free regime. And like currently the studies have demonstrated clearly in standard risk and intermediate risk that ATO-ATRA combination without any chemotherapy works well, both in terms of survival or relapse risk. And also the toxicities are understandably lower, which was a concern. For the high-risk group also, we are slowly coming up with studies which shows that we can do with ATO and ATRA. Usually, yes, we do have some anthracyclines at the beginning for the cytoreduction. And when, as and when GEO is available to us and affordable uniformly for all patients, then probably we would move away to a combination.
Do you agree that anthracycline is not uniformly required and we can move away from it?
So for a long time now, even for the high-risk patients, we are just using the initial phases of 2 to 3 anthracyclines, and for the later cycles, we haven't been using it.
If you could have managed that with hydroxyurea alone, if I'm just giving you a scenario, you would be comfortable not to give anthracyclines at all to that subset?
Yeah, as per the current literature also, I am supported in my action. I would move away from the anthracyclines as far as possible.
Agree to it? Is there a difference of opinion on this? Not using anthracycline in ALBL, which is a high risk.
High risk I'll be worried about, really, at the moment, till it's completely, work out good evidence.
Okay. So, there is still an ongoing debate on that. If you look at a lot of the adult protocols, the MRC 17 trial, studies from MD Anderson, they have all moved away from anthracycline across both standard risk and high risk. That is because they use GEO in their high risk protocols. So we don't know what is the impact of removing anthracycline, not using GEO and treating APL, high risk APL. The pediatric protocols till date, whatever data we have from the West, the most recent was the COG study which was published last year, still continues to use anthracyclines in the high risk group. So that is where we are. Even I am not very convinced. At Tata Hospital, we have considerably changed our protocols. Our low risk do not have anthracyclines anymore. At high risk, we have limited doses of anthracycline, but our anthracycline, if not used in induction, we try to give it during consolidation. We don't want to add to the toxicity of inductions. That has been our experience. So we had even recently analyzed the data over 6 to 7 years. So we have faced a lot of toxicities in induction. So our anthracyclines are reserved for consolidation period. And as of now, our cumulative dose has been reduced to around 150, 160 milligrams per meter square. But still, for a high risk, we continue to use it. So, Dr. Sneha, a question to you. I hope you use ATO. So, if you use ATO, what dosing regimen would you prefer? Because there are 2 dosing regimens as of now. The standard is the one which you are seeing on top, and there was the alternate which the MRC had suggested. The major advantage is the convenience of administration. What do you practice?
We have used the first one, obviously, the 0.15 mg per kg per day, and in induction, and in consolidation it is for 5 days per week. And but eventually both the doses has shown this is the higher. The next option shows is a higher dose, but the frequency is less. So ultimately the cumulative dosing is quite similar. So yeah, that's
so could probably consider it as an alternate. Or probably we should consider it.
Yeah, can consider, but we follow the daily dosing 5 days per week.
Okay. So this patient was started on ATO along with hydroxyurea for induction. On day 13 of induction, the TLC shot up to 41,000. The child was having fever, the respiratory rate was high, hypoxic. There was a weight gain of 1 kg. Dr. Suman, just a question to you, what would be the differentials, what would be your differential be at this time point?
So as the patient is a high cell count patient, so I have to consider the differentiation syndrome first, and then there are lots of differentials there. So it can be interstitial pulmonary infiltrates to sepsis, fluid overload, and pneumonia. So we need to keep those differentials in mind. But as we do the investigations and start the treatment, we have to keep in mind the underlying, if the primary is is the differential is not the primary, but differentiation syndrome may be there.
Sure.
So we have to give steroids.
So it would pretty much be a diagnosis of exclusion, I presume, the differentiation syndrome. But you would simultaneously start treating and also working up for your other differentials. Agree. So what would you do? I mean, what investigations and in specific to differentiation, what management would you want to do?
So steroids. So steroid is the mainstay of treatment because these are all such kind of the expression of differentiation syndrome is like SIRS. So we need to give either prednisolone or dexamethasone or methylprednisolone. But the standard that we use dexamethasone 10 mg per meter square BD.
For treatment?
For treatment.
Okay. Do you give prophylaxis?
Yeah, we give. If the patient is the initial or during the treatment, if the QC count is more than 5,000 or the creatinine level is more than 1.4.
So across both risk groups, you do not use prophylaxis? In the sense you have
both the risk groups. If that happens, then we use.
And your prophylaxis preferred would be dexamethasone or prednisone?
Dexamethasone, maybe 2.5 milligrams.
Is there a difference in opinion on this? Do all of you use prophylaxis? And if so, what? If not, why?
We use in a high risk, definitely we use dexamethasone and the same dosage as you said. I'd probably stop the atranosonic for a couple of days because this kid is, depending on how sick this kid is, if this kid is going close to getting ventilated, then I'll probably stop that a couple of days and then restart it once the counts are a little bit more stable.
So
otherwise,
we kept him in the ward, we put him on oxygen and we started Dexa. Would you still stop atra and arsenic or would you like to continue atra and arsenic?
It depends on the clinical situation. So if you think that kids, they sometimes go on very fast. I've seen kids going from that getting ICU ventilated quickly.
Sure.
So I think if in doubt, I'll just stop it. That if it's differentiation syndrome and not an infection, then I'll take the call. I think we have already discussed this. So dexamethasone was the thing.
Okay. So with dexamethasone and other supportive care, the child improved and he completed induction therapy. So that was the second case. The third case was a 7-year-old girl, APL, low risk, anti-angio induction. And day 30, she started developing severe headache, 3 to 4 episodes of vomiting, no fever, no meningeal signs. Dr. Deepshika, question to you, what would be the diagnosis? What would be your further course of action at this point of time?
So the most likely diagnosis here, as you have pointed out, intra-induced pseudotumor cerebri. That's a typical complication. Most likely due to vitamin A toxicity, increased CSF production, decreased resorption of CSF. So we hold the drug for the time being. Start on supportive measures like Diamox, sometimes mannitol. And once the symptoms come down, we restart the drug, but definitely at lower doses, maybe 50% or so, and then build upon it.
What is your, otherwise what is your dose of atra?
25 mg per meter square.
Do any of you use 45 mg per meter square? No. So you would restart at 50% of the dose?
Yeah.
Okay. Have you ever required to use mannitol for your patient?
Not usual. I haven't.
Dr. Sneha, question to you. This is regarding intrathecal therapy. So when do you do your first lumbar puncture?
So in APL, we should avoid the lumbar puncture in induction, as there is high, obviously they are prone to coagulopathy, and there is obviously risk of CNS involvement is also low in APL. So when we need to do ITs are when the high risk APL is there, or there is CNS involvement. And prophylactically, we do in high risk only, not in low risk. And also, if there is any risk of CNS hemorrhage or the child had CNS hemorrhage, then we
no ITs for low risk at all.
No, we follow no ITs, but in some protocols they have.
What your opinion?
No ITs for low risk.
And for high risk?
For high risk, we are doing prophylactic ITs, that is in consolidation. 2 to 3 ITs were.
The rest of you, is that what you practice, or is there a difference of opinion on this regarding intrathecals in APL? When do you do, when do you not do?
We do a bone marrow in the second at the end of the induction, and they do IT at the same time, and 3 ITs, both high and low risk. That's
3
our
ITs
institution.
for high and low risk. Any difference of opinion? Okay. So, if you go by literature, with ATRA, ATO, the adults have moved away from intrathecals in APL. Though there is a CSF analysis done at the end of induction, most of the protocols don't give intrathecals irrespective of whether you are high risk or low risk, but for patients who have had bleeds or found to be CNS positive on CSF examination, which is almost always doesn't exist. But patients with intracranial bleeds to start with in the beginning, or retinal bleeds, these are the patients who have get these prophylaxis. Again, for pediatrics, the evidence comes from the last 2 papers, which is from the COG as well as from the Chinese studies, which again used ATRA and ATO. They also did not routinely give prophylaxis, but the major concern is when they relapse, do they relapse in the CNS? Though the relapses are very rare, it does happen in a small subset of high-risk patients, and if you go back and look at both these papers from the Chinese and the COG group, there were some 3 to 4 relapses, and each of the papers said there were 1 to 2 of them had a CNS relapse as well. Okay, there is still a chance of relapse, but these numbers are not big. They are almost always salvageable, and they almost always occur in combination with a medullary relapse. Maybe that is the reason why people have started to move away from prophylaxis, routine intrathecal prophylaxis for APL. So the symptoms of pseudotumor resolved, was restarted after 25% dose reduction, subsequently tolerated well, and end of induction marrow was done. Marrow was in morphological remission, there were no abnormal promyelocytes. Dr. Abhishek, is there a role of PCR at this time point? We are at the end of induction.
No, I don't think that PCR is required at the end of induction.
A morphological remission would be fine?
Definitely.
Okay.
And what we practice, that once the treatment is started, we can repeat the peripheral smear and to look at the differentiating cells, so that can give an idea about the efficacy.
At what time point should we do this?
Once the ATRA and ATO is started, we do it on daily basis, and what we see initially, the differentiating cells are increasing, and as the therapy goes on, the mature neutrophils comes into play.
Okay. So, say we did an MRD, and say it is at the end of consolidation. Should we do an RT-PCR and an RQ-PCR?
So definitely, as far as MRD is concerned, we need to quantify it. So we will obviously go for an RQ-PCR. We will quantify.
It should be an RQ-PCR.
It should be. Yeah.
Is RT-PCR, if I don't have access, is RT-PCR fine?
For MRD evaluation, I don't think RT-PCR. For subsequent follow-up, we need a quantification.
Okay. So the end of consolidation, RT-PCR was negative. Could you tell me the time? Am I overshooting? 5 more minutes. So, what is the role of maintenance therapy there of differentiating agents? All 3 of you, yeah, 4 of you can take this thing. So, do you routinely give maintenance therapy in APL? Or have you moved away from giving maintenance therapy? How long is your therapy for?
We aren't giving any maintenance therapy, like usually it is induction followed by the consolidation. So we are using the ICC APL02 protocol. So no
Does
maintenance.
it not? It has maintenance.
It's ATO ATRA,
Okay.
followed by then again 4 cycles of ATO, 4 weeks off and on,
Okay.
along with ATRA 7 cycles. So that's it.
So, what is your duration of therapy?
It takes around say 8 months, maybe 6 to 8 months,
Okay.
depending on the tolerability.
Dr. Rajat,
Yeah, so we have very small numbers, but what we agreed to do, 2 chemotherapy, then 2 ultrasonic consultation, and look at the qPCR. Actually, we didn't have the qPCR, RT-PCR. The digital droplet PCR was we're trying to validate. Idea was that if the acute PCR positive at the end of therapy, then we give 2 years of maintenance. So in absence of that, we just elected to give 2 years
How
of maintenance.
often do you see an RQ-PCR, positive at the end of consolidation?
I have no idea because we didn't have the data, but it's possible. But
Have you seen?
Yeah.
Have you seen an RQ-PCR positive?
Well, my UK experience was that when David Gilward was doing the study, then they looked at the PCR and looked at increased relapse risk. At what depth, I cannot remember.
Sure. Because the last 6 years, I have not seen, maybe Sir would say better. With ATRA-ATO, I have never seen an end of consolidation RQ-PCR being positive. Nevertheless, the treatment paradigm that way has changed for APL. I think people are again moving away from maintenance therapy. The total duration of therapy has shrunk now. The protocols talk about 10 to 12 months of therapy. The initial 60 days is called as induction. The subsequent so many 8 to 10 months is called as consolidation. It is broken out. The drugs are almost always the same. It's ATRA and ATO. It's just called as different phases of cycle. But when ATO is not used, then there is definite role of maintenance, which is what most of the predecessor trials have shown. So that is where we are with maintenance. So Dr. Suman, a question to you. How do we monitor this patient after treatment completion?
So for every other leukemia, for APML also monitoring is really very important because early identification of a relapse, we can salvage the patient very easily with the medicines. But the data shows that we don't have to monitor by bone marrow investigation like high-risk patient. There is a protocol that we have to monitor bone marrow every 3 months for 3 years. But for low-risk patient, we don't have to because the relapse rates are really very low, and if at all they relapse, we can treat them easily.
Is a marrow required, or can we do?
Actually, the feasibility is an issue, and the patient's patient family also. So every 3 months they have to undergo a bone marrow that is really psychologically very demanding. So when I was in TMC Kolkata, so we were doing that from the peripheral nerves, not from the bone marrow. But the practice, the protocol says it should be from the bone marrow. And with bone marrow, obviously we can identify the relapse about a month or 2 earlier.
Sure. The rest of you, peripheral blood, marrow, what do you practice or not doing PCR? Any different? You would say peripheral blood.
We practice in peripheral blood.
Sure. No difference of opinion? Okay. So the child has been on routine clinical follow-up for 3 years now and doing well. I think for the want of time, I would stop it here and we can probably move on to the next talk. Thank you panelists for your time. And thanks and congrats to the Medica team. Yes, thank you.
I would request all the panelists to kindly stay in the hall itself, and would request Dr. Rajat Bhattacharya to kindly chair this session, and would call upon Dr. Shripal Manavari sir to deliver his talk.
So we are honored to have you. Of course, the audience is not there, but we will listen. So needs no introduction, I think, for this audience.
Sorry, actually I'm looking at the watch because we have a flight to catch. But thank you, Preetham, for the invitation. And when he told metronomic, I couldn't say no, because that's one subject which is very close to my heart. So, we can again discuss here because all of us are pediatric oncologists, so I don't have to go through this. But very importantly, the cure rate in the West has gone more than 80% now. But at present, in the low and middle income countries, it's still much away from that. magic number of 80%. And as we know in India, in some centers it's as good as the West, but in many other centers it's still very much low. Not only that, actually, if you see, even where the cure rate is 80%, there are many cancers out there, pediatric cancer, which are much away from the magic figure of 80, and especially, we talked about APML, but the other way around, the acute myeloid leukemia, neuroblastomas, these are still some conditions, patients with advanced cancers where the cure rates are still, much desired. So, as we all know, the management of high-risk pediatric cancers, actually still the cure rate is not as good as patients with early cancers. Not only that, actually, the treatments for the cancers like neuroblastomas, where we use therapies, anti-GD2 antibodies and all, they are very expensive and still cannot be used in most of the lower and middle income countries. So, in such basically situations, there is still a role of metronomic therapies, and that's what I am going to talk about. So for those uninitiated, I think everyone knows what metronomic therapies is, but at least I'll mention a word. So metronomic therapies come from the word metronome, which is a musical instrument which gives chimes at regular intervals, and basically that helps the musician to play the instrument. Same way here, instead of what we used initially every 3 weeks, every 4 weeks therapy, actually we come down to either every weekly therapy or every day therapy, but that's not enough actually. The other part of metronomic therapy is that this therapy has to be given for a considerable period of time for it to work. And very importantly, actually, this is metronomic. Why I like this concept is because that was the first time we thought to go away from just the cancer cell and not only think about the cancer cell, but to think cancer as something that involves the cancer cell, along with that the tumor microenvironment, and very, very importantly, today we talk about immunotherapy, but the other part of the metronomic therapy was to modulate the body's immunity also. So in metronomic therapy, we actually target not only the tumor, but along with that we try to modulate the tumor microenvironment, whether it's anti-inflammatory, whether it's anti-angiogenic. There are various ways to modulate the microenvironment. And lastly, we also try to improve the body's immunity. But this is not a very new concept. Actually, this is the concept that the pediatrics or the pediatric oncologists gave to the world much before the word metronomic therapy was coined. Because as you see, the most successful treatment in pediatric, or not only pediatric, in oncology for that matter, is the treatment of childhood acute lymphoblastic leukemia. And if you see the treatment of the induction treatment, for example, consists of giving prednisone every day, giving vincristine every week, giving elaspernase every other day, giving intradecals every week. So all this is a concept of metronomic therapy. So this is one of the earliest concept of using what we call the term metronomic therapy that we use today. Not only that, in ALL we give 2 years, 1.5 to 3 years of maintenance therapy. That is again a very, very prime example of metronomic therapies, because not only we give daily therapy, weekly therapy, but we give it for a prolonged period of time. So metronomic therapy was coined initially, or was brought in by pediatric oncology itself, though we use it less nowadays. So we can use this metronomic therapy in 3 settings. The first thing that we all use many times is when we get patients with a resistant recurrent disease, as palliative therapy, we use this therapy. Not only that, actually it can be used in the curative setting also. There's one period, the perioperative period, that is when you operate and then by the time you start the next chemotherapy, that may be too late. And this concept of angiogenesis was brought in by Dr. Judah Folkman, who was a pediatric surgeon, and he saw this. The younger generation will not know this, but when we were practicing, patients with osteosarcoma used to get operated, and the old times the large tumors they used to get amputated, and by the time they used to come within 2-3 weeks after the surgery, they used to come with great cannonballs, metastasis in the lung. So this concept came at that time because thought that we are doing something which is stimulating the tumor to grow. So this anti-angiogenesis and angiogenesis concept was brought in by another pediatric surgeon, Dr. Judah Folkman, who was at Boston Children's Hospital. So whether we can do something during the perioperative period and try to prevent this, so this is where we can use this. And very importantly, now we are already using it in the ALL, but there are many other advanced tumors and other cancers where we can use this as maintenance therapies. And there's a lot of work going on in that. So, they started this, for example, we were using this even before the word metronomic was coined. I published this as biological response modifier based therapy, and this is what we had used that time for patients with recurrent sarcomas, both Ewing sarcoma and rhabdomyosarcoma, where we were using tamoxifen, etoposide and cyclophosphamide in metronomic doses. It was given for 1 year. You can see this was a patient of large, basically recurrent metastatic Ewing sarcoma, who with just, basically the therapies was not only doing well for a year, but also till 2013, basically we have followed this and he was doing well. So this is a large recurrent Ewing sarcoma where we use this therapy. We have used it in recurrent and metastatic rhabdomyosarcoma. This paper was published by my student, when we showed that it can be used effectively, and very importantly, actually the best was if you could use this metronomic maintenance in patients with advanced cancers as part of the therapy. Don't wait, like stage 4 cancers, if they are used before they recur, basically maintenance therapy after standard therapy, these patients were really doing much better than the others. So we can use this in patients with sarcoma. And this much later, actually now we also know that in rhabdomyosarcoma, this trial was published where they've used this vinorelbine and low-dose cyclophosphamide for 6 months as maintenance, and they've shown that the outcomes were significantly better. Again, another area where this can be used and is being tried is patients with advanced neuroblastomas, where we know the outcomes are not that good. So there's again papers of oral metronomic maintenance therapy which have shown to improve the outcomes in patients with neuroblastoma who couldn't go for the standard what we call autologous transplant or anti-GD2 antibodies. And basically, as you can see here, patients with were treated with high-risk neuroblastoma patients who did not get, if you see here, when they got the metronomic maintenance, the outcome was better than the patients who did not get the maintenance. So definitely this is being tried, and I'll talk about it later, but there are newer ways where we are trying this in neuroblastomas also. The other thing that we started using this way before any other thing was in acute myeloid leukemia, because as we know, especially in patients, the patients that we see, there are many patients who come with poor general condition who cannot be started on standard chemotherapy, or patients in LMICs where the initial funds are not there, and we have used this patient for both in patients who we needed time to arrange funds, as well as patients who could not be started because they had infections. For example, you see here this patient had come with pneumonia, couldn't start with the 3+7 induction, gave the oral maintenance, and then once the pneumonia cleared, we could start them on the standard therapy. This is another patient of basically the granulocytic sarcoma, where you can see just the large tumor, which had near complete remission within 2 cycles of therapy. So this was the protocol that we were using, prednisone, etoposide, 6-thiazide. At present, 6 stages not available, but we have changed to 6-MP. But if possible, 6-TG is a much better drug for myeloid leukemias. We were using that. And then we thought if we can use this in patients in palliative setting, whether if we give this as maintenance therapy, whether that will improve outcome. So this is not a randomized trial, but here we gave after the standard therapy, we gave these patients of acute myeloid leukemia 6 cycles of maintenance therapy. And here you can see, actually, though again, like I told, this is not randomized, but the 80 patients that we saw, actually this was years back, but the 5-year survival had improved to our regular outcome at that time. So definitely it helped us to decrease the relapses in that group of patients with myeloid leukemia. And the other one where we still use the metronomic therapy is patients with acute promyelocytic leukemia, where we, in induction, like we were discussing now, we don't regularly use anthracyclines, but we use etoposide 6 MP now, and along with arsenic in the initial period and this thing. And as you can see here, the outcome of our patients, both for basically the event-free survival and especially even the disease-free survival, is excellent with overall 97% at that time when we had evaluated these patients of acute promyelocytic leukemia. So definitely when we had a lot of toxicity, when we gave anthracycline during induction, when we changed to this simpler and milder type of therapy, the outcomes definitely improved. And not only that, now if you see now in adults this has come out, but the addition of venetoclax, FLT3 inhibitor and decitabine for patients with adult patients, now these are elderly patients who had dismal outcome. You can see the more than 80% or nearly 80% outcome for patients was unheard of. And all this is oral therapy. Now you will get the decitabine or azacitidine oral is available now. So oral venetoclax, FLT3 inhibitor and azacitidine or decitabine here will change the way we are treating patients with acute myeloid leukemia also. So slowly I think this will percolate down to the pediatric practice also. So what we want to say is that metronomic therapy has its advantages. Most of the drugs that we have used are low-cost drugs which can be given orally. It can be given, basically it can be given in the outpatient basis. We do not admit many of our patients, at least initially. Most of this can be done on outpatient basis. It doesn't require basically much support. Definitely AML during induction will require, but other than that, when we use metronomic therapies, we have given it on outpatient basis with minimal basically monitoring also. Doesn't require nutritional support, antibiotic support, etc. And no need of complex infrastructure or highly trained human resources for execution. And very importantly, we have changed from drug discovery to drug repositioning. So many of the drugs that we use, actually I have shown pediatric, but we are using it more in adult also, and we have repurposed many of the other drugs like propranolol and metformin, tamoxifen also, not in breast cancer but as metronomic anti-angiogenic therapy, and celecoxib. So there are many drugs which have repurposed for this purpose, and that has helped us not only to improve the outcomes but also decrease the cost. So very importantly, I show this figure. You can see from there, there's a BMW sign on this donkey's head. So we always want the new drugs which are expensive, but this for this setup actually on this mountain, a BMW is not going to work. So this donkey actually which will serve better than a BMW in this. So that's what metronomic therapies are. Where other therapies do not work, we have many times seen that this type of therapy does work. And very importantly, now we talk, especially in adult, we are talking about immunotherapies. But we always talk about immunotherapies which are the positive or the stimulatory immunotherapies, like you have PD-L1 inhibitors or basically cell therapies. All these are immune modulating therapies. But the other part of immune therapy or immunity, body's immunity, is the suppressor immunity, which we don't talk. And these are your deregulatory cells, the macrophages, the myeloid-derived stem cells. These are all the negative or the suppressor immunity. And unless this suppressor immunity is taken care of, the positive immunity also does not work. And that is why we see that the immunotherapies do not work in all. There are many patients where we need actually much better outcome than what we get presently. So this is a new concept that has been coming out, that if you modulate the tumor microenvironment, remove the suppressor immunity from there, then maybe your positive immunity or basically your checkpoint inhibitors, your cellular therapies will work better, and then basically the outcome will improve. And not only we are seeing this in this thing, but even pediatric patients of neuroblastoma now they have seen that if you do this type of therapy, more cellular CAR T cells which are developed for the neuroblastoma, they will reach there better and the responses will be better. And this we have shown actually, this is again in adult, but our group has shown where we have used low dose immunotherapy along with oral metronomic therapies. We have shown that the outcomes were much better in this, and this is now trials are going on at Tata Hospital. So slowly now we are moving away to low dose immunotherapy along with metronomic therapy and see if we can improve the outcome. So this is what it is basically. This Lamborghini, such an expensive car, but on this is a real video you can see in the net where it is stuck in this mud, and it has no value, if it's there. But along with that, if you do it on this type of road, it really works. So if you want to have this Lamborghini work or your immunotherapy work, if you create the tumor microenvironment in such a way that it helps the immunotherapy to work, we'll get better outcomes. I think the future is where we will be using immunotherapies along with basically metronomic therapies and see if we can improve the outcome. So thank you very much again, Preetam. Thank you for inviting me.
Thank you, sir. Would you please kindly stay back on the stage? I would request Rajat sir to kindly felicitate Dr. Banamuli. I would request Rajat sir to please stay back, and could you please felicitate Dr. Shyam Srinivasan. Thank you, sir. Now I would request Dr. Pradeep Mandal to kindly felicitate Dr. Rajat sir. You can't leave. Thank you, sir. Now I would request Dr. Deepshikha Maiti, Dr. Sumanpal Chaudhary, Dr. Abhishek Sharma, all our respected panelists, and Dr. Shreya Agarwal to kindly come up on the stage. And Dr. Preetam, could you kindly do the needful? Dr. Preetam, please stay back. Thank you. Dr. Deepshikha. Sir, behind Pradeep sir, Vishan and sir atke gayechen. Thank you, sir. Dr. Sneha, please. I would request everybody to please come up on the stage for a group photograph. Dr. Panavali hasn't left. Okay, then Rajat sir, please come up. Everybody please come up. Dr. Shyam, please one group photograph. Pradeep sir, please join. Thank you for a very crisp and informative session. I, being a plastic surgeon, understood some of the hemat-oncology, so thank you so much. Thank you. Thank you, sir. Okay,
Next, we have a session by Zydus. The talk is Response Guided Approach in HER2 Positive Early Breast Cancer, How TDM1 Can Help. May I request Dr. Tanmay Kumar Mundal to kindly deliver the talk? Can we have the presentation, please?
Cancer Conclave for giving me this opportunity. And so this is a small talk on adopting response guided approach in the management of HER2 positive early breast cancer and how does TDM1 help in this. So the prognosis of a HER2 disease, HER2 positive disease is not good, it's poor. As we know, it's one of the driver mutations in breast cancer and the poorest marker or biomarker which we see till date. And it has been seen that a strong correlation between the amplification of HER2 or a HER2 positivity by IHC has been associated with a poor clinical outcome, and it has shown to have small disease-free intervals with increased incidence of brain metastasis and all these things. So up till date, US FDA has approved around 8 HER2 targeted agents starting from trastuzumab, pertuzumab, dapatinib, margetuximab, tucatinib, neratinib, and of course TDM1 and now TDX is another online. And anti-HER2 therapy and how does it help in the adjuvant treatment? So it has been seen that adjuvant trastuzumab improves the disease-free survival and overall survival for patients with HER2 positive early breast cancers. The different trials which we have, the HERA trial, the NSABP, B31 and the BCIRG, where it has been seen that treatment with adjuvant trastuzumab after chemotherapy is associated with significant clinical benefit with an absolute improvement in the range of around 6.8 to 10% in almost all these circumstances in the disease-free survival, and around 6.5 to 9% in the overall survival is what we see, and all are statistically significant. But what happens is there is a risk of recurrence and still needs to be minimized in the HER2 positive breast cancers, and that's one important issue which we face now. So what are the risk factors for recurrence of HER2 positive breast cancers treated with trastuzumab therapy based therapy alone? Is that in high risk patients like heavily nodal disease positive or a higher tumor size T3, T4 disease or a heavily nodal positive, these tend to relapse too significantly earlier with a shorter disease-free survival. So for that, what we need to do is the neoadjuvant therapy. It's a move towards the personalization, because if we use a neoadjuvant response, it can guide us in improving the outcomes by changing or by escalation or de-escalation of the adjuvant treatment which we have. So in turn, this also leads to improvement in the recurrence rates, and this is also what we see, that there is an association of PCR or pathological CR and the event-free survival by the breast cancer subtypes, and HER2 positive disease treated with in this, which we see that there is a good association with this, but this has never translated into a good overall survival benefit. So these are the different studies in which the HER2 positive agents were used with good pathological complete response rates when used in the preoperative setting. So which patients should be considered for a neoadjuvant therapy? The suitable candidates are inoperable breast cancer, mostly the inflammatory breast, or a bulky or a high nodal disease positive CT4 tumors, and in operable disease, any tumor size more than 2 cm or any node more than 1 cm are selected with a HER2 positive disease or a triple negative disease. These are the candidates for neoadjuvant therapy, and these patients should be subjected to neoadjuvant therapy upfront. So adjuvant therapy in patients with a higher risk of HER2 positive, in patients who have a risk of recurrence of more than 10% after appropriate neoadjuvant therapy, any residual disease, if it is there, that means no pathological CR, and if the patient undergoes upfront surgery, and if it has a node positive disease or a T4, T3 disease, they are to be considered as defined as high risk HER2 positive disease. So what we have seen is that any patient, if is subjected to a neoadjuvant based treatment and after surgery, if we find a residual disease, it has been seen that they correlate with a poor outcome in those patients, so needs escalation of the adjuvant therapy, and it was the need of the hour for a long duration until and unless we got the Catherine trial, where it answered many questions. So building on trastuzumab additional therapies, it has been seen that from the 2017, the neratinib was approved in the extended as an extended adjuvant treatment and in maintenance phase, and of course this trastuzumab plus pertuzumab was also approved in HER2 positive early breast cancer. And then in 2019, what we see that in patients who have a residual invasive disease after neoadjuvant therapy, we need an escalation of treatment. This is the trial, the Catherine trial, we are all aware of this, in which the patients who had a residual disease post trastuzumab in the neoadjuvant setting, they needed to have escalation in the adjuvant treatment in the form of TTM1 for a total of 1 year in the duration. So in those patients, what we feel that it has seen that the primary endpoint was IDFS and the secondary endpoints was disease, distant recurrence-free survival and overall survival and the safety profile. These are the different stratification factors. So what we see that of these, whether the patients had pre-use of trastuzumab alone or trastuzumab plus pertuzumab, all the factors were, irrespective of all these factors, there was a benefit. And what we see that in the invasive disease-free survival, there was an absolute benefit of 11% with the use of TDM1 in the adjuvant setting. So there was a 50% decrease in the risk of recurrence with a hazard ratio of 0.5, which was statistically significant. So the distant recurrence rates and the local regional recurrence rates were also better in this TDM1 with the use of TDM1. So in the forest plot also we see that irrespective of the hormonal status, whether it was ER/PR negative or ER positive, PR negative or ER negative, PR positive, irrespective of the ER/PR status, and whether the preoperative treatment was whether trastuzumab alone or trastuzumab plus pertuzumab or any other agents, whether the pathological nodal status after the preoperative therapy was node positive or node negative, all the subsets benefited the TDM1 arm. So the secondary endpoints also, what we saw that distant recurrence-free survival, there was an absolute benefit of around 6.7%. and in the distant recurrence-free survival with the use of TDM1. This is the affinity trial in which pertuzumab, trastuzumab and chemotherapy versus the trastuzumab and chemotherapy in the HER2 positive early breast cancer was used, the 10-year survival, in which we see that if the patient was on pertuzumab plus trastuzumab and if after the use also the node was positive, the node positive subset only had a maximal benefit, whereas the node negative subset didn't have that much amount of benefit. So access to these therapies in India, what we see that for pertuzumab, the cost is one of the major factor which becomes an issue, because for that we can't prescribe it to most of the patients which we have. Neratinib is also a high cost molecule, so that's also a reason for which we can't prescribe most. TDM1, of course, it was still, I think 2 to 3 years back, we also didn't have a biosimilar, but presently we have a biosimilar, and for this reason we at present day we even prescribe to many patients for this. So the proposed strategy for managing patients with stage 1 to 3 HER2 positive breast cancers is, if any patient has a tumor size of more than 2 cm with a HER2 positive disease or a node positive disease, we should go ahead with a neoadjuvant therapy followed by a surgery. And if in surgery, if we see that the pathological CR has not been achieved, so that on those patients we escalate the treatment to TDM1 for the next 14 cycles. So this is what should be the pro forma now, and generally in day-to-day practice also we use this strategy now. The future directions, TDM1 after upfront surgery in small tumors, there is a planned study attempt 2.0 in which TDM1 followed by trastuzumab, and this trastuzumab plus paclitaxel has been used in the alternate study. There is another study also with tucatinib to further reduce the isolated CNS recurrence rates, because we see that the HER2 positive disease has a higher risk of CNS metastasis. This is another Estefania study design. with atezolizumab to further increase the invasive disease-free rate. So in summary, for patients with HER2 positive breast cancer, the availability of HER2 targeted agents have markedly and remarkably rapidly improved the overall outcomes, and need to offer the neoadjuvant treatment for most the eligible HER2 positive patients. For adjuvant treatment, what we prefer is TDM1 as an adjuvant therapy for patients with residual invasive disease after neoadjuvant taxane and trastuzumab based treatment. As per the affinity trial, especially for node positive disease, we can offer them trastuzumab plus pertuzumab for 1 year after neoadjuvant therapy, and extended adjuvant in the form of neratinib also might be offered, but we generally don't use, and it's not, I don't think it's available in India also. So I think with this, I end my talk.
Thank you, Dr. Conclave. And as you all know, that cancer care is not complete without pain and palliative care. So here I would request Dr. P.N. Jain sir to, okay. So, Dr. Jain, please could you come up on the stage? And Dr. Argo Mukherjee. May we have Dr. Prarthana? Dr. Prarthana, could you please come up on the stage? She is a consultant of pain and palliative from Medica Hospital. And Dr. Obiru, could you please take control of the slideshow? So handing over the mic to Dr. Argo Mukherjee.
So, thank you, Dr. Sanjini, for your kind introduction. So, the days are almost, the CME time is almost towards ends, and obviously we are exhausted hearing different talks, but we will not discuss about anything theoretical or like that. We will discuss about things, about reality in life, okay? So, start with the first question. Sir, you have been associated with the Apex Institution of Pain Management, that is the ISSP, for quite a long time. I mean, you have been the treasurer, the president, and so do you think that even in the Apex type of CMEs or the national conference, the awareness about cancer pain management and cancer palliative care is still lacking?
First of all, thank you very much for the organizers to include pain and palliative care session even in the evening. It is very, very important aspect of quality of life. So thank you very much for the Medica Hospital organizers and Dr. Saurabh Datta and Dr. Argo Mukherjee. So certainly pain is very, very critical topic in all the symptoms, and our 70% patients who are coming to cancer hospital, they are having pain. We are not asking them any question about pain, and pain patient is also not having the priority as a pain for relief. They are wanting actually cure from cancer or relief from cancer, treatment of cancer. So in their mind also, cancer is more at a higher priority rather than pain management. So pain management always takes the back seat. But of course, in the during the treatment or later on when they are in advanced stages, certainly pain is more advanced and more in critical stage. So they can't live without any analgesic treatments and all that. So that needs important attention. However, a national palliative care program started in 2014, and it has been actually allocated also 200 crores for developing national palliative care program. But that money has gone to the National Rural Health Mission, NRHM. So we did not get the money for developing a district hospital. 200 districts were actually isolated for a separate block of palliative care, for a doctor in palliative care, nurses were there. So now, luckily, we have been now entrusted with WHO Collaborating Center. Tata Memorial is now becoming a WHO Collaborating Center. And we had just meeting 20 days back with WHO people came and the Director General of Health Department from Delhi, Nirman Bhavan also came. And we had a meeting. Now we have chalked out a program for Maharashtra. Similarly, you can make a program for West Bengal, where this money, which is coming from center to the state government, but not getting utilized. So once that is getting utilized, you can develop this.
Thank you, sir. Thank you. That is a new kind of information we got, and definitely we try to implement it. And now coming to next question. So this question to Prarthana, Dr. Prarthana, can you tell me, as we have seen, most of the patients in our society with cancer, they present late, and again they present with mostly the pain. So what do you think? How they will get treated? In short, can we explain?
So this is thank you for your question. This is really unfortunate that patients. Like mostly 80% of the advanced cancer patients present with pain, and it depends on the setting they go to, the resources that the center has. So again, there's very less awareness of pain. So mostly, if they are lucky, they have a palliative care department in that. So it's not there in maybe in the cities, but not in peripheries. So if they come, I think first a needs assessment along with symptom management, the symptom assessment or needs assessment also needs to be done. It's not just pain in palliative care.
In total.
So we have to see also their psychosocial issues, their financial issues, their social and everything, and do a holistic assessment. Because pain is also, it's a total pain. We can't just treat it with just giving analgesics. We need to also try the other non-pharmacological methods and even try to alleviate the suffering through even reducing the psychosocial distress. So all that holistic component.
Oh, okay. Coming to next question. Sir, this question to you. You have been in Tata Memorial Cancer Hospital, have been HOD for pain department. Now you have shifted to palliative care department. Okay. So, what do you think? How important it is for a palliative care physician to know the details of pain management?
We see about 70 to 80 patients per day in Tata Memorial palliative care unit, and 90%, 80 to 90% patients are suffering from moderate to severe pain. Mild pains are not recognized or not told by the patient, not referred also. So paracetamol and NSAIDs are not the drug. So it is the opioids and opioids. So whatever it is, WHO later also tells that at step 2 also opioid, step 3 is also opioid. So these patients will need opioids. And Tata Memorial Center being a tertiary care center, So all these patients are not from Bombay. They will go back. And cancer therapy is finishing. So how they will receive the opioids later on? Even tramadol is a controlled drug. And has to be given by the prescription. And sometimes patient in the village. So how to procure a prescription without seeing the patient? The doctor insists that to bring the patient. And sometimes patients are bedridden in palliative care. So they cannot be brought by taxi in lying position in the trolley and all that. So those are logical problems and barriers. So in palliative care setting, this is the important thing, that patients are in the last stages of life. They are in end of life. End of life doesn't mean 1 month of life. It is up to 1 year, that whatever is the state is, that patients are in last stages. They need certainly the pharmacological drugs and certainly non-pharmacological, so in totality. So these things are very important in palliative care and they should be understood. However, in telemedicine, they have not given us the authority to prescribe morphine by just a video conferencing something. So it
yes,
is,
I mean in NMC they have prevented us to prescribe morphine, but I think that is also a hindrance.
That is also a barrier.
Okay, next question. So this question, death is a reality and death comes to everyone, and I would like to say that most of us don't have any concept of good death, right? So Dr. Prarthana, can you explain us first what about good death? What is good death? That is, we used to say in palliative care.
Okay, so the good death definition, I cannot recollect right now, but what I can say is just to, for the least suffering for the patient is a good death.
And with the dignity.
With dignity, and it's not just for the patient, it's for the patient who is surrounding the patient also, even the doctors who are treating the patient and the family and providing care for the patient. All their suffering should be at the minimum, as much as we can provide, that is good death. So how to implement the concept, that now I feel it is we have two kinds of society. There are people who can provide good quality of death at home, and there are people who would prefer to die in the hospital also, because the conditions in their home are so bad.
Sir can enlighten us in this context, how we can implement this thing.
Yes, there are certain elements, like 11 elements are there, that patient, as far as physical aspect is concerned, patient should be pain-free, it should be symptom-free as far as possible, and on psychological issues, they should not feel totally overburdened that I am dying so soon and what my children will do and all that, and they are not settled, my house, this and that. So many responsibilities are there. Patient feel that I have a lot of unfinished work to be done. So they do not die in good death, right? Then also the social issues, they want their near and dearest by the side at the time of death. So if you are ensuring these things, that patient should relinquish everything, their roles and their responsibilities of the family, they should be, the relatives should be by the side, caregivers should be by the side, so they will be comforted. Even presence of the relative or friend or wife or son makes the death very comfortable, right? And so all these issues are there, and they should be able to die in their cultural belief, their spiritual belief, right? In whatever way they want to, in the village or wherever in the pilgrimage, or somebody wants to go into Kashi and somebody
that means the spiritual and the other aspects will be taken care as well during the end of life care.
Yes, so it should be pain-free, it should be amidst the family members, okay, without any social this thing, and spiritual also, they should be without any existential distress. They should die without any existential distress. So these are the features of physical, emotional, social, and spiritual. 4 concepts, 4 elements of good death are there. If you give these 4 elements, this is a good death. It is just like good living. Those who do not have good living, how they will die with a good death. So it is just like that only, right?
Okay. Next question. So this question to myself, not only myself, to sir, of the many pain and palliative care physicians among all over India. So being a most experienced and pain and palliative care physicians, what are your tips to the present generation physicians?
Certainly give importance to quality of life and assess pain. Try to tell the relatives what is the goal of the pain treatment. So measure the pain. Try to understand what is their objective and meet the expectations. Right? So all pain cannot be totally 100% free. So set a standard, set an objective that I can treat or I can give you 60% pain relief. Right? So try to set an objective and try to meet the expectations, make the drugs available, tell them that this drug has to be given by the clock, by the mouth, and by the letter, by the WHO guidelines. So all these young generations, they should give importance to the quality of life.
So one particular question by me. Still we follow the WHO ladder strictly, or shall we deviate?
No, I strictly follow. And if you are adhering to this guideline, simple guideline, 80% of the patient can be given good relief. With the individual details, whether the patient is having kidney dysfunction, liver dysfunction, that should be also included. Yes. What is the preference of the patient? What patient wants? Whether they want it, whether it is a tablet is applicable, that the patient will not. If the patient is vomiting and you are prescribing morphine, so it doesn't work, right? Then patches or routes should be different. So all these assessment is very important. So what type of pain is that? Patient may be having serious intestinal obstruction and colic pain, or patient may be incarcerated in the bed for many months. So there will be muscle spasm pain, or maybe bed sores, so bed sores pain, or maybe diabetic neuropathy, or maybe chest pain, body pain, pathological fracture pain. So try to understand.
Another thing in this regard, this was the last question, this is my last question, that young generation pain physicians, they already think about intervention, correct?
Right.
So there is a tendency for intervention, doing intervention in the first, and there are a lot of controversies regarding to sticking to the WHO ladder, or shall we deviate anywhere, do the intervention first and then come back to ladder, like that. And what do you think in cancer pain management? What do you think about?
In chronic pain, they are having such notions that you can give the intervention and all the pain will go away. If you block the pain generator, pain will go away. These things do not happen. In palliative care setting, in cancer setting, it is total pain which is important, like physical, emotional, social, spiritual, financial pain. So everything has to be understood in the patient concept, belief, that what is important to him. So it is very important. Morphine is not panacea. That if you prescribe morphine or you have morphine tablets, then every pain will go away. So only 70% pain can go away. Neuropathic pain doesn't work. It doesn't get relieved by morphine. Or a patient is having bone fracture, a patient is having bone metastasis. It won't go by morphine sometimes. So you have to use NSAID sometimes, you have to use steroids sometimes in intestinal obstruction, or the patient has severe headache due to brain metastasis. You have to give dexamethasone. So all pain will not go. Yeah. So those things should be understood.
Okay, that means that is the take-home message, that to alleviate pain in a cancer patient, we have to take the all 4 aspects of the pain and as well as in palliative care also, till the good death, if we can achieve it all. Okay.
Thank you, sir. Thank you.
I think even I agree with sir that interventions is not the first thing you should think of in cancer pain management. I think conservative management, if it's good, you rarely need interventions.
I was not talking about the first thing.
No, but with conservative management, and also you need good patient selection is a very big issue in cancer patients for interventions. So maybe in earlier stages it helps. By the time they come to palliative, interventions are very rarely possible in such patients. So I also agree with that in first conservative management, and then if you think it's like an adjuvant, it will help genuinely help a patient. Depending on the survival, prognostication is important, and then we think of interventions.
When you are giving intervention, some complication may occur. So at this time, no
it happens to
complication
us.
is expected.
Whenever we were doing intervention, it happens to us.
So in palliative care, patient is in last few months of life, and you can't add any complication. So per se, so.
Okay, thank you. Thank you very much. Thank you, sir, for coming such a long distance to you have been in Kolkata for many times and again. And thank you, Pratana.
So please do not leave the stage. I would request Dr. Mukherjee to kindly felicitate Dr. Jain, sir. Thank you, sir. Thank you for the wisdom. Dr. Pratna, could you receive your token of felicitation? I request Dr. Pradeep Mandal to kindly felicitate Dr. Arun Mukherjee. Thank you, sir. Thank you. Yeah, can we have a group photograph? Sir, please. Dr. Obiru. Dr. Obiru, please come. Dr. Pradhan. Thank you, sir. So next we have a session by Roche, and can we have Dr. Gunjesh Singh? Is he in the hall? So we move on to the next session by AstraZeneca. Can we have the speaker on stage? The topic is how I treat small cell lung cancer, these early stage with durvalumab. So we'll hold on the discussions as of now. The speakers aren't available.
presentation by Roche, I'll be discussing regarding atezolizumab in the management of extensive stage small cell lung cancer. The slides has been given by Roche only. So regarding small cancer, we all know that it's a fast growing tumor and most of our patient presents with distance metastasis in almost 70% of cases. The median age group of this malignancy is almost 65 years, and this disease is mostly seen in smokers population. And till now there was no targeted therapy was available regarding treatment of small cell lung cancer. Regarding outcome, it has a very poor or dismal prognosis. The 5-year OS is only 2%. Regarding staging of small cell lung cancer, it can be divided into limited stage and extensive stage. So it can be defined as when the disease is confined to the area tissue that can be treated with a single beam radiation therapy, it's called as limited stage disease. And when the disease is out of that radiation field, that we call it as extensive stage lung cancer. So mostly our small cell lung cancer patients present with extensive stage disease. Almost 2/3 of our patients present with extensive stage disease. And regarding incidence of small cell lung cancer in India, that again mostly almost 75% of patients present with extensive stage small cell lung cancer. Coming to treatment part, when the patient presents with limited stage small cell lung cancer, the treatment can be given with surgery followed by chemoradiation, or when the surgery is not possible, then chemoradiation is the treatment of choice. In case of extensive stage small cell lung cancer, palliative chemotherapy with platinum and etoposide is recommended for 4 to 6 cycles, followed by this prophylactic cranial irradiation if there is very good response in the primary site. So regarding past decades, we were treating this small cell lung cancer with platinum and etoposide. Initially, cisplatin etoposide was the treatment of choice. Later on, the comparison of cisplatin and carboplatin was done, and outcome was almost similar with a lesser toxicity. Then carboplatin and etoposide is now the current treatment of choice in advanced small cell lung cancer. In refractory or recurrent disease in second line, irinotecan, topotecan, taxane or gemcitabine can be used. In again second line, Nivo and EP combination can be given. Regarding treatment scenario in India, as I told that it's a very poor prognostic disease, and usually patients comes with distance metastasis, so we consider it as a systemic disease only, and we treat it with either concurrent chemoradiation, or in case of extensive stage, we treat with palliative chemotherapy with platinum and etoposide. So till now we can see that from 1986 to 2000 there was only improvement of 2.7% in 5-year overall survival data. So we can see that there is an unmet need of more efficacious treatment or drug in this entity. Regarding response rate and outcome, the response rate is quite very good. That patient usually respond with chemotherapy with a response rate of 70 to 80%. But when we see that most of the patient have progression or this relapse after median PFS of 6 months, and have a very dismal outcome of overall survival only 10 months, and 5-year OS is only 2%. Regarding treatment, carboplatin etoposide was approved by FDA in 1990s, and almost in 20 years there was no development in further treatment in this scenario. Almost 40 phase 3 trials failed to show any benefit with almost 60 agents such as VEGF inhibitors, mTOR inhibitors and other targeted therapies. So this now we have various chemotherapies or immunotherapy agents that have been tried, and almost 2 immunotherapy agents, one is atezolizumab, another one is durvalumab, has been shown benefit in improving overall survival. So this IM Power 133 have showed improvement in OS and PFS by addition of atezo with chemotherapy. So a rationale is that when we give chemotherapy, it releases cancer cells antigen, and the cancer cell antigen presentation is there, and this presentation leads to priming and activation of T cells trafficking of T cells into tumors, infiltration of T cells into tumors, and further these active T cells kills the tumor cells. So this is the basic of this mechanism of immunotherapy. So the data of atezolizumab came from this IM Power 113, and the patient which were taken in this trial were extensive stage small cell lung cancer, PS of 0 to 1, no prior systemic therapy, and treated asymptomatic brain metastases were eligible and taken. So patient was randomized to atezolizumab along with chemotherapy, that is carboplatin etoposide, versus placebo and carboplatin etoposide, followed by maintenance atezo versus placebo. So the chemotherapy was given, that was platinum, carboplatin etoposide for 4 cycles. And when we see the outcome, there was improvement in OS. The 12-month OS was improved from 38% to 51% in atezo arm. And also there was improvement in the median OS of 12.3 months versus 10.3 months. So there was 2 months overall survival benefit in case of extensive stage small cell lung cancer with atezolizumab. Again, the secondary endpoint was progression-free survival, and again the PFS was doubled. The 12-month PFS was 5.4% versus 12.6% in case of atezo. Regarding subgroup analysis, almost all subgroups benefited with atezolizumab, but the patients who had brain metastasis were not basically got benefited with atezolizumab, and they hypothesized that due to small sample size and no meaningful conclusion can be withdrawn with the patient with brain metastasis. Again, the atezolizumab showed benefit in all subgroups. Regarding safety summary, the incidence of grade 3 and grade 4 side effects were very similar in both arms, and almost 20% of patients with adverse events required treatment with steroid in case of atezolizumab. Regarding radiotherapy in IM Power 133, PCI was permitted, and consolidation radiotherapy was not permitted. So usually in clinical practice, we give PCI to those patients who initially respond to chemotherapy and have a good performance score. And in case of regarding consolidation radiation therapy to the primary site, we give when there is again very good response to primary chemotherapy. Regarding subsequent treatment, almost half of our patient, like 54% of patient in atezo arm and 60% of patient in the placebo chemotherapy arm received subsequent treatment, and treatment were either chemotherapy, anthracycline based, non-anthracycline based, immunotherapy and targeted therapy. So this is overview of chemoimmunotherapy studies. So we have only 2 positive studies. One is IM Power 133, which was the first study which showed benefit with adding immunotherapy along with chemotherapy. Another one is Caspian trial, and that showed benefit of durvalumab along with chemotherapy. So this is basically the frontline chemoimmunotherapy data and summary of efficacy. So the median PFS of IM Power was 5.2 and 5.1 with durvalumab, and median OS of IM Power was 12.3 months, and similarly 12.9 months was seen in durvalumab. And this is basically comparison between the IM Power 133 and Caspian trial. So they have mentioned that cross-trial comparison should not be interpreted with caution due to difference in each study, patient population and data maturity. So basically IM Power 33 was a double-blind trial. In general, blinded trial is regarded as best, and because they have a lesser subjective bias, they included treated and asymptomatic patients. And in Caspian trial, cisplatin and carboplatin were used, and already the meta-analysis showed that carboplatin is better tolerated in comparison to cisplatin. And in Caspian trial, chemotherapy was given for 4 to 6 cycles, so addition of 2 more cycles have not shown any benefit. So basically this was the comparison, and in NCCN also, it has been recommended for extensive stage disease, we can use atezo and durvalumab along with chemotherapy. We have 2 options in the front line. So summary of my this presentation is that atezo plus platinum and etoposide is the recommended treatment if affordable in first line extensive small cell lung cancer, but is shown to improve overall survival 12.3 months versus 10.3 months in atezo arm, and also there was improvement of 1 month in progression-free survival. The safety profile of atezo and the chemotherapy was similar to expectation, so there was no new finding. And this combination has been recommended by NCCN, ESMO, and other treatment guidelines in first line setting. So thank you so much.
Dr. Pradeep, please first. Gunjesh Singh, who is from Ranchi Medica. Thank you so much. Okay, so for the last two talks, I will request Dr. Pradeep Mandal to take over. And so this is for AstraZeneca. Dr. Pradeep Mandal.
Good evening. Thank you, Medica Cancer Conclave organizing committee for giving me this opportunity, and thank you, AstraZeneca team for arranging all the logistics and giving support to that Medica Oncology team. So today in back-to-back two topics, we'll discuss that role of that immunotherapy, basically that its role in immunotherapy in stage 3 lung cancer, non-small cell lung cancer, and in of course small cell lung cancer. So management of stage 3 NSCLC is the first topic. What is the that our experience in real life? So we'll discuss a few of the cases. As you all know that stage 3 is a kind of disease where that our expectation is high that probably patient is not metastatic, so that patients will cure, and back to back that there is a very high chance that stage 3 disease with that standard line of treatment patients progresses, patients have relapse, patients may develop metastasis. So it's very important, it's an unmet need that you will treat properly these stage 3 lung cancer patients so that that relapse can be prevented. So this is a case, is a 52-year-old gentleman is presented with an hedginess in the chest that has been investigated with a CT chest that had shown an posterior segment upper lobe and large mass with enlarged mediastinal sleeve nodes. So probably patient is having some malignant disease. PET CT has been done. It is showing that patient is having a left upper lobe lesion of 7.6 into 7.5 centimeter in a T4 disease because it is averting the costal and mediastinal flora, and patient is also having an N3 node. So it is a quite locally advanced disease, and patient is not upfront that operable. Patient has been diagnosed as adenocarcinoma lung on biopsy. So it's clinically T4 N3 disease and stage 3C. So as that in most of the stage 3 is a locally advanced disease, and most of the patients having an unresectable tumor. So is so most of the times is upfront surgery or even after neoadjuvant chemotherapy is very difficult to have a resection of all these tumors. So if you see that that overall survival of this according to the stage wise, you will see that in stage 3B or stage 3C that overall 5-year survival is quite pretty less. That's only 26% in stage 3B and in 13% in stage 3C. So basically that if you don't do that, this is the according to the standard treatment guidelines, that this is the overall 5-year survival in stage 3 non-small cell lung cancer. So staging, I will not go into details. So most of the times that is best to do in surgical proper surgical staging. in this stage 3 lung cancer. So invasive staging is of course better. If you see that the sensitivity and specificity of invasive staging, you will see that mediastinoscopy is almost approaching that 100% of specificity and almost 80% of sensitivity. And with EVAS TBNA, that sensitivity quite improved with up to 90% with the specificity of 100%. So of course that this sort of different surgical or even of course invasive staging you have to do for proper staging of these sort of patients. So that treatment paradigm, there is basically that oppose that since a long time, the last 20-30 years, there is not much of improvement in the treatment of stage 3 lung cancer. The standard practice is the concurrent chemoradiation. In last few years, that of course we have seen that that inclusion of chemotherapy in this stage 3 lung cancer that significantly improved that outcome of the patient. So this is the unmet needs that in stage 3 I have already told that most of the patients will have high chances of developing brain metastasis or other different loco-regional metastasis or recurrence in following stage 3 standard treatment. So it's very important that you do something better for these patients post concurrent chemo radiotherapy. So these patients received induction chemotherapy, that paclitaxel and carboplatin. Initially, patient had partial response to therapy, and of course that you will see that in different studies that induction chemotherapy has significant role. That it's almost that almost 26% of patients received this induction chemotherapy in this specific trial before that definitive chemoradiotherapy, because otherwise you have to include the large volume of lung, so that may give rise to that toxicity. So patient followed by induction chemotherapy, patient received concurrent chemoradiotherapy, and that concurrent chemoradiotherapy is of course better than that sequential chemoradiation, and where it is not feasible for do concurrent chemotherapy because of that poor performance status, poor general condition, then you can choose that sequential chemoradiation. So these are the different outcomes of consolidations in advanced non-small cell lung cancer. Different sort of consolidative methods they have used in different trials, and you will see that it has not much of help. So consolidation chemotherapy or radiotherapy post CGRT have demonstrated no benefit. So it's very important that we need some new treatment to improve this sort of treatment. So this is the specific study. It is a phase 3 randomized double-blind placebo-controlled multi-center study where that stage 3 locally advanced patients who have already received that chemo radiotherapy, they have included into two different arms, 2:1 randomization in durvalumab 10 mg per kg 2 weekly for up to 12 months, and another arm was placebo 10 mg per kg 2 weekly for 12 months. So primary endpoint was that co-primary endpoint of PFS and overall survival, and secondary endpoint was that overall response rate, duration of response, safety, tolerability, and patient-reported outcome. So basically, post chemoradiotherapy, they included immunotherapy, durvalumab, in these sort of patients to see that whether that outcome improves. So all the patients received 2 or more overlapping cycles of platinum-based chemotherapy. With RTN patients may have received prior chemotherapy in more than one context. So this is the updated 5-year overall survival. You will see that at 12 months, at 1 year, almost 83% patients in the durvalumab arm are progression-free versus 74% in that standard concurrent chemoradiotherapy in placebo arm. So almost 10% difference at 12 months, and if you go and continue to see that response in next 5 years, you will see that is a significant almost 10% difference. So at 2 years, 66 versus 55% patients are progression free. So almost 11% patients had less progression in that durvalumab arm. At 5 years, that almost 42% patients are progression free in the durvalumab arm versus 33% in the placebo. So that is a significant difference. If you see that the hazard ratio that is significant in that durvalumab arm. So basically that it is the first and only approved IO that have demonstrated almost 42.9% overall survival in 5 years. So in this locally advanced stage 3 non-small cell lung cancer, it is phenomenal probably that almost 42% patients are progression free at 5 years. That is a significant improvement. So if you see the different subgroups, you will see that benefits was seen in across all of the subgroup, whether it is squamous, non-squamous, whether patient is having PD-L1 high or low PD-L1, even in unknown PD-L1 subgroup patient had better survival with durvalumab. So this patient was planned for durvalumab. Patient was continuing on durvalumab, and that response PET-CT was shown that there was significant reductions in that FDG ability in that primary lung. So it was denoting a good therapeutic response. So basically that when to start the durvalumab, so that is that most of the studies they have shown that initiation of durvalumab treatment should be done at least within 42 days after the end of radiation. Those these are the different real world studies. I will skip this. So that in this real world study it was shown that almost 40% patients initiated durvalumab after 42 days of chemoradiotherapy, and the responses was similar that was observed in specific study despite of almost 40% patients had durvalumab even after 42. So if patients had some toxicity post CTRT, patients have delayed initiating this durvalumab, then we can have even after 42 days that patients may have good response. So basically that conclusion is that that traditional chemoradiotherapy that overall 5 year survival is only 15 to 25%, so we can significantly improve this survival to up to 42% after including this durvalumab post chemoradiotherapy. So that durvalumab in stage 3 lung cancer as a consolidation is an important armamentarium of treatment, and we should, if patient is affordable, we should include this treatment in this sort of. So if you see the different guidelines, even Indian expert consensus statement, NCCN guidelines and ESMO guidelines, all have included this durvalumab for at least 1 year post concurrent chemoradiotherapy. So concurrent chemoradiotherapy gives a better outcome than RTL1, of course that is the standard. But consolidation chemotherapy didn't improve survival outcome, so that was an unmet need to improve that survival of this sort of patients. So that durvalumab is the first and only immunotherapy that has demonstrated in 4 years overall survival and progression-free survival benefit. And durvalumab should be considered as a treatment options in all unresected stage 3 non-small cell lung cancer patients who didn't have progression post chemoradiotherapy. And durvalumab improves in that survival in all subgroups irrespective of that PD-L1 status or EGFR status. So durvalumab is the now standard of care for stage 3 unresectable lung cancer. Now I will discuss about that what is the role of Okay. So already Gunjas has told that how that deadly is that small cell lung cancer. You will see that less than 2% patients will be surviving for 5 years in small cell lung cancer extensive stage disease. So it's very important, it's an unmet needs of improving that survival of extensive stage small cell lung cancer. So this is a patient was diagnosed with extensive stage small cell lung cancer. I'm not going into details of their history. So basically patient had that extensive disease upfront that was not able to include in that single radiation field. That's why it was small extensive stage. Patient had brain metastasis also. Histology was small cell neuroendocrine carcinoma. PD-L1 was TPS of 3 to 4%. So this is extensive disease with the brain metastasis. So how to treat? Of course, if patient is symptomatic, then we have to give radiotherapy to the patient. If patient is not symptomatic, then we can directly go into the systemic therapy for the patient. So next option is that chemotherapy or chemotherapy plus immunotherapy. So these are the different trials we have shown that whether that radiotherapy to be given. I've already told if patient is not symptomatic, then in small cell lung cancer is a very chemosensitive disease. So we can directly go into that chemotherapy or chemo plus immunotherapy. So this is the NCCN guidelines. Recent NCCN guideline I have shown that in extensive stage small cell lung cancer, if patient is having brain metastasis, you can directly go into that systemic therapy if patient is not symptomatic. So if you see that different chemotherapy regimen in extensive stage small cell lung cancer, you will see that standard EP or CAB that have not significantly improved that overall survival. So overall survival in different studies is approximately that around in the range of 10 months. Patient initially have very good response, but is rapid relapse of the disease in small cell lung cancer, such a aggressive disease. So it was an unmet need to improve that overall survival for this small cell lung cancer extensive stage disease. So this patient of course received that standard chemotherapy regimens and of course that radiation. So that newer approaches which has come this to the treatments for small cell lung cancer is that along with that platinum doublet, etoposide platinum doublet, that either durvalumab or atezolizumab. Already Kunjas has told about this role of atezolizumab. I will tell you about that durvalumab. What is the role of durvalumab in this patient? So rationally already discussed by Dr. Kunjas. So what is the rationally is that so immunotherapy basically plays the role of eliciting an anti-cancer response by modulating that patient's own immune response to the tumor, and the patients who had a high mutational burdens that has been shown in small cell lung cancer that allows the tumor to be susceptible to that immunotherapy. And basically the timing of immunotherapy in relation to other therapies, in particular that chemotherapy is very critical to allow that proper disease control and development of an immune response. So this is the Caspian study. It is the first and only approved regimen in extensive stage small cell that allowed 6 cycles of EP in the control arm and to use the cisplatin, both cisplatin and carboplatin. So here in induction phase, Imfinji plus EP followed by that maintenance phase of Imfinji. Another arm was that EP, another was Imfinji plus EP, 4 cycles plus investigational agents, followed by Imfinji maintenance. Primary endpoint was that overall survival, secondary endpoint was that PFS, overall response rate, and health-related quality of life. So Caspian studies allowed for investigation choice of platinum, so either carboplatin or cisplatin, and patients with asymptomatic or treated brain metastasis was also allowed. The control arm allowed for up to 6 cycles of chemotherapy and PCI as per investigators' decision. So basically, if you see the difference between the Caspian and IMPAR 133, so that is that in IMPAR 133, the untreated brain metastasis was excluded, but in Caspian they have included all that whether patient is having biomarker selection or not, whether patient is having brain metastasis, whether patient has received PCI, and that cisplatin was also allowed in this Caspian study. So Caspian study inclusion criteria is reflective of real world clinical practice that allowed basically treatment with either cisplatin or carboplatin. It included patients with either asymptomatic or treated brain metastasis, and it's compared against up to the 6 cycles of chemotherapy with optional PCI. Yes, so in this study, the durvalumab is used 1500 milligram plus platinum etoposide 3 weekly for 4 cycles as initial treatment, followed by durvalumab 1500 milligram 4 weekly until progression as a maintenance. And choice of platinum was allowed, cisplatin and carboplatin both was allowed, and overall survival was that final primary endpoint. And control arm could receive up to 6 cycles of platinum etoposide, that is in line with the real world clinical practice. And optional PCI was offered only to the control arm in maintenance phase and not during the durvalumab maintenance. And asymptomatic as well as treated and stable brain metastasis patient was also included. So if you see that that durvalumab plus EP, and that almost 45% patient had progression free in that at 6 months, 17% patients are progression free at 12 months, 18% almost 13% patients are progression free at 18 months, and almost 11% patients are progression free at 24 months. When compared to that EP at 24 months, only 3% patients are progression free. So almost 8 to 9% difference in that median progression free survival of the in this study. So if you see that hazard ratio, that is 0.8, so almost 20% improvement in that event in the durvalumab plus EP arm when compared to that comparator arm. So majority of the patients who are progression free at 1 year remain progression free at 2 years. That is a very significant observation in this study. So if you see that 3-year overall survival rate, so it is almost 3 times more patients are alive in the durvalumab plus EP versus EP arm at 3 years. If you see the different subgroup analysis, so you will see that in each and every subgroups that basically durvalumab is favoring that over EP alone. So basically, whether patient is elderly, whether patient has received carboplatin or cisplatin, whether patient is active smoker, or whether patient is having brain metastasis or not, in all subgroups basically durvalumab plus EP was favored. If you see that overall response rate and that almost more than that durvalumab and almost 70% patient 70% response rate in the durvalumab plus EP versus 58% in that comparator EP arm. So overall survival and PFS benefit in first line durvalumab plus EP are maintained irrespective of that presence of brain metastasis, and it was further supporting that standard of care. So in brain metastasis patients that has a ratio of 0.79, and even, without brain metastasis is 0.76, is almost comparable between the two. So our patients receive radiotherapy and chemotherapy 3 cycles, immunotherapy 3 cycles, and follow-up PET-CT had shown very good response and significant decrease in that FDG ability of the patients. So basically, Imfinji is the only IO with clinical trial data supporting an 4-weekly maintenance dose administration schedule for the extensive stage small cell lung cancer. So first induction followed by 4-weekly maintenance. So Caspian demonstrated that Imfinji can be administered 3 weekly with EP and 4 weekly as a maintenance treatment. So Imfinji and EP is also cost effective versus EP alone, and it has significantly when compared to that Atijo plus EP, as well as it's improved that quality of life. So to conclude, that durvalumab plus EP is the new standard of care in the first line extensive stage small cell lung cancer, and durvalumab is the only IO that provides a flexibility in choosing between cisplatin and carboplatin along with etoposide, and it has benefit plus EP that was observed in across all the subgroups, and it includes that brain metastasis subgroup patient also. More than 17% patients on the durva plus EP are surviving even after 3 years, and that is a significant improvement in the survival in this deadly disease. Imfinji plus EP provided a very high response rate, and it's demonstrated an ongoing response at 2 years, and almost 3 times more patients than the EPR. Durvalumab offers a convenient once monthly dosing regimen as a maintenance phase, and safety findings remain consistent with the known safety profile of other immunotherapy and comparator other immunotherapeutic drugs. Thank you. Thank you AstraZeneca team and Ross teams for giving support to that Medica Cancer Conclave, and thank you specifically Anupam and that Dipankar giving this so much of effort to make it a successful program. Thank you.
Thank you, sir. It's our pleasure.
Before we finish, I would like to just show a couple of applications.
In this sponsored session by Roche, I'll be discussing regarding atezolizumab in the management of extensive stage small cell lung cancer. The slides has been given by Roche only.
राजदीप दा इससे complete.